sponsoring company Solco for this session. And this is on osteoporotic fractures, the instrumentation part, and what actually is useful in instrumenting osteoporotic spines. As we all know, that usually a problem in these instrumentations where with osteoporotic spines you are worried whether the screw will back out, etc. And what to. So how do you deal with this? What do you do to overcome this? For that, I want to invite the moderator of our session, Dr. Devesh Dholakia. Dr. Dholakia is a friend and a very good spine surgeon, very good colleague, very good person to have in Bombay. I thank you for moderating this session, and over to you, sir.
Welcome, friends, to the second session of the week, the second week of the excellent conference which we are having. We are starting the day with one of the commonest problem in our aging population, that is osteoporosis. I thank you, Solco, again for sponsoring this session. I'm Dr. Devesh Dholakia, and I'm going to moderate this session for you. We are lucky to have an excellent group of panelists for the session. The broad outline of the session is, first we are going to have a talk on evaluation of a vertebral compression fracture, followed by vertebroplasty, kyphoplasty, and how to improve a fixation in an osteoporotic spine. And if the time permits, we may have a few case discussions. Without wasting time, let me call Dr. Agnivesh Tikku. Dr. Agnivesh Tikku is a young dynamic spine surgeon from Mumbai City, practicing at Apollo Hospital, and he's going to talk on evaluation of a patient of a vertebral compression fracture. Yes, Agnivesh, you can.
I think it's a pre-recorded talk.
Yeah, we can play the video now. Dr. Agnivesh.
Hello, everyone. Today, I will be speaking about the basics of osteoporosis. So we know osteoporosis is a multi-systemic skeletal disease which weakens the bone and causes fragility fractures. WHO has defined osteoporosis as a T-score of less than or equal to minus 2.5 on a bone density measured by DEXA scan. So this is the way we quantify it. The DEXA is the gold standard, and this is what we should follow for the diagnosis. Just a bit of theory that for bone, you have bone cells and bone matrix. If your bone mineral is lost, that is osteomalacia. But if everything is lost, that's what is osteoporosis. So women are at increased risk of osteoporosis. We all know that. But it's not only about the females. The males are also at increased risk of osteoporosis, and we should consider osteoporosis in males, especially above 70 years. The consequences we know can be acute and chronic pain, increased use of analgesics, there is deformity, there is loss of quality of life, there may be a neurological deficit associated with a fracture, and this can severely impede their life and can result in increased mortality. Osteoporosis care gap is something which we all should know about, is that since we don't know the disease well, or we do not keep ourselves aware about the disease, there is a gap which remains and we do not treat it, and that leads to many problems. And that is why osteoporosis is a bone-shattering thunderstorm. It's not just a simple disease. To interpret DEXA is very simple. You have two scores, T-score and Z-scores. The T-score compare with a young adult and Z with an age-matched same-sex adult. And important point is, if any of your Z-score is less than -2, you should rule out secondary osteoporosis. Bone density scan, again, you have central measurements, which are spine and femur, and you have peripheral measurements, which are forearm. The Z-scores are more appropriate for patients less than 50 years, and T-scores, we should not rely on Z-scores above 50 years. So let's have a look at this DEXA scan with severe degenerative changes in spine and one hip replaced already because of fragility fractures, and we may conclude that the patient is not osteoporotic. But unless you look at the wrists, the other hip, where the T-scores are -4.2, -3, that is when you realize that not a single value needs to be considered. The patient's, all the values you need to consider. There is something called as a qualitative CT. It's better than DEXA. It's not available everywhere, but yes, you can measure the volumetric bone and stress strain index. Fracture risk assessment tool is a tool which is devised by WHO to quantify the fracture risk, and based on that, you recommend treatment. It includes DEXA and other factors also, which again strengthens the fact that DEXA is not everything. So the basic investigations which we should rely on are the vitamin D, the calcium test. We should also do a PTH, creatinine, alkaline phosphatase, phosphorus. And in females, I especially recommend TSH or the thyroid test, because a lot of them are hypothyroid, and that is also a cause for osteoporosis. Whenever you take the calcium sample, ask them not to apply a tourniquet and use albumin correction for any unionized calcium which you are measuring in blood. Advanced lab investigations, they are the bone formation and resorption markers. The clinically relevant one are the P1NP. In resorption, we have CTX and beta cross labs. So non-pharmacological treatment of osteoporosis includes to identify early and sort of do regular exercises, brisk walking, take adequate calcium, vitamin D, and keep yourself healthy. The medical management comes when you have osteoporosis, and you may have primary or you may have secondary osteoporosis. The primary osteoporosis can be type 1, postmenopausal or senile, and secondary be due to many other reasons or diseases. Now let's look at two scenarios where the bone formation is good, bone loss is good. And in this scenario, you just need to plug the leak and you will fill up the tank. You will fill up the bone. In other scenario where the loss is also less and the formation is also less, as happens in senile patients, you just by plugging the tank, you will not get the desired outcome. So you need something which can fill it. So you have an anabolic agent over here which works better and fills up the tank. And once it's filled up, you want to plug it by an anti-catabolic agent like bisphosphonate or denosumab to plug it. So the pharmacological treatment based on these scenarios can be anti-resorptive or anabolic. We know anti-resorptives include calcium and vitamin D, hormonal replacement therapy, calcitonin, bisphosphonates, and denosumab. Now, you should ensure that you take adequate calcium, especially natural sources are the best. Injectable vitamin D is not better. It leads to more toxicity. And if you choose to give it, do not give more than one injection. That is good to last for 6 months. Calcitonin is reserved only for hypercalcemia because of multiple metastasis or recumbency, and is not recommended as an anti-osteoporotic treatment. Bisphosphonate, before we start bisphosphonate, we should have a normal kidney function, and you cannot give oral bisphosphonates with creatinine clearance less than 35 ml and injectable less than the alendronate and zoledronate less than 35 ml, and the risedronate and ibandronate less than 30 ml. So you may have to ensure that vitamin D is normal, and the oral absorption of these is very less. So you need to take them empty stomach early in the morning and not have food for around 45 minutes after taking the tablet. And don't sit as well because they are slightly irritant. Now, the recommended use of these agents in prevention of osteoporosis, you can see that alendronate is not recommended for prevention of glucocorticoid-induced osteoporosis, and ibandronate is not recommended as treatment in men. So this is what 2 points we should consider, and also not for glucocorticoid-induced osteoporosis prevention. You see, every drug which is there works well on spine, but it's only the zoledronate which acts on hip and wrist as well. So if you have severe osteoporosis of hip and wrist, then giving oral alendronate is not the best option. You should choose zoledronate. Denosumab is a monoclonal antibody against the rank ligand. It is approved for 10 years. It's renal friendly, but has got increased hypocalcemic risk. It's cleared by reticuloendothelial system. There are certain risks for skin infections or skin events, and most likely we plan a switch therapy at the end of 5 years before we suddenly discontinue. So you should not suddenly discontinue the denosumab if it's going on. You have to give a crossover to a bisphosphonate before you stop it. Especially this applies when the renal function is normal. Anabolic agents, the most important one is the teriparatide, which is used in the clinical scenarios. It's recommended up to 2 years to be used once during lifetime. 20 microgram daily is as self-administered subcutaneous injection. There were concerns of malignancy in certain animal models, but again, it's not proven. But in any patient of malignancy, we should not use teriparatide. You can check P1NP before and after 3 months of starting teriparatide. It gives you an early indication how well the injection is working. And check serum calcium on therapy. Give a gap of 8 hours between taking teriparatide and checking calcium, because there is a slight hypercalcemia which happens immediately after the injection. We just want to see the resting or the trough values of the calcium here. Teriparatide is recommended in postmenopausal osteoporosis, in senile osteoporosis, and glucocorticoid-induced osteoporosis. And above that, there is a combination therapy as well. And you can combine teriparatide and denosumab together and then follow it up with the anti-resorptive. And this has been shown to give the best result. The take-home message is that prevention is better than cure. Identify the target population early. Identify the people at risk. There's custom-made therapy for each individual you need to decide. And the most important is ensure compliance. Thank you very much.
Thank you, Agnivesh, for the excellent talk. Any questions for Dr. Agnivesh? Let me put up some few questions, Agnivesh. How often do you recommend to do DEXA scan?
So
once you start treatment for osteoporosis.
Yeah, so if I'm screening a patient, then if it's in the post-menopausal age group and the values are borderline, then I would recommend to repeat it at 2 years. And if there are any risk factors associated like severe diabetes or some other rheumatoid arthritis or something, then I would recommend probably to do it at 1 year also. But 2 year gap is the usual what is recommended for the evaluation of osteoporosis.
And do you use bone markers regularly for your evaluation, or you only for selected cases?
No, I use them for very selected cases. For teriparatide, I may want to see the effect by doing the P1NP, but very rarely, if I'm stuck for a decision as to which anti-osteoporotic would be best for a patient, I may choose the catabolic markers like beta cross-labs or serum CTX. But it's very rare, like it's in 1 in 60 very or 70 patients.
I know it's very difficult to get those markers also and quite expensive. You talked about treatment for osteoporosis, Agnivesh. But if a patient of acute fracture comes, can you give us an outline of the management which you follow? So, besides evaluating that his osteoporosis is a senile osteoporosis and nothing else, you already evaluated them. But how will you go in an acute fracture?
Yeah, so in such scenarios, the drug of choice for me is teriparatide, because it also improves the fracture healing. We have evaluated everything. If the patient is deficient in vitamin D and I am not able to start teriparatide, then I would sort of hold on. If the values are below 20 nanogram per ml, I will not immediately start anti-osteoporotics or denosumab, because you need to have a normal vitamin D before you start anti-resorptives. So in those scenarios, I may wait for 4 to 6 weeks and then start them.
How soon you mobilize them? You ask them for bed rest, or you repeat x-rays, or how do you go about it?
So for the medical management part of it, I usually keep them on rest for first 1 week for 7 days. Thereafter, their pain start getting better. Once they are able to turn side slightly comfortable, then we attempt edge of the bed sitting. And the aim is to get them sort of mobilized from a bed to chair situation as early as possible. So it may be just for sort of using the commode once a day or urine twice a day, but we want to mobilize them sooner. So a week or 2 weeks is when I would look at starting mobilization.
Absolutely. I think by 3 weeks, most of them are quite mobile along with pain.
Yes, at least they can
probably use of a brace to decrease the pain. And
Yes.
probably, yeah. Do you repeat X-rays very often after the first episode, or you like to see what's happening?
I would do X-rays at 3 weeks, 6 weeks, and then 12 weeks. This is my protocol.
I think that's good enough protocol to work on, just to catch them early if some things are going wrong.
Yes, yes.
Yeah. Any more questions for Agnivesh? Otherwise, we can go to our next speaker. Yeah, let me introduce Dr. Niraj, the next speaker with us. He's a close friend, a spine surgeon trained at Twin City Spine Center, USA, and he's going to talk about vertebroplasty. Yes, Niraj, you can share your screen.
Yeah, can you see it?
Yeah, we are there.
Yeah, thanks, Devesh, for the introduction. So I'm just going to start off with a case which was something that piqued my interest. This is way back in 2006 when, QML wasn't very well discussed in most of our forums. And this guy came from Zambia with a prostate issue, and when positioning on the table for doing his TURP, he's got severe back pain and he was not able to stand, got severe pain radiating to the legs. The X-ray at that time showed this benign-looking L2 fracture. The MRI also didn't show much. There was a slight inferior end plate fracture of the L2 and slight canal compromise. And then we thought of doing these standing X-rays then. I mean, now it's become routine that we do them, but in those days it wasn't that common. And he showed a severe collapse of the L2. And then we went on to do an open vertebroplasty with stabilization. And as you all know, I do knee replacements also. He went on to then get his knee replaced with me. There was another quick case about a dermatologist who's also had a knee replacements done by me. She had a fall in the bathroom and she got this benign looking fracture at D12. Got the MRIs done and it looked very well like a decent case there wasn't much of a cleft seen. Looked like a good case for vertebroplasty, not responding to conservative management. Being a doctor, she wanted to get back to work. So we did the standard vertebroplasty. There was a little bit of a backtracking of cement, as you can see there. But other than that, it looked well done. But she got absolutely no pain relief. So we got the X-rays done in sitting and supine views, which showed that there was what we know as intervertebral instability now. And then we counseled her and then went ahead and did a additional short segment fixation. So this post-intervertebral instability is one of the issues that we have to deal with. So vertebroplasty is, what I'm trying to say, is not the end-all solution for a lot of things. They're very selective cases that we should do vertebroplasty in and expect certain results. So there's some cases like this also where you can see the cement migration even after doing a vertebroplasty. This is like a pincer phenomenon, which probably needs something in addition. So percutaneous vertebroplasty is indicated for the treatment of vertebral fractures which are refractory to medical and conservative treatment. So the essential indications are those that are not responding to your medical treatment that Agnivesh spoke about for 3 to 6 weeks, or patients demanding an active lifestyle. I've had people coming in earlier saying that they want to get better vertebroplasty. They're well informed. If that can help me, I want to do it fast. Metastatic fractures, particularly the osteolytic ones, hemangiomas. So these are the typical fractures that you can see that look pretty much benign, not responding to conservative conservative management. The ideal indication for vertebroplasty is a standalone vertebroplasty is a stable, non-compressile fracture without neurological deficit, without Kummer's disease. The presence of Kummer's disease or phenomenon usually indicates an instability and the need for probably additional surgery. Sugita, based on his X-ray classification, had these 6 groups with type 1 being normal. The topmost, that the concave and the dented type, usually have good prognosis with vertebroplasty. The lower 3, which is the swollen, the projectile, and the bow-shaped ones, tend to have a poor prognosis. Even the German Society for Orthopaedics and Trauma came up with this classification for osteoporotic fractures, depending on the extent of the injury, wherein the OF, osteoporotic fracture 1, 2, and probably 3 could respond to standalone vertebroplasty. The type 4 with the vertebra plana, the pincer type, and the instability usually do require some instrumentation along with it. So contraindications for vertebral augmentation are obviously healed fractures, asymptomatic stable fractures. Because if this patient has pain, you have to rule out other causes of pain. It could not be a vertebroplasty patient. Allergy to PMMA could be a relative contraindication. Patients on anticoagulation therapy, where there's obvious infection and epidural abscess. If a patient has a neurological deficit at the same level of the fracture, that becomes another contraindication for vertebral augmentation. Patients with neurological deficit can be treated with vertebroplasty, but this may require a sort of a mini hemilamiectomy with a controlled vertebroplasty along with adjacent screw level fixation, screws at the adjacent levels. The relative contraindications are a significant compromise of the spinal canal, back pain for more than 1 year, in which again, in case we need to rule out other causes of back pain, vertebra plana, when there's tumor extension to the epidural space. Another contraindication is the inability to lie, relative contraindication is the inability to lie down prone. So if you look at the natural course of the disease, most of the patients, or 70% will stabilize by themselves without any complications, and they will return to a normal function. There are only 30% which patients which ultimately may result in collapse, resulting in then instability, pain, deformity, and also neurological compromise. So essentially, when you look at these patients, there are 4 groups. The ones which are pain, which are not able to follow conservative treatment, or they fail conservative treatment. There are patients who have pain without instability, but with a small cleft formation. Then there are patients which have neurodeficit with instability and cumulus. And there are patients who have neurodeficit with instability and without the cumulus. A brief word about cumulus. It was described by this German physician Hermann Kümmel in 1891. Basically, it's the AV and pseudarthrosis or non-union of the vertebral body. Usually, it happens in osteoporotic compression fractures. The usual causes of AVN like alcohol, steroids, smoking, radiation predispose them to having this fluid phenomenon. It usually happens at the dorsal-lumbar junction, and it's associated with the intravertebral cleft that you see on the scans or on the X-rays. And they're very characteristic appearance on the MRI, maybe fluid or gas. So these pictures on the left, the one showing with the classical cumulus phenomenon, and this other picture on the right, the one on the left is a stir-weighted image, and the one on the right is a T2-weighted image, showing the intervertebral cleft adjacent to the fracture. So the typical history is that the patients are usually doing well with conservative management, and then instead of getting better, they start deteriorating. They're comfortable sleeping, but they have a lot of pain getting up from the supine position or sitting up in bed. And they can usually be diagnosed by the supine lateral and sitting X-rays, which show a change in the angle of kyphosis. CT scans could be useful in certain cases, though we generally tend to do MRIs to detect where the defect is, whether it's anteriorly, posteriorly, or towards the end plate. So this is like a typical anterior opening defect that you see. So post-vertebroplasty for cumulus, there's a higher incidence of free fractures noted. Hence, in 2 years, hence the medical treatment that Agnivesh spoke about is of paramount importance. It's just not your process. It's the medical management, since osteoporosis is a medical disease. The inferior cumulus that have the gas or the fluid formation towards the inferior end plates have a higher tendency to refracture. And the incidence of cement leakage is actually unknown. So only if you have these anterior opening ones, you have to be careful. So the technique, this can be done, vertebroplasty can be done in the OT under sedation or in the CT scan area. I usually do it in the OT. The patient should be cooperative if you're going to do it under sedation, and they should be able to lie down, maintaining their prone position for the duration of the procedure and able to maintain the oxygenation. Under GA, it can always be done because you're rest assured that the patient will not move when you have the stability. It's actually very comforting to do it under GA, but you have to be careful because you can't watch the patient's neurology. You have to be careful about the cement leaking posteriorly or about cement embolization. You keep the patient as straight as possible and probably even extend his back if it's possible to help open up the vertebra. I usually tend to use 2 C-arms if I can, if it's available, because it's safer, time-saving, and gives more consistent results. You also need a good C-arm technician. A lot of OTs have good C-arms but poor technicians, and this can really ruin your day if you have somebody who can't show you good images. Tend to use proper cement. I generally don't use our cement that we use for knee replacement, but that tends to become harder when it's mobilized. You need to add a little bit of radio-opaque material like barium sulfate. These ready-made vertebroplasty cements are usually better, and when they harden, they don't become completely hard. That probably helps adjacent level fractures, and that's probably one of the most, according to me, the area that we're deficient is in finding the ideal cement, which will be of low viscosity, allow flow, and ultimately get incorporated and not stand out like a foreign body in the vertebra. You can use either a single portal or a biportal, and you can do one level or multi-level fixations. I usually do a uniportal fixation, vertebroplasty. So these are just some images of the C-arms, how you position them, one from the top in the C, and the other one can come either from the top or from the bottom, depending where you are. Usually you need to stand on a stool because the table height has to be raised, and you put your screens on one side so you can see both the screens. So I don't use any fancy cement injection device. I know you get these ones which control, which you can turn and inject slowly. I generally mix the cement in a bowl, empty it out into a 20 cc syringe and then put it in either 1 cc or 2 cc syringes. I prefer a lower lock syringe which can lock into the cook needle, which allows no air leak and allows a more controlled injection. You can put the monomer on ice if you need more time, but usually if you're doing a single level, there's more than adequate time. Don't use a hammer while selecting my entry point. I generally use my hand. I just enter with force. Don't use a hammer unless the needle tends to slip off the pedicle, in which case I may use just a mallet at the entry point. You enter in a controlled manner like you do with your pedicle screws, and avoid multiple passes because these passes can then form trails along which the cement can then leak. I use a shorter Jamshidi or cook needle because you need space on the top. Your C-arm hanging on your, giving you enough space. We use a longer cook needle. You generally don't get enough space to put your hand in to inject. You inject slowly. If you're injecting and using only one C-arm, use the lateral film to watch for cement leakage. Often you get these air locks, which is air getting trapped in the canal. So you have to keep using these stillets to clear it out. Make sure that the cement is filled in the syringe adequately and there's no air trapped in the syringe. And when you're injecting, you have these marks on the cook needle, which you can use to monitor that you're not pushing the needle deeper inside when you're injecting. So keep one hand below to stabilize the needle, and with the other hand, you can inject. After they finish injecting the cement, don't be in a hurry to remove the needle. Rotate the needle in the body to prevent it from adhering to the cement. And after it's about 11 to 13 minutes, when it's not running, you can remove the needle. How much cement do you need to inject? Usually in the dorsal spine, about 2 to 3 ml is adequate. And the lumbar spine, you can go from 4 to 5. The volume injected does not dictate the pain relief. This is one condition where you don't need to get greedy. You've seen people getting neurological deficits when they inject too much cement. However, there's some data that suggests that patients with clefts, inadequate filling may result in what is the post-vertebroplasty instability because there's not adequate fill. So you also use Omnipack. I tend to use dilute Omnipack because I don't want that Omnipack to remain inside and get the cement dye and the contrast getting confused with each other. If there is a cement of epidural leak of the Omnipack, it's not a contraindication, but just you have to be careful that you go in a little bit late and be careful to watch for the patient's saturation. Tell the anesthetist to watch for that. In a patient without a cleft, you need to go a little early because the bone tends to be a little bit harder. But patients who are having the intervertebral cleft or the cumulus, they fill up easy, so you can go a little bit late. So this is like a picture of the complications that can occur: the epidural cement leaking anteriorly and the cement leaking posteriorly. Plan your projection depending on where you're targeting it. If your phenomenon is more inferiorly or your defect is more inferiorly.
Can you sum up fast? We are running a little late.
Yeah. These are quick pictures showing where your needle should be positioned. I think most of us know it, that when you're starting on the left side, it should be in the 10 o'clock position, on the right from the 2 o'clock position. And the location of the needle should be in the pedicle till the time it reaches the posterior wall of the pedicle of the vertebral body. If you cross that, then your trajectory is wrong. So these are the markers showing where your needle should be. And when you're finally in the vertebral body, it should be about 2/3 along the way and it should not cross the midline. Also, when you're putting the patient on the C-arm should be positioned at the spinous process should be right in the center. Both the pedicles should be clearly visible and they should be towards the superior end plate. So this has to be said before you start your procedure. Just a quick example of a vertebroplasty patient with not significant collapse. And so the take-home message is the indication for isolated vertebroplasty is limited to certain fractures only. These fractures also have a chance of getting better when treated conservatively. Intervertebral clefts or the tumors indicate potential instability and may need a short segment stabilization in addition. Medical management, though, remains of utmost importance. And this may never be the end. So you always have the patient has to be communicated with that osteoporosis is an ongoing disease and there could be associated complication, either adjacent ligament fractures or associated kyphosis. The idea is to get the vertebroplasty in a way like this so the patient can be happy. Thank you.
Thank you, Nirad. I think we are running late. No questions, Nirad. Excellent technical. I think nobody requires to ask any questions. Very excellent technical tips which he has given. Let's go to the third talk given by me. Satyan, can we run the video?
Run the video, please.
Good day, friends. I am to talk about single balloon kyphoplasty. Kyphoplasty is a minimally invasive technique for the vertebral augmentation of compression fracture. It is more advanced as compared to vertebroplasty with the following advantages: less chances of cement leakage and the ability to correct some amount of deformity. The main indications being compression fracture, which has a failure of conservative treatment, or it is very painful. In cases of instrumentation associated adjacent segmental vertebral fracture, or in cases of compression fracture associated with plasmacytoma, painful hemangiomas, or osteolytic metastasis. The absolute contraindications being coagulation disorder, infection at the entry site, burst fractures which involve the posterior wall or involve the spinal canal, vertebral plana not opening up on prone lateral view. The relative contraindications being severely collapsed vertebra, fractured pedicles, tumor invasion into the spinal canal, or more than 3 levels of involvement. The instrument kit, which consists of Gumsheeli needle with a stillet, the guide wire, working channel, reamer, balloon, pressure sensors, and the cement injector. This is how a double balloon kyphoplasty looks like. It's transpedicular. To overcome the shortcomings of a conventional two-balloon kyphoplasty, which mainly involves the cost and the time, single balloon kyphoplasty is being used. It was found to be equally efficient as double balloon kyphoplasty biomechanically. The plan is to insert a balloon catheter in the center of the vertebral body with the extrapedicular approach. However, the problem is it is not a well standardized procedure. The trajectory from the skin entry, which is the point A here, to the center of the vertebral body appears variable according to the level involved and its radiological anatomy. Let's take this case. 4 weeks after a vertebral compression fracture, repeated X-ray shows there's increase in the compression fracture D12 with minimal opening on flexion and extension view. Hence, it was advised to undergo kyphoplasty. Single balloon kyphoplasty was planned. I do it under general anesthesia. Patient is placed prone on a horizontal bolster. The lordotic position aid in the ligamento-taxic reconstruction of the vertebra. See how it has opened up. Whenever you do this procedure, see that you have an access to a good CM and an expert CM technician. CM and the patient is adjusted, so that is squaring of the vertebra. What do you mean by squaring? That is in the AP view, the spinous process is in the center. The pedicles are in the upper 1/3 of the body, and there is the entrails are parallel. And in the lateral view, again, the entrails should be parallel, and there is superimposition of the pedicles. This is a very important slide. The surface marking on the patient. So you draw the line C, which is a line along the lateral border of the affected vertebra on the opposite side. Line B, which is on the lateral border of the pedicle on the ipsilateral side of the affected vertebra. And the line A, which is 2.5 times the distance between B and C. Why this 2.5 times? This study, Korean study, shows that at each of the level, the rough estimate is around 2.5 times the distance. So the line A is drawn parallel to line B. Point C is on the inferior border of the affected vertebra. Point B is in the upper border of the affected vertebra on the ipsilateral side. When you extend the line from C to B, and where it joins the line A is the entry point. So make a stab wound at the point A. The junction needle is angled at 45 to 50 degrees. It is advanced to the point B, which is the outer border of the base of the ipsilateral pedicle. on the lateral view and in the AP view. This needle will pass through the ligamentous complex of the costovertebral joint in the thoracic spine or the transverse process in the lumbar spine. After penetrating the cortex of the vertebral body, minor adjustments of the tip is made so that in the AP view, the tip points to the lower and inferior border of the vertebra which is affected, and in the lateral view, points to the anterior inferior aspect of the affected vertebra. Before we advance the needle, see that the tip of the needle in the AP view is in the ring of the pedicle before it passes through the posterior cortex of the vertebra. This is to ensure that you do not damage the spinal canal. Once the tip of the needle passes the posterior wall, the slit is removed. The guide wire is placed in the center of the vertebral body, the AP and the lateral view. The junction needle is removed. Over this needle, the working channel is passed, which just penetrates the posterior cortex. Through the working channel, the reamer is passed so as to smoothen the edges of the bone, so as to prevent bursting of the balloon, the kyphoplastic balloon. Remove the reamer and pass the kyphoplastic balloon. The kyphoplastic balloon is expanded with an omni-packed solution. How much to expand? Till you restore the vertebral height, or you have reached the maximum volume which the balloon can take, or the maximum pressure has been achieved, or you are flush against the cortical bone. See that you do not damage the posterior wall or the end plates. You require about 150 psi in acute fracture and around 300 psi in old chronic fractures. Once the balloon is inflated and in good position, start mixing the cement. Once the cement is about 3 to 5 minutes, that is, it is becoming toothpaste-like, remove the balloon, and this leaves a void. And in this void, you fill up the cement with the cement injector. You fill up till you reach the posterior 1/3 of the body, but do not remove the injector or the working cannula because there can be leakage to that side. Leave it for 15 to 20 minutes till cement hardens. Go on rotating the vertebral injector and the cannula so that do not set into the vertebral cement. Once the cement is set by 15 to 20 minutes, you can remove the working channel, and this is how the picture will look like. We added percute screws because there was problem of the posterior tension band on the MRI. This was how the pre-op looked, and this is how the post-op. See the restoration of the height. The complications related to this technique are malposition of the cannula can lead to the vessel nerve damage. There can be end plate fractures or lateral wove fractures during inflation of the balloon. There may be recollapse after the balloon has been deflated, or if you're not careful, there may be local cement leakages in the cortical bone, epidural, or anterior venous system. The non-technical problems being transient hyperalgesia is known to occur because of exothermic reaction of the cement. If the monomer leaks, there may be cardiorespiratory effects. There can be chances of infection, or there can be adjacent level fractures. Thank you. Let me take any more questions if you have.
We are running late. Any questions? We can take a question, or we can go to the next talk.
Devesh, I'll ask a question.
Yeah.
Yes, so is it still your go-to procedure?
I also started doing recently single level. I've not done many cases. I've done 3 or 4, but I found that it does cut down the cost quite a bit because all kits can give us only one balloon. And I was trying to see how we can, when I came across this paper, I found that I've done 3 or 4 cases. I've not done many, but I think it's a good way. The 3 cases have gone off well. And it's a good way, especially the thoracic spine, where you can get right into the center, where you cannot angulate a transpedicular needle in the center. So it's working well till now. Hopefully, let's see what happens for the next few years.
Okay.
Let me introduce my next speaker. He's a dear colleague from Global Hospital, an excellent spine surgeon, Dr. Uday Pawar. He's going to give us the next talk on fixing an osteoporotic spine. Yes, Uday Pawar, please join in.
Good afternoon. Today we are going to discuss the surgical options or surgical principles in the osteoporotic spine. Now, the osteoporotic spine can present to you with just an instability, a neurodeficit, or a significantly associated kyphosis along with it. In 2013, we did a study and published in the European Spine Journal discussing the surgical options in osteoporotic fractures in cases without neurodeficit and in cases with a significant neurodeficit. And as you can see, the options range from a plain simple vertebroplasty or a kyphoplasty to a moderately challenging procedure of a minimally invasive fixation addition to it, to a significant column reconstruction surgeries which involved an osteotomy to a mesh reconstruction of the anterior column or from a posterior surgery. So I'm going to take you through all the options that we can do surgically and the principles associated with and the issues that we faced along the line. So principally, you need to reconstruct the anterior column and augment it with fixation devices wherever possible. The anterior reconstruction might range from just a vertebroplasty or a kyphoplasty to either a column shortening osteotomy or a mesh reconstruction, as well as discussed. Now, options wise, you have pedicle screws, significantly available options where you can have these dual threaded screws which improve the pull-out strength of the screw. You have these fenestrated screw, these fenestrations inside the pedicle screw, a cannulated screw where you can push in cement, thereby increasing the pull-out strength. You have this expandable pedicle screw, which after putting in a plunger, the mouth of the screw, the tip of the screw expands and improves its hold. And then you have this HA-coated screw, hydroxyapatite coated screw as well. But traditional implants which take care of the strongest bone available in the osteoporotic spine, namely the lamina, are the sublaminar wires and the hard shields rectangle, along with these pedicle hooks as well, or laminar hooks as well. So these are important modalities you mustn't forget about. In pedicle screws, you can also take advantage of the different trajectories available, wherein this is a outwardly directed screw, which is a cortical screw. You can have a medially directed screw, angulated screw to the superior cortex. Basically, wherever there is a significant good hold in the superior part of the pedicle and in the cortical bone of the pedicle, you take advantage of these different trajectories as well. Now, patients with normal neurology in whom you're just going to do a vertebroplasty, an important tip that we learned all the way along was to avoid overfilling of the cement. Even in this case, as you can see, the cement looks a little bit significantly pushed. So avoid overfilling of the cement, and importantly, medically treat the osteoporosis always and always. This is a patient with a normal neurology with a conus or cord compression. She didn't have significant neurology, but just instability, back pain, and needed support for walking. Now, whenever in these borderline cases you feel a little bit hesitant just to do a plain vertebroplasty, so we devised a surgery, sort of a mini open or minimally invasive decompression along with an open vertebroplasty. So you negate some of the effects of that fear that you have with what's going to happen if the middle column just gets pushed behind onto the cord, in getting a neurologist to a patient who previously didn't have any neurology. And it gives good results, but importantly, you need to avoid it when there is a significant kyphosis, because you just can't do it in a kyphosis surgery. Whenever there is a gross segmental instability or three-column instability where the posterior column is stretched out along with an anterior column deficit, where you have destroyed end plates or the disc space is affected, as in this case, as you can see, the disc plate It's a paper wafer thin bone along with adjacent displays issue, and obviously where you can just get away with a percutaneous vertebroplasty. In today's age, I would just add an pedicle screw fixation either through an open surgery or through the MISV preferably, especially if it's a junctional fracture like a thoracolumbar injury. We would add a pedicle screw insertion one level above, one level below, and preferably a small screw in the same level along with the anterior reconstruction with a vertebroplasty. Now, osteoporotic fractures with neurology becomes a different beast altogether, where you have to have all the surgical experience and of different procedures of osteotomy and anterior reconstruction of the column from a posterior approach. Now, the principles remains the same. You have to decompress the spinal cord and you have to stabilize it a little bit longer than you would do routinely. So in this case, one above, one below, or two above, two below just won't do. So you make sure you instrument the spinal column a little bit longer, and wherever possible augment your fixation as well. Now, to reconstruct the column, we encounter two types of vertebral instability, and the reconstruction, anterior column reconstruction, differed if you have an intervertebral instability or an intravertebral instability. Now, in an intravertebral instability, the non-union, as you can see, is restricted inside the vertebra only. Okay, so you have a thin shell of bone surrounding non-union, whereas in an intervertebral instability, you have the fractures which were either close to the superior or the inferior end plate, and the end plate just gave away, giving rise to a intervertebral instability. So this is an intravertebral instability, wherein the principle of reconstruction remains is to just fill the cavity either by a cement or any cage. A T-leaf cage also can be inserted into the cavity, or you just close the cavity surgically. So a porotic fracture with neurology, with intravertebral type of instability, but without kyphosis, can be treated like this way. So a case, for example, significant stenosis with an osteoporotic vertebral fracture. This needed a decompression and stabilization along with a vertebroplasty. Now, mind you, the use of these cemented screws was done where you make a tract, inject the cement along the tract, and you can just use the dual threaded screws as our sponsors have it. Today's sponsor of the meeting have it. Or you can use what was earlier shown as a fenestrated screws, where you can insert the screws which has fenestrations at 2-3 fenestrations at the tip of the screw, wherein, and after putting the screw, you can just insert cement so that this part becomes solid and the pedicle screw has a good hold over this area. So cement augmented pedicle screws along with a vertebroplasty and a decompression is an option in this case. Something similar again, old healed fracture with cord compression along with a new fracture. Again, a similar cement augmentation with vertebroplasty, again column reconstruction was done. Another case wherein you had a intravertebral instability in neurology with kyphosis, the option remains to reconstruct the column with a pedicle subtraction osteotomy. A huge yawning gap which was seen anteriorly once you position the patient. Once you take down the pedicles on both the sides and compress the column, the gap actually closes. So either you can close in the gap, or you can fill in a bone graft or a titanium or a peak spacer inside, just like as you would do for a transforaminal lumbar interbody fusion surgery. A T-leaf cage can be inserted into the gap. The whole idea is to fill in the gap anteriorly, either by cement, either by compressing the column, or use of cages. Now, wherever you don't have pedicle screw, it's not like you need to have pedicle screw. Actually, the best implant for osteoporotic spines, everybody would agree, is a hard shell rectangle, sublaminar wires and a hard shell rectangle, which will really save you the day. Wherein if the bone is significantly osteoporotic, your screws are just pulling out, it's like mushy bone, then you can take help of this sublaminar wire fixation along with hard shell rectangle as well. So you have a traditional option available as well, wherein your screws just won't give you that confidence of fixation. Now coming to the intervertebral instability, where the instability is very close to the disc space, or the fracture is very close to either the superior disc space or the inferior disc space. The end plate fractures fall in this category, where over a period of time they get into kyphosis, the end plate ruptures, then you land up with a kyphosis along with the middle column pressing onto the spinal cord, leading to neurology. And in this intervertebral sort of scenarios, you need to take down, remove the discs along with the bony shell which is remaining, reconstruct the anterior column with a cage, and then augment posteriorly significantly longer. So as discussed, you need to reconstruct the anterior column, and your window, your gateway becomes the transpedicular approach for most of these cases. Take down the pedicles on either side. Make sure you have significant space. Take help of an expandable cages wherever possible. And depending on the size of the defect that you leave behind in reconstruct the anterior column. So case in point, again, a patient wherein the end plate was breached. Then you'll have to take down significant amount of the end plate as well as the disc and reconstruct the anterior column by putting in a mesh cage in. Again, something similar case for a second reconstruction of the anterior column. So to summarize, you need to reconstruct the anterior column either by a cement, either by a spacer or a mesh cage, or closing down the column. Have fixation modalities, either traditional hard shell rectangle or pedicle screws. Augment the pedicle screws. Use more than one modality of fixation or multiple fixation points when you are going to fix posteriorly. Whenever in doubt, go longer in osteoporotic spine and have more than one fixation modalities. What my personal choice is, I try to either cement at the ends, use cemented screws at the ends, or use such sort of a construct where you have wires either at one level or two levels, either superiorly, inferiorly, or at both the places, because that's where the construct is going to fail in an osteoporotic spine. You will have to proximal or distal pull out. And if you can protect those levels, then you'll have good results. Now, all of this is going to fail, and we have had failures with this if the osteoporosis is not treated, or there's a severe grade of osteoporosis. So osteoporosis treatment is medical therapy only. So take home, there are different options that you just saw, from a plain simple vertebroplasty to a mini open procedure, to a significantly large procedures like a transpedicular decompression and reconstruction of the anterior column. So if at all I have to tell you some take-home messages, it's going to be: don't have significant cement insertion in your plain vertebroplasty patients as well. The posterior surgery is the important benchmark for this thing, but with an anterior support. Try to reconstruct the anterior column. Prefer multiple fixation modalities like use of sublaminar wires, use of cement augmented screws. That's going to prevent pull out of the screws. And importantly, significantly importantly, treat the osteoporosis as well. Thank you.
Thank you, Uday. Any questions for Uday? Excellent talk. I think the take-home message is very good. That one, you need to reconstruct, and what has to be done, not that patient is old or patient is not going to tolerate. So if you're going to operate, do a good job out of it. And many people have lost touch passing sublaminar wires, hooks. I think everybody should learn that with an aging population. It's an excellent add-on to our pedicular reconstruction. Dr. Satyan, do we have more time or anything, or any more questions for the panelists?
We have to stop the session at 4 o'clock. So you can just take a quick case.
I think we have one case. Let's take that case.
Yeah, go ahead.
I think we can. I already sent it. They have it, I think. Just project it, second case.
Can you share the case, please? And while we are sharing the case, I wanted to ask, Devesh, you have been showing about kyphoplasties.
Yes.
Are you still preferring that over vertebroplasties, or do you find a difference?
Kyphoplasty just helps us to open up space, become more safer. But every time it's also sometimes the cost is too much. It's too much the cost as compared to a vertebroplasty. So if there's not much collapse, I would just do a vertebroplasty, get away with. But if I think I want to open up, it's an older fracture, probably I'll do a kyphoplasty. It gives a little better option to open up the space, and low pressure cement injection decrease the chances of leakage also.
Okay. Go ahead with
So this is a very interesting case. It was this patient was around 75 who came to me with low back pain. I just did his X-rays, and this is what I found. So you can all see what all things are wrong, but patient had no deficit, nothing. So I just saw that it's a learning curve for all of us. This was done probably at the early time when we started doing vertebroplasty, and you can see all things going wrong in the AP and the lateral view. And I just wanted to project saying that how you could have avoided all these things. Any panelists, any ideas how we could have avoided all these problems?
My 2 bits would be most of us, when we started doing this thing quite early in our careers, we used to any vertebral osteoporotic fracture, we would start doing it quite early. So doing it late, giving it at least 2-3 weeks of conservative trial before you think of getting into vertebroplasty. Then injecting cement in its liquid stage, not very flowy stage. If you inject, this could lead to.
And I think at that time many used to use this joint replacement cement also.
Yeah,
Very fluid as compared to a normal vertebroplasty cement. I think tends to leak much faster. You cannot see the cement where it is going till it is too late. And I think vertebroplasty was a high pressure. They used to inject with a lot of pressure, and once you inject, I think you could not stop once it has gone out. So I think, and probably I think removing the needle, not taking good AP and lateral X-ray has added to the problem.
Importantly, what you mentioned, Devesh, was continuously moving the needle, because in a haste of waiting for that 12-15 minutes, most of us in a haste would remove that needle quite
too fast also,
into a tract of cement completely. That's been seen in the lower lumbar region.
It leaves a large tract, yes. And any more ideas how we could have avoided all these complications? You can see it going. What do you do if you see an epidural injection? In this case, you could see that it has gone into the epidural space. Whether you would go immediately to do anything about it, or see how the patient behaves post-op and then take the call for it, or how do you go about if you see there's an epidural leakage?
So epidural leakage with the cement or with the dye?
With the cement dye, so still you can go slow and change the position or something of that sort. But if you see a cement leakage like this one, how do you go about it? Do you wait, or you would like to be aggressive and remove the compression? And any ideas regarding that?
No, you would wait. I don't think you need to, because as you said rightly, sometimes it just tracks below if you're lucky, it tracks below the PLL and it does not go behind and does not cause cord compression.
I think it dissipates the heat also. The CSF dissipates the heat also, and you may get away with it. So I think probably it's safer to wait unless you see a large blob pressing on the canal or something. But if you see just along the PLL, probably you may wait and watch. Yes,
the thing I think that we would be excited earlier when you used to see that intravertebral cleft. You would get very excited to put in the cement in that cleft, but over the years after burning fingers, that started to excite. It looks more challenging.
That intervertebral cleft was an invitation sign for vertebroplasty. Right? I know so many people used to keep coming, "Arey, vertebroplasty."
I think now everybody has burnt fingers. I think teriparatide, your medical modalities have also helped.
No, but the only worry is about teriparatide is the indiscriminate use now, because they're just using it for every person. It's not. And as we know, it's only once in a lifetime. The question is, what do we do after a person becomes a little bit older?
Absolutely. Okay, thank you all the panelists. I think we are running less. The time is running out. I thank you all my panelists for doing a wonderful job in a short notice. Yes, Dr. Sanjay.
I'm here. I'm actually looking at both the screens. So I invite everyone to come into Hall A for now, where we'll be doing our inauguration session. We will be running the same thing in Hall A and Hall B simultaneously. And after this, we will be again breaking our back into the two halls for the abstracts. So I'm concluding the session in Hall B. We've had a very good meeting there. Thank you, Dr. Devesh over there, and thank you, Vishal here.
Thank you.
Thank you, Dr. Devesh. Thank you so much.
मुझे लगा आई वाज नॉट एक्सपेक्टिंग
बट यूरोप में तो दोपहर में वाइन मार के काम पे जाते थे।
हाँ, और उधर बियर मतलब वो लोग पानी
एग्जैक्टली वाटर।
केरला में क्या सीन था, मॉर्निंग में वो साला फिश ऑर्डर करते और बियर ऑर्डर करते मॉर्निंग, मतलब ब्रेकफास्ट चावस।
वापस जाने
हाँ तो फिर 5:30 को निकलती है, आधा घंटा मिनिमम लगेगा।
Are we live in Hall B? Suvida, are we live in Hall B?
Sir, 1 minute.
Suvida, are we live in Hall B?
Sir, in 1 minute.
Hi, Kunal. Hi, Mazda.
Hi.
So I'll, as soon as we are live, I will invite you to take over the session.
Okay.
Nikhil is there. Is Nikhil here?
I believe he told Kunal he's not going to make it.
Okay. All right. So I'm there with you in case you need any help, but you guys can manage.
Right.
You have the list as well. You can invite them one by one. Let them do their presentation. The present is all recorded. And then after that, any questions? If there are any questions from other
All
audience
12.
members.
All 12 presentations are.
Yes, I think so. So with the all 12 are available.
Yes, sir. Hall B is live now.
There's an echo in her sound, huh?
So Suvidha won't be.
Sir, we can start the Hall B paper now.
So we are live now in Hall B.
Yes, sir. Yes, sir.
Okay, thank you. Thank you. Welcome everyone. We have a very exciting session on with these young spine surgeons, upcoming spine surgeons who are presenting their work. A lot of effort has gone into their studies of different aspects and scientific papers which they have made. And I encourage all of you to have a patient hearing, and you can even ask questions if you have any doubts. It would be very encouraging for our upcoming surgeons for this. For this session, I invite two of our experienced campaigners, Dr. Mazda Turel and Dr. Kunal Shah, to please take over this session and invite the speakers.
Hi, good afternoon, everybody. We'll start straight away with the first talk by Meher Mehta, the importance of ICD insertion in a patient post-kyphotic deformity correction. Can we have the talk, please?
Good morning, everyone. Today, I'll be talking about the importance of ICD insertion in a patient post-kyphotic deformity correction surgery. Now, we were presented with a 45-year-old male who came with complaints of neck pain, mid-back pain since the past 4 years, with features of myelopathy, occipital headache, and gait instability. The patient was diagnosed to have T6 to T7 hemivertebra with kyphotic deformity and myelopathy, as well as being a known case of seizure disorder. These are the x-rays preoperatively along with the chest x-ray. Now, using the posterolateral approach, the patient was taken up for vertebral body osteotomy with resection from D6 to D7, along with corpectomy, with kyphotic deformity correction and posterior spine stabilization with pedicle screws from D3 to D10, along with partial rib resection from the 6th and the 7th ribs under general anesthesia. Postoperatively, on post-op day 2, the patient developed chest pain and breathlessness while he was being made to sit with a Knight Taylor brace and a saturation drop to 70% at room end. The patient had decreased breath sounds on the left side. Immediately, the patient was intubated and shifted to the ICU. 2 days later, the patient underwent a bronchoscopy on the post-op day 5 under local anesthesia, where the left bronchus mucus plug was removed, following which the patient was maintaining on non-invasive ventilation. After 2 days, due to persistent chest pain, cardiac evaluation was done for the patient, where the cardiac markers were within normal limits. A pleural tap was then performed, which showed bilateral hemorrhagic effusion, and bilateral ICDs were inserted, with approximately 1 liter drained from each side. Following which, the patient's saturation improved following the ICD insertion, and the patient was maintaining on 4 liters of oxygen on nasal prongs. 2 days later, the patient was shifted out of the ICU, and 4 days after the ICD was insertion, the right ICD was removed, and the patient was maintaining on 2 liters of oxygen on nasal prongs. 2 days later, the left ICD was removed, and the patient was weaned off of oxygen and was maintaining oxygen at 95% SpO2 at room air. The patient was started on chest physiotherapy soon after and was mobilized with a Knight Taylor brace, following which the patient's SpO2 was monitored continuously but showed no changes. After 4 months, the patient came for follow-up with reduced neck pain, no signs of myelopathy, and was mobilized comfortably with the KT brace, thus showing us the importance of ICD insertion and hemorrhagic pleural effusion as a complication post-operatively following a kyphotic deformity correction. Thank you.
That was really interesting. Would you suggest that you put an ICD for all patients who have a thoracic kyphotic deformity correction electively, prophylactically during?
If we suspect a pleural tear during the surgery, then it would be advisable to prophylactically insert it.
So in this case, did you all notice one intraoperatively, or you all did not notice anything?
We did not notice any pleural tear intraoperatively, sir.
And when the patient deteriorated, what you put an ICD 2 days later. Why didn't you think of a pleural effusion at the same time when he had a whitewash of the left side and insert an ICD the same day?
Because initially we had taken a pulmonologist's opinion who had suspected a bronchus plug, for which the bronchoscopy was done and the mucus plug was removed. Thus, we didn't suspect any other pleural tear. And other side of the chest pain, which we had suspected, we got the cardiac markers done, which were also showing that they were within normal limits. And that is why there was a little 2-day delay in putting the ICD.
Yeah, but any drop in saturation following a major deformity correction in the thoracic region, one should always suspect that there could be a pneumothorax, hemothorax.
Yes.
And,
point well taken, Dr. Turaj. We'll go to the next one.
We'll move on to the next talk
Yes,
by Norman Attar, a rare case of primary extradural hydatid cyst causing spinal cord compression. Oh, yeah.
Good evening everyone, myself Dr. Noman Attar, Spine Fellow from Hiranandani Hospital. Today I am going to present a very rare case of primary spinal extradural hydatid cyst causing spinal cord compression over a previously operated of same site intraspinal extradural tuberculous granuloma. So start with the introduction. As we know, the tuberculous infection is highly prevalent in India, while the hydatid cyst disease is a relatively uncommon. The frequent site for hydatid disease is a liver and lung, around 80 to 90%. The bone involvement is a very rare, out of which vertebral column is 50% of this bone involvement. The most commonly vertebra involved is a thoracic spine over around the 52%. The causative agent for this hydatid disease is Echinococcus granulosus. The purpose of study to report a very rare case of spinal extradural hydatid cyst over the previously operated site of tuberculous granuloma. Our aim to create the awareness among the surgeons about this rare clinical entity and to include in the differential diagnosis of the atypical spinal presentation. So our patient, a 60-year-old gentleman, came OPD in 2017 with the chief complaints of the swelling over left chest wall with the backache and the weakness in the both lower limb with difficulty with walking, and there is a sudden neurological loss with the bowel bladder involvement. There is a loss of power around 3/5. There is a tenderness at the D6, D8 level, loss of sensory functions below the D4 level. There was associated symptoms of weight loss, fever, loss of appetite, night sweat during the last 1 month. And on blood investigation, there is increased ESR and CRP level. We did an X-ray. We found there is a caries rip on the 7th, 8th. We confirm on the MRI dorsal spine. On sagittal view, we can see that is an intraspinal extradural mass at the level of D6, D8 level. We operated this patient with the excision of this mass along with the abscess and confirmed our diagnosis on the histopathology, where we found the caseous necrosis along with the Langerhans giant cell. So we put the patient on the ATT drugs for the regular follow-up, and after around 1 year, we found complete neurological recovery with the motor and sensory function. There is unfortunate, and this unfortunately patient after 1.5 years again came to our OPD with the similar complaint, backache, complete paraplegia with the bowel bladder involvement, power 0/5 with the loss of sensory functions of pain and fine touch. There is a physical examination, plain X-ray were normal. We did the MRI. We found there is an intraspinal extradural multiple cystic lesion over the same area at the D6, D8 level. Other tests like the USG abdomen, contrast MRI, serology were negative. This patient taken for surgery, surgical decompression. We found there is a multiple pearly white cyst in the extradural space. We washed the wound with hydrogen peroxide and with the normal saline. We confirmed the diagnosis on histopathology. We put the patient on albendazole for 3 months, and patient recovered around in 2 months. And fortunately, there is no recurrence in last 2 years of regular follow. On discussion, as we know, tuberculosis hydatid disease is a public health problem. The India has highest burden of tuberculosis, but the hydatid disease is more common in Andhra Pradesh, Tamil Nadu, Gujarat, and West Bengal. And we know the route of infestation is either fecal-oral route or the direct ingestion of the parasitic eggs. As we know, the spinal hydatid disease is a very rare, around 0.2 to 1%, but there is appearance of tuberculosis followed by hydatid disease.
I think we've run out of time, and that's why they've electively discontinued the.
We can ask him to say his conclusion and then ask a question.
Hello, is Noman there?
Yes, sir. So our conclusion is the hydatid disease is a very rare, very, very rare. The incidence in bone involvement and that of spine is very rare. It's around 0.5 to 1%. But in our case, we found it is a co-occurrence. Like first with the same region, the tuberculosis occurred, tuberculous granula, and followed by, we found after 1.5 years, the hydatid cyst. So there should be, it is a atypical presentation. Whenever there is a dorsal spine involvement, we should always think about the hydatid cyst as a differential diagnosis.
Interesting. Yeah, it's one of these rare freaky cases. We'll move on to the next one. Tarini Johari, talk about the effect of denosumab therapy on spinal giant cell tumors.
Good evening, everyone present. I'm Dr. Tarini Johari, and I will be presenting a short case series on the outcome of denosumab therapy in spine giant cell tumors. So giant cell tumors are a good and a bad disease because it's benign, but it's also locally aggressive. It's a primary bone neoplasm composed of a proliferation of mononuclear cells, multinucleated osteoclast-like giant cells, and stromal spindle cells. GCT represents 21% of all the primary bone tumors with an incidence of 1.7 in a million. In spine, it ranges from 1.5 to 9.4, therefore making it really rare. Surgical treatment has been the gold standard for GCT, but due to its friability, all-block resection of GCT in spine is technically more challenging and less effective owing to the risk of collapse or breakage of the mass during the procedure, thereby leading to tumor cell leakage and seeding. We classify GCT using Enneking or Campanacci staging based on the radiological appearance. It's described three stages that correlate with tumor local aggressiveness. So stage 1 being latent, stage 2 being active, and stage 3 being aggressive. For the neoadjuvant, denosumab is the monoclonal antibody that is used for targeted therapy as a brand ligand, a cytokine that is expressed by the osteoblast surface, which inhibits the brand that is expressed on the osteoclast, thereby helping in prevention of bone erosion. So, three patients were included in the study that were diagnosed with spine PCD from our institution. Denosumab usage was categorized as either preoperative treatment or postoperative treatment. All the patients were administered 120 mg subcutaneous dose monthly for the next 6 months. And the symptomatic treatment as well as the functional improvement was calculated according to the VAS scores, ODI, and Frankel grading. On imaging, local effect of denosumab treatment at 6 months was staged using the classification provided by Boreani. The result was that there was no evidence of local recurrence at their first follow-up in all the three patients, with significant neurological and functional improvement. So in order to stage the local effects of denosumab, Boreani proposed 6 levels based on the ossified rim in the periphery and the formation of new bone within the lesion. We have a 26-year-old shopkeeper who presented elsewhere with compressive myelopathy. He was operated in December 2019, and the biopsy that was sent was suggestive of malignant tumor cells with an epithelioid appearance and clear cells. He also underwent histopathological review and repeat biopsy. It was done on a separate occasion because of progressive neurological deterioration, and it was suggestive of GCT. He presented to us in September 2020 bedridden and underwent a preoperative arterial embolization followed by decompression and separation surgery. A mutual census was taken between the patient and us to start him on denosumab thereafter. On 6-month follow-up, we can see that the cord had taken an ovoid shape and it then turned into a circular. And we can also see restoration of cerebral spinal fluid. Here we can see that this can be staged as Boreani stage 2A, as we can see a proper sclerotic bony rim formation in the periphery. The patient had significant neurological as well as motor function improvement, going from Frankel grade A to grade D. So now we have a 39-year-old housewife who presented to us as a diagnosed case of GCT of L4. The patient was started on denosumab bias for the next 5 months, but thereafter she began to deteriorate and presented as a cauda equina syndrome. On the MRI, we can see that the tumor is encroaching the surrounding soft tissue, as well as it is engulfing the pedicle and the facets and causing cord compression at L4. On CT scan, we can stage it as Boreani 1B. So looking at the surgical emergency, we chose to do stabilization as well as extensive debulking. And then we started her on denosumab for the next 6 months. And on the 3rd month, post-operative, she also had a significant motor function improvement and improvement in her urinary incontinence. So concluding, denosumab therapy in spine GCT is beneficial to halt or reduce the extensiveness of the tumor, thereby making unresectable tumors resectable. It causes radiological improvement, and we have observed clinical improvement in 4 patients, both symptomatically and neurologically. It is a reasonable alternative in patients where surgery has an increased risk. And despite many recommendations, the dosing schedule and the duration of denosumab therapy still remains uncertain. Thank you.
Yes, that's a really nice presentation. There is now more and more evidence to see how denosumab works in these situations, and you can really use it both preoperatively and postoperatively, and that's its great advantage. Thanks a lot for this. We'll move on to the next paper by Akshat Pandey on aggressive vertebral hemangioma, an institutional study of 3 cases.
सर गए हॉस्पिटल पहुंच गए तो सुबह कॉलेज थी तो सुबह कॉलेज बस गए
I am Dr. Akshat Pandey and I will be presenting a short case series of aggressive vertebral hemangiomas. Vertebral hemangiomas are benign vascular bony lesions enriched with thin-walled vessels and encompassed in fat that permeates the medullary cavity between bony trabeculae. They have a high incidence of 10 and 27% and only 0.9 and 1.2% are symptomatic, and they can cause osseous, extraosseous, and epidural expansions with a recurrence rate of 3%. Patients who were diagnosed with vertebral hemangiomas and minimum 6 months of follow-up were included in a study. Surgical intervention in the form of decompression excision instrumentation was done, and all patients underwent preoperative arterial embolization. Neurological improvement was assessed using the Frankel grade, and functional improvement was assessed using the VAS and ODI scores. 5 patients were included in a study, out of which 2 were lost to follow-up. 2 patients had primary disease and 1 had recurrence. 2 patients underwent open stabilization and 1 underwent marginal excision with MIS stabilization. All patients improved symptomatically and functionally. Histopathology in all patients was suggestive of epithelioid hemangioma. The first case is of a 16-year-old student who came with mid-backache and bilateral progressive lower limb weakness for past 3 months, and she is now bedridden with urge incontinence since past 2 weeks. She denies any history of trauma, but gives the history of instrumentation, spine surgery for similar complaints 1 year ago. On physical examination, she was spastic paraplegic with a neurological level of D10. She had undergone decompression and fixation at D8 and D10 level a year ago elsewhere, and the histopathological diagnosis was suggestive of hemangioma. The present MRI shows high-intensity signals with extraosseous portion of D9 compressing the cord on action and sagittal view both on T1 and T2, indicating a vertebral hemangioma. We did decompression and extension of fusion. This is the post-op X-ray and the histopathological slide showing vertebral hemangioma. On 14-day post-operatively, the patient had improved neurological status with complete sensory recovery and grade 2 power in right lower limb and grade 1 power in left lower limb. After 6 months of aggressive rehabilitation, the power improved to grade 3 in left lower limb and grade 4 in right lower limb. The sphincteric control was also found to be fair at 1 year of follow-up. The second case is of a 35-year-old male with complaint of low backache and with left leg radiation since 3 months. In a known case of epithelioid hemangioma, biopsy proven. He also complained of night pain and transitional pain. On examination, power on right side was full, but on left side, knee extension and ankle dorsiflexion were found to be weak. The MRI showed involvement of body and left pedicle of L4 and left partial involvement of left pedicle of L5 with compression of L4 nerve root. The contrast MRI also showed a hyper-intense signal at L4 level vertebra. CT scan shows involvement of the left pedicle of L4 and L5 vertebrae. We did preoperative arterial embolization with unilateral percutaneous fixation at L3, L4, and L5 levels with left transpedicular decompression. Flexion extension X-rays was taken at 6 months of follow-up. The functional outcome also improved after 6 months with painless extension, flexion, and normal gait movements. So my conclusion is epithelioid hemangiomas can be aggressive and can lead to instability and cord compression, and observation should be considered in patients without instability or cord compressions. Aggressive epithelioid hemangiomas should be followed up regularly to pick up any recurrence, and they can be managed appropriately. Preoperative arterial embolization aids in controlling intraoperative blood loss in these tumors. Thank you.
Thank you. That was a really nice talk. There is also a role of embolization with absolute alcohol. Have you all ever considered that? Or it's only embolization with glue or any other material?
No, sir, we did not try the absolute alcohol.
Yeah, that's also something you should read up about in the literature and see that's equally effective.
Yes.
We'll move on to the next talk by Kaushal.
और हमारे तो ग्रेट फैकल्टी अभी सेशन कंडक्ट कर रहे हैं इधर फोन पे से BSSCON है ना, BSSCON चल रहा है, फैकल्टी है सेशन।
Good evening, everyone. The study is titled Percutaneous Wide Biopsy, Needle Biopsy for Spinal Lesion using Plastic Cannula, a technical note. Biopsy remains the most important tool in a spine surgeon's armamentarium, especially to clinch the diagnosis of a vertebral body lesion. However, sample inadequacy plays an important part in lowering the diagnostic accuracy. Hence, we present a technical modification by using kyphoplastic cannula and pituitary forceps to improve the sample adequacy and the diagnostic accuracy. 71 patients with radiological evidence of discovertebral lesion from T1 to S1 were included, and CT scan was used to localize the exact location of the lesion. The technique of the transpedicular biopsy involves use of CM with the patient in prone position and use of Jamshidi needle. The CM is oriented in such a way that a bullseye view of the entire pedicle is obtained and Jamshidi needle is passed and directed according to the location of the needle. After confirming its position, a guide wire is passed over the Jamshidi needle and the Jamshidi needle is replaced with a kyphoplastic cannula. Once the cannula reaches the point where it just meets the lesion, the wire and the stillet are removed, and thereafter a 20 cc syringe was fixed over the tip of the cannula and aspiration was attempted. A drill was then introduced to scrape the lesion along with the LD tissue, and after its removal, a 16 centimeter long and 3 millimeter thick pituitary forceps is introduced in the cannula, and under fluoroscopy guidance, the samples were obtained with the pituitary punch. The cannula allows the repositioning and anteroposterior adjustment of the pituitary forceps until adequate sample is obtained from the lesion. Similarly, the process can be used to harvest the material from the disc. To obtain sample from the disc, the Jamshidi needle is introduced through the far lateral approach and an oblique CM shoot is used to identify the end-on views. The needle is introduced lateral to the facet joint and not too close to the pedicle above. The samples which were collected were sent for aerobic, anaerobic culture, AFB culture and fungal culture, and were also sent for gene expert and histopathology examination. Of the 71 patients who underwent biopsy, 95% had a definite diagnosis. All the samples were found to be adequate on histopathological examination, and only 3 patients did not grow any organism but showed chronic inflammation. These were gene expert negative and they responded well to the antibiotics. This chart shows first chart shows distribution of the location of the lesion and the gender distribution. Our method showed a positive diagnostic yield of about 95% without any rate of complication. None of the patient underwent a repeat biopsy, and our study had 100% sample adequacy without performing any intraoperative scrape cytology. This pie diagram shows the distribution of the pathology, with most common being infective pathology. The limitations of our study were that it was a small sample size and the fact that it was based on a single center, and nearly half of these patients were of infective pathology. Thus, to conclude, our technique of using pituitary forceps through a cannula is highly effective in getting adequate representative sample with excellent accuracy in diagnosis. This procedure is beneficial for soft tissue lesions and for infective pathology, especially discitis. Thank you.
That's a nice talk and a great idea. I think it really helps getting more tissue in getting an adequate biopsy, because so many times we end up with just a Jamshidi needle biopsy and it results in not getting an adequate sample. What is the size of the pituitary forceps that is it custom made? Is it easily
No, it is the regular forceps which we use, 16 centimeter long and the 3 millimeter punch, which is usually
the Jamshidi needle.
No, through the kyphon cannula, sir. First we introduce the Jamshidi needle and then replace it over a guide wire with the cannula, and then the cannula is used as a sleeve to maneuver the forceps.
Great. No, that's really nice. Thank you very much.
Yes, thank you, sir.
We'll move on to the next talk by Manoj Kumar Katkari. And
Myself, Dr. Manoj Kumar Gadikeri. My study is on comparative analysis of long-term outcome of anterior reconstruction in thoracic tuberculosis. The outline of my presentation includes introduction, aims and objectives, materials and methods, results and conclusion. Tuberculosis of spine was first described by Sir Percival Pott. Thoracic spine is the most common site affected. The anterior part of the vertebra is the most common area affected in the spine, leading to collapse and kyphotic deformity. The aims and objectives of my study were to retrospectively evaluate and compare the long-term outcome of anterior reconstruction of vertebral body in tuberculosis of dorsal spine by anterior versus posterior approach, for which we chose a retrospective study design consisting of 245 patients, of which 118 operated by anterior approach and 127 operated by posterior approach. The study duration was of 1 year. Clinically, the data regarding demography, neurology as per Frankel grading, approach used, surgical time, blood loss, post-op mobilization and complications, if any, were recorded. Radiologically, the patients were assessed by X-rays taken preoperatively and postoperatively at immediate post-op at 1 month, 3 months, 6 months, at 1 year. MRI scan, CT scan were done. Pre and post-operative corpse angle were calculated. Percentage correction of kyphosis, time to fusion, and loss of correction were recorded. The anterior approach was indicated in young patients with absence of comorbidities and those with 2 or more vertebral body involvement. The surgical technique involves versatile approach technique. The anterior reconstruction was done using cage, rib graft with or without iliac crust grafts. The fixation in all cases was done using hard shell rectangle with sublaminar wires. Posterior approach was preferred in older patients with comorbidities and those with less than 2 vertebral body involvement. The surgical technique involves standard posterolateral approach via transfacetal, transpedicular or costotransfasectomy approach. Cage anterior reconstruction was done by cage, iliac crest graft and with or without rib grafts. And the fixation was done in all cases using pedicular screw system. The results of our study showed the mean age of the patients was 36.3 years in anterior approach as compared to 39.8 years in posterior approach. The mean operative time in anterior approach was slightly longer of 6.11 hours as compared to 5 hours in posterior approach. Mean preoperative kyphosis was 41 degrees and postoperative kyphosis of 9.5 degrees with 77.46% of correction in anterior approach, which was statistically significant compared to 67.2% correction in posterior approach. The time to fusion was relatively less in anterior approach with 4.69 months, which was statistically significant compared to 6.34 months of posterior approach. The mean loss of correction in anterior approach was mere 6.18 degrees compared to 4.18 degrees in posterior approach. The mean time to mobilization in anterior approach was 2.51 weeks as compared to 1.18 weeks in posterior approach. The neurological recovery was slightly better compared to posterior approach in anterior approach. The complications, there were 17 complications in anterior approach, of which there were 2 dural tear, 7 suture set complications, 3 pneumothorax, 1 implant failure and non-union, and 3 neurological deterioration. As compared to 35 complications in posterior approach, where there were 11 dural tear, 10 suture set complications, 10 implant failure and non-union, and 4 with neurological deterioration. To sum up, the goals of management in TB spine includes thorough debridement and neural decompression, anterior column reconstruction and deformity correction, rigid stabilization and bony fusion. All this can be achieved better with anterior approach as compared to the posterior approach. From our study, we would like to conclude that anterior approach gives a better functional outcome and kyphosis correction compared to the posterior approach. Thank you.
So good evening and greetings from me, Bhuvaneshwar.
Thanks a lot for that interesting talk. It really is also a very individual case-based approach, based on what the original kyphosis is, etc. But a lot of people who are extremely familiar with the posterior approach can achieve the same amount of correction as you do with the anterior approach, are able to do the same amount of debridement and neural compression from behind as one can do from the side. It really is a question of what you're more familiar with keeping the goals that you mentioned in mind. I think the goals should not change. The approach should be targeted towards achieving those goals and minimizing complications. So like you rightly said, they both more or less are on similar ground. In your case, the anterior approach has a better result, but people can do the same thing posteriorly. Thanks a lot. We'll move on to the next talk by Mantu Jain on evaluation of changes in sagittal spinopelvic parameters.
So good evening and greetings from me, Bhubaneswar. The title of my study is Evaluation of the Changes in the Sagittal Spinopelvic Parameters Post-Total Hip Arthroplasty in Patients with Secondary Hip Arthritis, a prospective study. Low back pain has been associated with hip osteoarthritis, and the term is hip spine syndrome, first coined by Offersky and McNabb. Later on, Schwab et al. Also reported changes in the sagittal spinopelvic parameters, or the SSPS, which were leading cause of disability in patients who had back pain with concurrent hip osteoarthritis. Few studies in the West have been done in patients with primary hip osteoarthritis, but the changes in the SSPS were variable. And the logic given by the authors are the elderly populations have advanced lumbar degeneration which resist changes in the SSPS. So the aim is to study the alteration in the low back pain and the SSPS following total hip arthroplasty due to secondary hip osteoarthritis in the younger population. So this is an observational study at our institute at AIIMS Bhubaneswar with a sample size of 30 in patients with secondary hip osteoarthritis. Patients with previous spine infection, surgery, trauma, myelopathy, spondylolisthesis or scoliosis were excluded. Inflammatory arthropathy affecting the hip and the spine such as rheumatoid or ankylosing spondylitis are also. So the variable clinically measured were VAS for the hip and the back pain, and functional assessment was done using ODI for the back pain and the Harris-Hip score for the hip. Radiologically, we measured the SPSS in a 36 cassette orthoscanogram using the SurgiMap software, and the parameters measured were PI, PT, SS and the SVA. So we had 30 patients, of which 19 were male and 11 were female. The main etiology was avascular necrosis, among which idiopathic was maximum. Other causes include the old Perthes disease and the developmental dysplasia. So there were 17 unilateral affected and 13 bilateral affected. 27 were operated unilaterally and 3 were operated on a single stage. In overall results, we find that there is a clinical improvement in all parameters, including the low back pain, whereas in the radiological parameters, we find that statistically significant changes are seen only in the SVA, whereas other parameters such as PT, PI, SS and LL are not significantly changed. So when we do a subgroup analysis of patients who were operated unilaterally or bilaterally, so again we find that there is improvement clinically in both group of patients, but radiologically the improvement is again statistically significant. Similarly, in patients with bilateral affected operated unilaterally or bilaterally, radiologically we find that the changes are. So this is an illustration of a 29-year female having a unilateral AVN operated with a total hip arthroplasty, and here we can note that there are some changes in the SSPS. This is yet another patient with a 48-year-old female having bilateral AVN, and here we find that the changes in the SSPS are not significant. So this is 41-year male with a dysplastic hip, and we find that post-surgery the spine gets balanced and the SVA is reduced from 141 to 53. The limitation of our study is that the sample size is too small, particularly for the subgroup analysis, to draw any conclusion. We did not measure the limb line discrepancy or coronal parameters as part of our study. We also did not segregate patients having low back pain and their severity. Rather, we took everyone and measured their back pain scores. And we also believe that 3-month score was probably too less to find any significant conclusions. So to conclude, we believe that SSPS such as the PI, PT and LL do not significantly change, whereas the SVA tends to move toward the center of the body. Hence, routine evaluation of the SSP may not be necessary while considering a surgical planning of the total hip arthroplasty. Thank you.
So it was a very good presentation, Dr. Jain. So did you analyze patients doing with changes in the X-rays post-operatively in patients done one-sided versus two-sided hip replacement?
Sir, whatever we have done for bilateral cases, there were two kind of patients. One having severe affection on one side and the other having osteoarthritis which was lower grade. So we operated unilaterally. Those who were operated bilaterally were operated in the same sitting. Bilateral totally pathologized in the same sitting.
So were there any changes in the X-rays in patients who had done unilaterally versus bilateral hip
No,
replacement?
sir. In patients who were operated unilaterally or who were operated bilaterally, clinically patients have improved, but the SSPS did not alter.
Okay, thank you.
Thank you, Dr. Mantu. Good paper.
Next paper is by Praveen Goparaju.
I am going to speak on this topic. Thanks for all the mentors who have actively participated in this multicentric trial. There are various techniques of performing lumbar discectomy. The main goal of each technique is to relieve the patient from their symptoms. There is always a claim of one technique being better than the other. However, the evidence in the literature is low, and there is no single study comparing all the techniques. So the authors venture to assess the perioperative factors, outcomes, and complications of each procedure and compare them. The aim of the current study is to assess the functional outcome in the form of VAS score and ODI scores, operative outcomes, and complication rate. This was a retrospective study where the consecutive patients that underwent discectomy using the following techniques were included. They were broadly classified into minimally invasive group, where tubular, endoscopic, and distensive techniques were included, and open group, where open and microdiscectomy were included. Surgeons with minimum of 5 years experience were included to have a level playing field. The premise was set for 2 years follow-up. Data collection was initiated in July 2019. These were the 10 centers that participated in the study. The single level lumbar segment with age more than 15 years and failed conservative treatment were included in the study. Patients with stenosis, instability, and calcified disc were excluded. These were the statistical tests that were run, and P values less than 0.05 was considered as statistically significant. These were the demographic results, where sample size is 946 and male to female ratio is 568 to 378. Coming to the VAS score of the leg, there is significant improvement compared to pre-op. However, there is no statistically significant difference among the group. This can be attributed to the experience of surgeons in understanding the nuances of the technique to decide the end point of discectomy. Coming to the VAS score of the back, there is a mild superiority of minimally invasive group compared to open group at 6 months follow-up. The correspondingly reduced tissue trauma can be attributed to this. Again, in ODI score, there is no statistically significant difference among the group. Maximum improvement is seen in the first 6 months. This explains how the quality of life improves after discectomy, irrespective of the technique used. Operative time is high in open group compared to minimally invasive group. The need for exposure, hemostasis, and closure possibly prolong the operative time in this group. Blood loss is high in open group compared to minimally invasive group. Better visualization of the vessels and under magnification can be attributed to this. Hospital stay is high in open group compared to minimally invasive group. However, this cannot be the best measure for the invasiveness of surgery, as other factors like insurance system and post-operative protocols affect the outcome. Incision size is high in open group compared to minimally invasive group. This can be a contributing factor in patients' decision making to choose one technique over the other. The total complication rate is around 12.89%, with most common being recurrence and least common being the deep infection. A particular pattern can be made where recurrence and reoperation are comparatively high in minimally invasive group, while wrong level surgeries and infections are comparatively high in open group. Coming to the limitations, this is a retrospective study. The anatomical location of the disc herniation is not included in the study. The study doesn't analyze the perioperative costs incurred. In conclusion, this is the first study to compare all the prevalent techniques across the globe. Minimally invasive techniques have some advantages in certain perioperative factors, but all the techniques provide similar pain relief and functional outcome at the end of 2 years. The minor differences in the incidence of complications were not statistically significant. The various rates of individual complications provides a reference value for future studies. Thank you.
Hi, that was a very interesting and very detailed talk. Why do you think that the recurrence rates are higher with the minimally invasive group, even though the goal of surgery remains the same? What is the possible postulation of that being the case?
Sir, can you just repeat the question again, sir? Sorry.
Why, in your opinion, do you think that the recurrence is higher with minimally invasive procedures as opposed to the open ones? Do you feel that adequate amount of disc is not removed, or what in your opinion tantamounts to
Yes, the recurrence rate in literature is normally shown by inadequate the annulotomy what we do, and also the amount of annulotomy or the size of the disc or also instability. So if the size of the disc or inadequate decompression is done, the recurrence will be high. So that might be one of the reasons that minimally invasive group it is high.
Okay, interesting. I would love to talk a little more about this, but we are running short of time, so we'll move on to the next talk. But it is a great paper. We'll have the talk by Rudra Mangesh Prabhu.
My topic is evaluation of functional outcome and neurological recovery pattern in patients with paraparesis secondary to a retrothecal epidural abscess managed at a tertiary apex center. Our study is a retrospective observational study. We included the patients managed by us between 2014 and 2020. The inclusion criteria in our study was retrothecal epidural abscess causing cord compression without spinal instability. The exclusion criteria in our study was anterior disease causing cord compression. We calculated the maximal spinal cord compression ratio on sagittal T2 MRI sequences. It is the ratio of the mid-sagittal diameter of the spinal cord at the compression site divided by the average diameter of the spinal cord at the non-compressed regions above and below. We used the lower extremity motor score as an objective way to quantify the neurodeficit. We performed a laminectomy with or without instrumentation in patients with progressive worsening of neurology, involvement of sphincters, inadequate response to chemotherapy, and those with a static significant deficit. This is a 13-year-old female. She had a D1 epidural abscess. The MSCC was 0.53 and the LEMS was 0. We managed this patient with laminectomy followed by fixation at C7, D2, D3 using pedicle screws. The LEMS improved to 40 at 1 year follow-up and she did not have any spasticity. This is a comparison between the preoperative and the postoperative MRI of the same patient. This is a 14-year-old male who had a D3 to D6 epidural abscess. The MSCC was 0.66. The LEMS was 42. The patient was managed with a CT-guided biopsy followed by AKT. The LEMS improved to 46 at 1 year follow-up and he did not have any spasticity. This is the only case in our study which showed a worsening of the neurology. She was a 15-year-old female. Though she had an anterior subligamentous collection from D2 to L1, it was the posterior D7 to D9 epidural abscess which was causing the cord compression. She had a MSCC of 0.42. The LEMS was 40. The patient was managed with a CT-guided biopsy followed by AKT. Drug resistance was detected in the samples, following which second-line AKT was started. However, the patient defaulted after 3 months of chemotherapy. The LEMS was 20 at the latest follow-up and she had a grade 3 spasticity as per the modified Ashworth scale. We had 3 males and 7 females in our study. The mean age of our patient was 22.3. The mean MSCC was 0.5. We performed decompression in 8 patients, out of which 2 required additional instrumentation. The mean LEMS score on admission was 20.2, which improved to 38.5 at the end of 1 year. The postoperative spasticity was seen in those patients in whom the time interval between the onset of neurological deficit and initiation of management was more than 6 weeks. The LEMS score showed a significant improvement after 3 months of treatment when the time interval between the onset of neurological deficit and initiation of management was less than 6 weeks. To our surprise, the MSCC ratio did not have a significant relationship with the postoperative LEMS scores. One patient in our study showed a worsening of neurology on follow-up as discussed previously. One case had an intraoperative dural tear due to extensive adhesions. The limitations of our study were the limited sample size and the retrospective study design. However, these cases are rare in occurrence. Spinal epidural abscess secondary to tuberculosis has a relatively good prognosis if treated adequately and in a timely manner. AKT remains the mainstay of management. Surgery is reserved for those with neurological deficit. As per a study by Rathod et al., preoperative neurological status was found to be the most significant determinant of postoperative neurological outcome in cases of tuberculosis of the spine. We also found a significant association between the preoperative LEMS score and the satisfactory recovery. In our present study, the time interval between the onset of neurological deficit and initiation of management was the single most important predictor of postoperative neurological outcome and spasticity. The MSCC ratio did not have a significant relationship with the LEMS. The most probable reason for this would be the gradual compression occurring in our patients and the adaptation of the cord to the slowly developing compression. To conclude, when managing spinal epidural abscess, clinical evaluation and regular follow-up is of significant importance. Conservative management should be offered initially to the cases with intact neurology. Management decisions should not be based solely on radiological findings. and management should be initiated as early as possible in order to achieve a good functional outcome. Thank you.
That was also a very nice talk. Were all these cases TB, or there were other infections as well?
Good evening, sir. Sir, all the patients had microbiologically detected tuberculosis, mycobacterium tuberculosis in the samples.
Okay, so they're all TB patients.
Yes, sir. Yes, sir. All were tuberculosis patients, sir.
TB generally has the ability to respond very well, not only to the decompression, but also the anti-TB medication. What it does is it reverses the vasculitis that is caused, and that which also adds to spinal cord damage. But that's, the earlier you decompress, and your pre-op neurology,
yes,
even for spinal epidural hematomas, that's
yes,
the thing. The earlier you decompress and what the pre-op power is what actually determines the final outcome.
Yes, sir.
Thanks so much for this wonderful talk.
Thank you, sir.
To Kunal.
Yes, sir. So our next speaker is Dr. Sachin Kandagatla, who will present a case of dorsal compressive myelopathy secondary to spinal epidural angiolipoma. Yes, Sachin.
I am Dr. Sachin Kandagatla, presenting a case report on dorsal compressive myelopathy secondary to spinal epidural angiolipoma. Spinal epidural angiolipomatosis is a atypical benign tumor of the adipose tissue with abnormal vasculature that causes spinal cord compression. They usually account for 0.14% of all spinal axis tumors. They usually arise in the epidural space and, unlike lipomas, do not exhibit age or sex bias. The symptoms of spinal angiolipomas usually appear gradually because of the progressive compression of the cord. These patients present with back pain, unstable gait, paraparesis, and paresthesias of lower limbs. Sometimes symptoms can rise rapidly because of intratumor hemorrhage and venous thrombosis. Most spinal epidural angiolipomas have a good prognosis after surgical resection. Epidural angiolipomas can occur in female more than males and usually occur in the age group of 40 to 50 years. MRI is an important diagnostic tool for detecting and characterizing spinal angiolipomas. Angiolipomas are ultimately diagnosed by histopathological examination of the removed lesion following surgery. A 30-year-old woman presented with progressive weakness of lower extremities evolving since 6 months with onset of urinary incontinence. There was no history of corticosteroids or hormonal therapy. There was no history of any trauma. On examination, she was spastic with motor grade 3 and a sensory level of D2. CT and MRI scans were suggestive of intracanal space occupying lesion located in the posterior epidural space extending from T2 to T9, showing hyperintense fatty tissue on both T1 and T2 sequences which were trabeculated by vascular elements. Preoperative MRI showing angiolipoma lesion in the T1 wetted image. She underwent total resection of the tumor after total laminectomy from the T2 to T9 level. Microscopically, the reddish soft tissue mass was easily cleavable from the durameter. Histopathology revealed mesenchymal proliferation made of mature benign adipose cells associated with a network of small vessels, and the findings were suggestive of angiolipoma. Post-operatively, the patient neurology improved by grade 1 with reduced spasticity and early improvement in the bladder function. The histopathology slide shows angiolipoma. There was significant improvement in the VAS and ODI scores at 6 months follow-up. No earlier delayed complications was noted. Histopathology was suggestive of angiolipoma. There was no evidence of clinico-radiological recurrence was seen in the latest follow-up. Conclusion: spinal epidural angiolipoma is a rare cause of progressive spinal cord compression. MRI is necessary for diagnosis, and the treatment consists of complete excision of the lesion, which results in excellent prognosis. The patient should be regularly followed up so that the recurrence can be detected early and can be managed accordingly. Thank you.
Yes. आवाज आ रहा है?
Hello. So can you
Hello,
hear
yes,
now,
sir.
Sachin?
Yes, I can, yes.
Yeah. So is there any preoperative way of diagnosing these rare tumors because there is some vascular component, and any change of plans accordingly?
Only MRI was a diagnostic tool because in other way we didn't find anything which was helpful.
Okay. So is there any role of preoperative DSA in this case because there is some vascular component which will minimize the bleeding intraoperatively, or any technical tips intraoperatively we should do for these cases?
No, sir.
Okay, fine. Thank you. So we move on to our next question. Next speaker, who is Uday Kumar. He'll present on comparative study of TrueNat MTB RIF assay and MGIT culture in testing different types of spinal tuberculosis tissue specimens in T Ward, Mumbai.
Good evening, everyone. I am Dr. Uday Kumar. Today I am going to present a paper on the comparative study of TrueNat assay and MGIT culture in testing different types of spinal tuberculosis tissue specimens in T Ward, Mumbai. According to WHO, in 2020 report says that there are 10 million people globally contracted with tuberculosis. Of these, 10% are rifampicin-resistant tuberculosis. In this, 27% of the burden taken by the India. Early diagnosis and determination of drug resistancy to promote effective treatment and decreases the drug resistance. The sensitivity of AFB line probe assay and other nucleic acid amplification test is low in extrapulmonary tuberculosis because the bacterial load is very low in extrapulmonary tuberculosis. Although MGIT culture is the gold standard, but its time consuming, it takes 3 to 6 weeks. The sensitivity is around 10 to 60% in extrapulmonary tuberculosis. So WHO recommended gene expert as an investigation of choice in extrapulmonary tuberculosis. Here I am showing the flowchart how to do the gene expert. The test results will come within 1 hour 45 minutes. But there are some advantages that it is rapid and consistent, but there are so many disadvantages because shelf life of the cartridges lasts for about 18 months. For this, we need to stable electricity. The temperature of the room is very less. The cost of the instrument is very high. Instruments need to be recalibrated every year. So it's difficult to establish in endemic countries and developing countries. So the big tech laboratories in India developed a TrueNat device. It is portable, point of care, rapid, automatic, battery operated, and less expensive. The accuracy of these PCR-based molecular diagnostic technique depends upon the type of the specimen and the bacterial count of the specimen. It is necessary to compare the positive rate of the bacteria in different types of tissue specimens in this region. Our aim of the study is to compare the sensitivity and specificity of bacterial culture and TrueNat test on different types of spinal tissue. Our study is a multi-centric retrospective study done in 2 tertiary case centers from January 2016 to August 2021. In our study, 198 patients are involved. There are 426 specimens we obtained either through CT guided biopsy or fluoroscopy guided biopsy. I am showing the flow how we will perform the fluoroscopy guided biopsy. Our results was that out of 198 patients, 86 patients are positive with culture and 145 patients are positive with TrueNat. In 86 patients, the sensitivity of TrueNat is 95%. In culture negative 112 patients, the sensitivity of TrueNat is 56.2%. When compared with specimens, first will give higher culture positive and higher TrueNat positive. The TrueNat positive is around 72.7%. The p-value is very low. It is significant. Whether in granulation tissue also, the culture positive is around 47% and TrueNat is 64%. It is also significant. Whether in bony tissue, it is 35% and in culture and 41% in TrueNat, but it is not clinically significant. There are similar studies done by the Ling Tang et al., but they are done between the gene expert and culture. The results are high coordinates with our study. So our conclusion is early detection and treatment is the only strategy to prevent in spinal drug resistance in spinal TB. TrueNat is a promising technique. This technique is a point of care, battery operated and less expensive chip-based RT-PCR micro device. First specimens will give more accurate diagnosis when compared with other type of specimens. So we recommend TrueNat is the investigation of choice in all the patients who are suffering with tuberculosis. Thank you.
Yeah, hi. So it was a very good presentation. I just wanted to ask you a question. Is there any, so what are the false positives or false negatives of this TrueNet assay?
Sir?
What are the rates? What are the rates of what are the rates of false positives or false negatives in this TrueNet assay?
The false positive, it is around 30% in TrueNet false positive. 30% in our study.
Okay. And what is the so are there any comparative studies in the literature comparing TrueNet assay with the standard gene expert which we do? And
Sir, there are so many studies. There are so many studies comparative studies with the gene expert and TrueNet, sir. But the rates are similar. The rates are similar with other studies also.
So the newer test is called as. So are there any studies comparing TrueNet with Ultra Gene Expert which we have right now, currently which we use?
No, sir.
Okay.
This TrueNet is widely available everywhere in all labs, or there are specific places that do it?
TrueNet is available in major cities like Mumbai and Delhi, sir. It's not available in everywhere, sir. Because it is less expensive, we can establish this TrueNet in everywhere. It costs around less than 5 lakhs. Whether for gene export it costs around 20 lakhs, but infrastructure also we need to. It is more expensive, but gene export.
Okay, great.
It is easy to establish TrueNet.
I think we'll probably start doing it and seeing what the results are and comparing it with the standard tests that are available. Thank you very much for that talk. Thank you very much to all the speakers. With that, we finish this part of the session. Kunal, do you have any questions for anybody or any concluding comments?
No, sir. It was so all the cases were different and different topics were covered. It was very well conducted and very well presented.
Thank you very much. We'd like to hand over to Satyen now to take the conference further. We've finished just 1 minute before our proposed time. Thank you very much.
Thank you, Mazda. Thank you, Kunal. Please do stay on for the next sessions as well, as your inputs will be most appreciated. And you'd give the opportunity to all the delegates to learn from your experience as well. First of all, I want to congratulate all the speakers, the young Turks, the upcoming spine surgeons, for presenting some very good papers. This is just the beginning of your journey in most cases, and I encourage you to continue doing scientific pursuits so that you may go on improving and getting more and more knowledge. Even we are learning new things from some of the papers being presented. Now, for our next session, we are going to be discussing degenerative scoliosis. Now, as we are dealing with an aging population, this problem of further osteoporosis and then further degeneration and then further scoliosis is becoming more and more common. And there are a lot of complications in dealing with them, and all these patients, they are, have started demanding a better quality of life, more mobility with better cardiovascular treatments available. These patients are able to be more active, and so they are also demanding, more for better treatment, improved treatment, so that we are able to, treat them better. So the treatment for them is a very wide range of treatments are available, where we have medication to help these osteoporosis and degenerations. We have got pain management techniques as well, and finally we have surgical techniques in which we can do corrective treatments. I have Dr. Nikhil Arbati with me, who is going to be moderating this session. We have a few minutes extra, so I'm going to pick his brain and ask him questions about scoliosis. In these cases with degenerative scoliosis, there are a lot of parameters that go into, you need to see a lot of things before you decide on the right method of management. Are you looking at radiological parameters, more than actual clinical parameters? What is your take in these patients?
So, Satyan, thank you for giving us the opportunity to moderate this session. So, I basically feel that the clinical parameters, looking at the patient's entire mental framework, what is his economic background, that all makes a big difference on deciding the line of treatment for adult degenerative scoliosis. Because looking at the literature that we have and even the scientific data, there is no one sure shot method to treat an adult degen scoli. I mean, there are people who would advocate to go for only conservative line of management, looking at the age and how the bone quality can be. There are people who would say that we can try some pain management if it's just some pain which is intermittent. And then we have people who say that we should go for a minimal invasive treatment, or people who say that we should go for a complete instrumentation along with decompression at multiple levels. So there is a lot of methods to treat it, but there's no one sure shot method. So I look at the clinical parameters, what is the patient's mental framework, what all things he has undergone before, and what is his main economic this thing, like the patient is working or this thing, and then plan out the line of treatment. What about you, Satyan?
I agree with you. There are so many things we look at before we actually take them up for surgery. We have a very good talk about when not to do degenerative scoliosis corrections, which is going to be taken by Dr. Ranjit. Hi, Dr. Ranjit. Thanks for joining us. As one grows older, this is a learning curve of maybe experience, that when you start off, you are very enthusiastic about operating on everyone. And as you learn more and more, you are able to then see which patients are actually going to do well with these surgeries and which are not going to. So you start refining more and more. And so we are going to discuss about when not to do this, but I want to just check about when sure shot would you want to operate on these patients. One of my indications is, number one is chest, when there is going to be a respiratory compromise. And that is one condition where I sure shot go ahead and start advise surgery for these patients. Maybe another one is where they start getting a lot of neurological complications, where the cord starts getting compressed, and where because of maybe a kyphosis or increasing kyphotic deformity, kyphoscoliotic deformity, where we need to then think about correcting them. The other is when they are so debilitated with pain that they are unable to mobilize at all. And so that is when we want to think about operating on these patients. Now, other than this, what is your other indication? Where do you want to take these patients up for surgery? Dr. Ranjit, if you are here, if you can answer this, or otherwise Nikhil.
So sure shot, if what we look at the MRI picture, and if there is definitely a neurological weakness happening and the patient has tried conservative line of treatment and it's a worsening, then that's a sure shot where I would go for a surgery. But apart from that, if it's just a radiating pain which is intermittent, which comes and goes, and which patient has come to you with the episode where the pain is at the high, but there's no neurological deficit, I would still go for a conservative line of treatment, maybe with the pain management. And then if that does not get better in this episode of pain, then go for a surgery. But a sure shot is only when the patient comes to a neurological deficit or weakness.
Neurological deficit is number one in your list where you would want to operate these patients. That is a very, obviously, that's a sure shot red flag. Yeah. Yes, go ahead. You were saying?
Yeah, and if the patient has been under my treatment and my care for maybe a considerable period of time, say 3-4 months, and has not improved with all my methods of conservative line of treatment and is now willing to go for a surgery, then that is the second option where I would go surely for a surgery. But then explaining what can be the pros and cons and what I would prefer to do, and maybe if they want a second opinion, take it and then go ahead with it.
How about for patients who have got some pain, not completely debilitating, but if it is an increasing deformity, and over the last 1 or 2 years, if the kyphosis has started increasing more, is that something that you would want to operate on, if preempting that there is going to be a deficit and you want to correct it, or preempting that now the mobility is going on reducing and you want to correct it, or would you want to still wait and watch in these patients?
So the reason why the deformity is increasing is one thing that you need to watch. If it's some lytic listhesis which is increasing, maybe because of an osteoporosis and all, then maybe you can try to correct it and the osteoporosis and then go for an instrumentation. I mean, you should first try to find out that what is the reason why the deformity is increasing, I would say. Because we have patients in their 60s and 70s who have weak bones and who are either diabetic or obese and all. So any of these parameters which are not controlled and which is causing the osteopenic component or osteoporotic component to increase the deformity, I think that is what needs to be a addressing part. If the, as you said, the disability is not so severe, and then think for a treatment.
Yeah. So that's a very good point that you made about osteoporosis, and we have seen that if we do a good medical management for osteoporosis, very often you are able to treat them with non-surgically as well. And here I would like to add that teriparatide has been something which has been a very important tool and a very useful tool in treating these patients. And with teriparatide, we are very often able to correct the progression. We are able to stop the progression of disease. What is your opinion on medical management? Teriparatide included, or do biphosphonates and all also help?
So if it's an osteopenic, then maybe you can try only with bisphosphonates and calcium. But then you also have to look at what is the FRAC score and what is the patient's age. If the patient is somewhere around 65 plus, 70 plus, then maybe you can even give a teriparatide course, a short-term 6 months, to see if he improves with it clinically. Because I have in my practice seen that sometimes when you get those 75 plus who are not someone who would want to get operated, and you have tried with all medical management with medications and they want something better. So that is basically, we would go for a teriparatide or this thing management in those.
Great. That's a very good point again. Now, why are we again talking about non-surgical managements when so many good surgeries are available? What is the major complication or what problem that you see with operating on these patients?
So that is because the thing is that I don't think so that, as I said beforehand, that you have any sure shot treatment which will be giving you a complete resolution of symptoms. It's not like a disc surgery or like a listhesis. If you have a L4-5 degen listhesis and you know the symptom is only at one level, and you can operate at that level, decompress and get a complete resolution of symptoms. So the patient has come after initial line of conservative treatment. In those, I mean, whatever I have, I mean, we have got a very good panel today. We have got Samir Dalvi sir from BSS, we have got Ranjit, we have got Dr. Gibson, we have got Dr. Lee, both have joined from UK. I think they can give a better insight that what works better in a surgical line of treatment. For my, I think being a novice, I would say that looking at everything, what works best.
So as you discussed, as you said, Nikhil, while you're on freeze, I'll go ahead and say, okay, this basically this surgery is a back pain surgery. If we are talking about leave out the neurological deficit, leave out the respiratory compromise and operating for those issues, the rest of it is back pain. And when the patient comes to you, they come with back pain and they want an improvement in that. And if you are not able to provide a good improvement in that, then they are always unhappy. And so the result for relieving back pain in these degenerative scoliosis or degenerative kyphoscoliotic deformities is very unpredictable. You're not going to be 100% in giving them good relief, and maybe even if you are able to give them, it's not going to be a full relief. So that is why we are always skeptical, and we don't want to jump the gun and start operating these patients. Since we have our esteemed foreign faculty, Dr. Alex Gibson, Dr. Robert Lee, if you are around, we would like to ask your views as well before we start the session formally. What problems do you encounter in these patients, and whether you want to, how often do you try conservative treatments before you go on for surgery? If Dr. Samir Dalvi also can join in. Yes, Dr. Gibson.
Hi, Sachin. Good morning or afternoon where you are. I have to say, we always try conservative management before we consider surgery, because the biggest problems, the biggest complications you have are with post-op complications rather than with complications because of the original pathology. So you're absolutely right. Osteoporosis is one of the biggest issues that we have, and it's very difficult to manage them. And I will turn patients down if they are too osteoporotic and they don't have good bone stock. Then surgery is going to be a failure unless you can improve that with your medical management or augmented screws. But occasionally it's just precludes surgery and you have to say no to people.
Thank you, Dr. Gibson. Welcome, Dr. Lee. Your views on osteoporosis, and is that the main problem post-operatively that you encounter in degenerative scoliosis?
I have to say that I mirror Mr. Gibson's comments. I refuse surgery for patients who are severely osteoporotic, because essentially it's a difficult enough and complicated surgery as it is, and you're just simply going to end up with more complications afterwards. If you're forced and you have no option at all, then I try and limit the surgery to just those levels which are most symptomatic and causing neural compression. But otherwise, I stay away from that. And obviously, if they are osteoporotic and you have to do something, then I send them to the rheumatologist for optimization as much as possible prior to surgery.
Thank you, Dr. Lee. Dr. Nikhil, I hand over to you. Dr. Nikhil Arbati is an esteemed member of our Bombay Spine Society. He is a spine surgeon here in Mumbai, and he will be taking over the proceedings for this session. Over to you, Nikhil.
Thank you, Satyan, and thank you to BSS. Let me see if my co-moderator, Samir sir is there. Hi. So that's the beauty of this virtual conference, Satyan, that Samir sir is officially joining 2 conferences, but unofficially is having a beer in his hand, is watching Netflix. And same thing is what Ranjit is doing. So without further this thing, we have a very good panel here. We have got Samir sir from the Bombay Spine Society. We have got Ranjit from Kerala. We have got Dr. Gibson and Dr. Lee from the UK joining us. A very interesting topic that we have, the adult degenerative scoliosis. A lot of doubts, a lot of questions, and some answers hopefully we can answer today. So if we have the talks, Samir sir, should we go with the talks first?
Yeah, I think let's do my recording first.
Yeah, we have your, can we have Samir sir's talk? The technical team.
Significant stenosis or radicular pain, back pain, who are definitely not fit, is a very, very complicated matter. Definitely cannot be finished in 10 minutes, but I'm going to try to give a brief overview. So patients who don't have much significant stenosis or radicular pain, back pain, who are definitely not fit for surgery, smaller curves, and a reasonable balance, they are better off not being treated surgically. And we use a combination of physical therapy, injections, and bracing to keep the patient as fit and active as possible. Surgically, broadly speaking, there are 3 options. First is a decompression alone without a fusion. Second is a decompression with a limited fusion, selecting few levels. Or finally, extensive fusion of the deformity with or without decompression. So a decompression without fusion would be for a patient who has only radicular pain with less back pain, and whose curve is less than 20 degrees, and whose spines are stable. So the lateral listhesis is less than 2 millimeter, and who have collapsing discs and osteophytes. So these are stable situations which may present with only root pain and can be treated selectively with decompression alone. Of course, if the spine completely collapses in the dynamic X-ray or there is instability, we cannot do that. And the long-term problem of this would be progression of the curve and reappearance or worsening of the symptoms. What about a limited fusion? This is very attractive. And these are patients who have leg pain but require extensive decompression at one or more levels. But for them too, the curve has to be less than 30 degrees and there cannot be a global imbalance. So that is for this selective fusion. How do you select? At the proximal end, you have to make sure that you are not ending at an area of subluxation or segmental kyphosis. And at the distal end, also you have to make sure as to where you're ending it. And if there is a stenosis at L5S1 and you have to decompress L5S1, then you may have to go down to the sacrum as well. And if there is a sort of other pathology like a listhesis or a pars defect, again, you may need to go down to the fusion. So the only problem with limited fusion is accelerated degeneration and deformity at the other levels. What about fusion of the entire deformity? If the patient has more of back pain, larger curves, more than 45 degrees, loss of sagittal balance and subluxation, these patients probably need a more extensive fusion. Of course, if you were to read only one thing, I would suggest you read this paper by Lenke and Silva, who have given both a classification and a treatment protocol. As I mentioned in the beginning of my talk, each case is individual based on multiple factors, including their physiological age and bone stock. But if you want to generalize, then this is one way of generalizing it, at least for the radiological point of view. So basically, they have said that there are 6 levels of operative treatment. The first is decompression alone. The second is decompression with limited posterior fusion only of the decompressed. So that's a limited fusion. The third onwards are all extensive fusions. So third is fusion of the entire curve. Fourth is anterior and posterior fusion. Fifth is not just fusion of the lumbar curve, but extending into the thoracic. So that is you're fusing the entire, almost most of the spine. And the sixth includes procedures such as osteotomies. So how does this work? We look at these factors. Basically, we look at neurogenic claudication, radiculopathy as the symptom. We look at back pain. So whether it's root pain, back pain, which of the two. We look at the x-rays to see if there are stabilizing osteophytes. Is there a listhesis, an O listhesis or a lateral listhesis? We look at the cob, and 30 degrees seems to be the cutoff mentioned by these gentlemen, a lumbar kyphosis and a global imbalance. And accordingly, we look, if the patient has minimal symptoms, obviously it's non-operative management, but surgical management of level 1, which is a decompression alone, would be used for patients who have only root pain with minimal back pain, good osteophytes, and no listhesis or kyphosis or imbalance. Level 2 surgery, which is a decompression and a limited fusion, would be for patients who have all of this, but also have back pain and less anterior osteophytes. But they again cannot have a lumbar kyphosis or a global imbalance, and the coronal cob of 30 degrees is the cutoff. Level 3 surgery is where you fuse the entire curve, but only with the posterior fusion. These are again patients who have claudication radiculopathy plus back pain with less of stabilizing osteophytes, who have a listhesis and a cob more than 30 degrees. But if they have a lumbar kyphosis or a global imbalance, then just this simple posterior fusion may not be enough. And we then go to a level 4 surgery, which includes an anterior column reconstruction. Because if there is lumbar kyphosis, you have to correct the kyphosis into lordosis. And if you do so, the anterior column has to be fused and reconstructed either by a TLIF or nowadays by OLIFs. Coming to a level 5 surgery, which includes fusion of the entire spine, even to the thoracic curve. So if they have all of the indications to do a level 4 surgery, but they also have a global imbalance which can be corrected, then you may have to fuse the thoracic and the lumbar spine, because achieving spinal balance, both coronal and sagittal, respecting the pelvic parameters, becomes part of the surgery. And finally, if they have a global imbalance with a stiff or a fused spine, these patients then need osteotomies as well, and that becomes a level 6 surgery. So let's look here. A level 1 surgery is a decompression alone. Patient with a minimal deformity with just root pain and good anterior osteophytes can be considered for this treatment. But of course, the disadvantage would be a progression of the deformity and a recurrence of the symptoms. A decompression plus a limited fusion is a good option for a patient with claudication, minimal back pain, but a COB of less than 30 and no O-listhesis with no lumbar kyphosis and a decent global balance. But these may then progress later on. So this is one of my patients, which was, as you can see, a COB less than 30 and was treated with a limited decompression and fusion. Or level 3, which is the entire lumbar curve fusion, are for patients who also have back pain and who have listhesis more than 2 millimeter and a COB more than 30, though they have mentioned 45 here. So these patients, as you can see in this X-ray, requires a fusion of the entire curve. And this again is a patient of mine with a much larger curve and a lumbar kyphosis, and this patient required entire curve fusion. Level 4, which is anterior and posterior surgery, are those who have larger COBs, listhesis, but who have a lumbar kyphosis. So anyone having a lumbar kyphosis for the correction of the sagittal deformity, the sagittal plane deformity here, needs to have an anterior fusion as well, because that's the only way that the lordosis will be maintained. Level 5 surgery are those who have global imbalance but flexible. So they have lumbar kyphosis as well, but more important is that they have a global imbalance which can be corrected, in which case an entire spine fusion is required for them, thoracic plus lumbar, to correct their sagittal and coronal balance. And the last one are those who are globally imbalanced but stiff, and they don't have good correction on the side bending films. They need osteotomies in addition to all of these procedures. So osteotomies plus anterior reconstruction and of course decompression as well. If you look at sagittal imbalance as a modifier, which again becomes very important, there is the type 1 and the type 2. Type 1 is a globally balanced spine with just a flat or a segmental portion of flat or kyphotic spine, whereas the type 2 are globally as well as segmentally unbalanced spine. So the options here are osteotomies because they are stiff, and you can have simple Ponti's osteotomies, which are posterior based osteotomies like a chevron, which are closed, or a PSO, which is a 3-column pedicle subtraction osteotomy, or sometimes PVCRs, which are more extensive. So if you have a type 1 sagittal imbalance, which is a globally balanced spine, so the whole spine is globally balanced, but a small segment is flat, you can correct it just by doing segmental Ponti's osteotomies. But if the imbalance is more, it's a type 2 imbalance, which means that the spine is also globally imbalanced, you may end up, depending on the level of deformity, having to do PSOs or then PVCRs. Finally, like I said, there's a lot of nuances, a lot of thoughts, because all of this ignores things like this was a theoretical discussion. It ignores things like the physiological age of the patient, the physiological status and the frailty, the bone stock and osteoporosis, and many, many other factors, including the patient's acceptance, tolerance to surgery, and has not spoken at all about the long-term results with these, which are fraught with problems. Hence, my own experience in 22 years of practice is that I shudder when a degenerative scoliosis walks into my clinic. And no matter what you do, whether you conserve, whether you decompress, whether you do a limited fusion or an extensive fusion, the result is bad and the patient is unhappy. So I'm really sorry to give you such a negative view, but degenerative scoliosis truly has been my Waterloo in spine surgery. Thank you very much.
Yeah, thank you, Samir sir.
So I think let's go ahead with the talks so that
Samir sir,
the next talk so we can have discussion and case discussion at the end.
We have ample time actually because we are on time. So just one question. Sure. As you said in that talk, you said that more likely to look at the physiological mindset and to go ahead with limited decompression. So is that what generally practice would do, that to conserve as much as possible and go only for a limited fusion if required?
No, it depends on what the case is. See, eventually you also want to deliver a result. But the point is that, you can't be over-aggressive. You cannot be over-aggressive in these patients, and you have to tailor it to their physiology, their lifestyle, and their expectations. We can't only look at X-rays, MRIs, and we can't look at foreign papers and foreign, when you go abroad, you see a huge bunch of these patients who do surgeries again and again. Our patients don't like and tolerate that. So you have to solve their problem. So sometimes a patient with a very bad looking X-ray and a CT and an MRI may actually have only L5 leg pain. So if you can just relieve that by a block or by a limited decompression, that would work for them. And they're used to having that little coronal imbalance and that little stoop. They don't mind it.
Right. So it looks more of a theoretical what we have, but looking at the physiological.
That's right. So degen scoliosis, if you go internationally, I just came back from Paris, and you just see revisions after revisions after revisions.
Yeah, that's
Which our patients would never forgive us for even the first revision.
They would never. Yeah. Agree. So I think going ahead with this, I think we have Dr. Ranjit, who is going to give a talk about when not to do a surgery in a degen. So Ranjit's talk is going to be very interesting, because that is one thing like all of us should look at when we should not operate. And then we have the other two interesting talks. So Ranjit, if he's there, we can just ask him to have his video, the technical team.
Very good evening to you all. Thank you very much, BSS, for this invite. So this 64-year-old female with untreated adolescent idiopathic scoliosis presented to me around 11 years ago with intractable back and leg pain and significant difficulty in activities of daily living. At that point of time, we went ahead and did her correction of deformity along with facetectomies and intradiscal releases, and this was her post-op X-ray. She's on follow with me and present developed this after 9 years. She has not undergone a revision. She comes to me. She's quite happy and almost independent at around 75 now. Compared to this patient who was again in her 70s, came with this coronal and sagittal malalignment with significant back and leg pain, where then I went ahead and did this T4 to S2AI fixation with again intradiscal releases, facetectomies, and I thought I did a good job. She's very well balanced. She comes to me every year and is extremely unhappy with the surgery. I don't know what went wrong. So this puts a question in adult spinal deformity, when to say no. So at the outset, let me declare, I really don't have an answer. It's my perspective of this question. Individual opinions across the nation or across the world might change. So we have to consider multiple domains when we come to this situation. The most important is the patient domain. When you look at the deformity domain, the economical domain, which is of utmost importance for us, because these are people who might or might not have a medical insurance, or even if they have them, it might not cover their complete cost of treatment, along with post-op family and social support, which is equally important in the Indian perspective. And most important, the treatment expectations from the patient. So what exactly is our perspective or our look on this? So in these situations, we have our decisions can essentially be data-driven. Now, when we look at these data, essentially from the Western or the Eastern world, and they might not really parallel our expectations or patient population, and or we could have our own personal data, or it could be kind of level 5 evidence. And most important, the willingness to accept a revision surgery and the patient's expectation from the surgery. So there should not be a mismatch between what you offer what the patient wants And a lot depends upon your practice settings. Are you into an institutional practice? Are you into a group practice? Are you a one-man show? And what is your support systems in your practice? A lot of this decides as to what you do. This is another very pertinent question which I ask myself, or you should ask yourself. Who will benefit from the surgery? Is it the patient? Is it the family of the patient? It's not very uncommon to have a family, a kind of nuclear family where the earning members goes to work, or they essentially want the patient to be ready as much independent as possible. You should be very careful and cautious when you take up these patients, because they really might not be wanting surgery. Or is it the surgeon and the team for obvious reasons? Are you really keen on doing it? Do you want to make that buck because of doing a deformity surgery? Trust me, it is not worthwhile if it is for making the buck. And or is it to get data, or is it to support science? So on the deformity domain, we all know this, that how the spine ages and what happens in our 50s and how we end up in. And this classic paper from the ISSG, which said that the deformity is not the driver in these elderly patients, it is the pain, whereas the deformity is a driver for a surgical decision in a heterocerebral scoliosis. And these data that decent spines may progress at the rate of 3 degrees per year, whereas which is not the case in case with the adolescent spines. Now, when we come to this should come to a notice that look at the extreme amount of complications, up to 40%, meaning around 1 in 3 of your patients will end up with a complication because of deformity surgery. Is it really worthwhile to go for it? These are the spectrum of disorders which we think when you think about adult deformity, degenerative kyphosis or scoliosis, and exactly what are we treating? Most of them have got stenotic symptoms. 50% of them have got back pain, and a vast of them have got a curve of around 30 degrees. Most of them have got lateral listhesis. Around half of them have got a flat back, and a lot of them have got sagittal imbalance. So we are trying to tackle each of these when we think about treating this deformity, the central and foraminal stenosis, along with the extrafemoral stenosis, and the sagittal deformity and the curve angle. Now, the patient and the family domain. So we make sure that we have multiple visits. We should get to know the family and the person as to why they really have to undergo surgery. It's not uncommon for me to see a patient who was to undergo surgery because they want to have their kids who live abroad with them. And the only way to get them is to have a surgery or something major. And I really had one of the patients who was not getting better after the best of my efforts. And I know that she wanted her son to be here, who was not living in the country. So beware of that. And you should check them through this vast preoperative optimization. And we have a peer support group where we have a collection of patients who undergone surgery, and they talk to each other. I get them to see these people and let them explain that do they really need the surgery or are they happy about it. So we all know about the Seattle Spine Protocol, which we follow in our institute. And we strictly have this NSQ surgical risk calculator, which once you select tells us exactly as to what to go through. What are the percentages? It makes sense when you talk to these patients as to what are your expected risk of cardiac complication, your expected hospital stay, return or readmission, pneumonia, etc. So I use this effectively to speak about my complication possible in a particular patient. This tells your patient's particular risk compared with the average risk and what are the chances of outcome. So it's a lot useful to use this tool in your practice. It's a free web-based tool. And when it comes to deformity domain, I use the MSDF by Bumaneni, the ISSG group, as to how I make a decision as to what to do, which class of deformity I follow. I will not go into the details because that is not the purview of this presentation. And I have, whenever possible, I try and use minimally invasive techniques in deformity corrections in adults. Could be A-leaf, D-leaf, X-leaf, combined, hybrid, staged, as and when the case demands. Because of that, I have gone over from these huge incisions to whenever possible to these small and minimally invasive incisions, which might be either staged or single setting as and when the case might demand. Why did I go over to that? Because we know that there's enough data again from the ISSG which tells that there is a significant reduction of post complication rate from 30%, from 60% to 30% when we have gone over to MIS techniques or hybrid techniques as compared to open. And we also know that they've got lesser blood loss and less hospital stay. So to conclude, I will say that adult deformity is a real challenge. Be very sure whom you are treating. Are you treating the patient's mind or the patient or the family? Set out your goals very well. Be very clear as to what to expect. Whenever possible, minimal invasive surgery is a very attractive option in these subset of patients, and I think you should get familiar with it and try and use it more often in your practice, because they've got significant post-operative decreased complication rate. And in that, I follow the ISSC guidelines. Today we have the MSDF2 by Dr. Momanini and team. And limited surgery is attractive too. Today, if you ask me, after 15 years of adult deformity practice, I try and do whenever possible into limited surgery, because that is more long-lasting as per me. And if attempting a minimally invasive, you should arm yourself with all these navigation, BMP, etc. Be very careful in patient counseling. Exactly know who you are treating, whom you are treating, and be very clear and transparent in telling no. And believe me, the revision is a truth. Thank you for your patient listening.
Hello, Dr. Lee, Dr. Gibson.
Yeah.
Nice. Yeah. So
food for thought. Yeah.
Food for thought. Yeah. So I would like to ask the Dr. Lee and Dr. Ranjit, what would be some criteria for which you would say that this degenerative scoliosis adult you definitely would want to operate? Which clinical criteria would say that no, this patient definitely would require a surgery and maybe conservative line would not work? Dr. Lee?
There's never a definitely for surgery. My criteria are that the patient always has to have leg pain, and that's the reason why we're doing it. I don't do it purely for deformity correction or for back pain alone. So that's the 100% thing that I expect of all my patients. There are other factors as well which I take into account, as been mentioned already, in terms of patients' wishes, family wishes, etc. And I likewise spend a lot of time counselling my patients to ensure I meet their expectations. So if it's just leg pain, I'll simply do a limited fusion, because that's all that they need.
So radicular pain or leg pain is one criteria for which you definitely think of an operative management.
That's a must.
That's a must. Okay. Ranjit, your talk was very good. So after having burnt your fingers and gone through so many cases, what would you say would be your clinical criteria for operating? Ranjit, are you there? Hi, Ranjit. I think his network is not there. Samir sir, so we heard about your talk, this thing. So would you agree that, Ranjit, I think it's online.
Yes, sorry, I'm doubling up with the ASSN also. Tell me, please.
So I would say, having burnt your fingers or maybe gone through so much experience of cases, what would you now say would be an absolute criteria for you to operate in an adult degen scoliosis? I mean, all your parameters that you mentioned are all fine, but when patient comes in your clinic, outpatient clinic, and with the x-rays, which
live with the back pain, and I can treat the leg pain with as less minimal thing as possible.
So back pain and leg pain both you would say, or only leg pain if it's more, like what Lee said?
So it's actually a bet between what you want. It's the better devil. Nothing is going to get better whatever you do, right? It's a matter of time. 15 years ago, I used to do more of T2 to S1, S2Is. Today, I do much less of that, because they are all good for 5 years. After 10 years, when you look at it, they really don't know, they ask them, they are fine. But eventually, the quality of life improves a lot for first 3 to 5 years, and they gradually deteriorate due to multiple reasons. So if today, today I try and see, I try and see what part of them is really disabling them. I ask them 5 times. So primary, I don't want to operate. That's what I'll keep in my mind. I don't want to operate. Then they say they want to operate. So what part you want to get better? So it goes on and off, on and off, on and off. And then gradually, somebody comes to a point in which that they will say, no, doctor, please make this part better. My leg pain better. I'm okay with the back pain. Then I think, can I do it minimally invasive? Why? Because that is the one which gives better immediate post-op results, right? So the patient say, I'm happy to live with the deformity. I've lived it for last so many years, right? I've got if you look at the X-ray, very grotesque looking deformed X-rays whom I just did an apical foraminectomy, did an apical fusion. So look at the X-ray, it looks horrible. Got a single level fusion at the apex of the kyphosis, but they're happy much because their leg pain has gone away and they would live with the back pain. So that's where today it's really tailor-made, like what Samir sir mentioned. I'll sit on it multiple times, try to know what exactly is getting it. So a good-looking X-ray is good for you on the day 1 post-op, not for the patient.
Right. So good insight.
I would, Nikhil, I would say disability, deservability, and desperation. So the first thing is the disability. It doesn't matter whether it's leg pain, back pain, or the coronal imbalance. If the patient is tremendously disabled by that at that particular point in time, because some young patients also do get degenerative scoliosis, and they may be terribly disabled. So the disability has to be a lot, because what we tell them is that we can make you better from this, and you may need revision surgeries, and some aspects will improve and some aspects will worsen. The second is deservability. Do they deserve the surgery in terms of their physiology, etc. And the last thing is the desperation, because the desperation is very important. Like he said, the patient should be asking you for the surgery rather than you asking the patient. Rather than you chasing the patient chasing you, multiple you get multiple visits, multiple blocks, etc. Not getting better. Okay, let's do the surgery.
Okay. So basically disability, desperation, and
deservability.
Okay.
And drive of the surgeon. And the surgeon's drive.
As well, drive.
Surgeon's drive is always there. So we have got 2 very interesting topics about the surgical aspects of degenerative scoliosis. We have Dr. Lee, who's going to tell about the minimal invasive ways to handle degen scoli, and you have Dr. Gibson about the open way. So shall we have Dr. Lee's presentation about the minimal invasive way first or the open way? What do you say, Samir sir?
Either. I think they both have made. Let's start with the MIS. Let's start with the MIS. Let's hear that.
Will you start with your presentation?
Yeah, we have a recorded presentation. Dr. Lee's presentation, please.
Yeah, please, Dr. Lee's presentation.
Hello, my name is Robert Lee. I'm a consultant spinal surgeon at the Royal National Orthopaedic Hospital in Stanmore in the UK. I'm delighted to be invited here today to participate in this debate. I'll be presenting my views as to why MIS deformity correction in adult degenerative scoliosis is really the way forward. Now, my colleague, Mr. Gibson, may well use the following arguments against me. He'll say that you don't get the same degree of correction with MIS surgery. He may even say that complication rates are not less, and that patients have the same outcome or worse than with open surgery. He may say to you that you don't get good fusion with MIS surgery and that it takes much longer. And you may even use the analogy and tell them to stop trying to paint the hallway through a letterbox. One thing I'll give to him, however, is that MIS surgery is not good for rigid curves. So when you do need a Smith-Peterson osteotomy or PSO, there is no substitute for that. But in the majority of cases, the curves are relatively flexible, or there is an ability to use some invasive techniques. The Vancouver group has published this paper back in 2012, and this was a 2011 Outstanding Paper Award at NAS. They showed that in adult spinal surgery, the incidence of post-operative complication was around about 73.5%, with a 13.5% risk of wing complications occurring amongst many other complications. They concluded that major spinal surgery in the adult is associated with a high incidence of intra and post-operative complications. And this is what you get with open surgery. Open wounds with pus-filled lakes require multiple debridements and vac pumps. This is not what you want to deal with, and certainly what you want to try and avoid. The goals of spinal surgery in any adult deformity correction is that of neural decompression, to establish or maintain sagittal and coronal balance, and to successfully obtain an arthrodesis. And I'll hopefully show you today that we can achieve all these three aims using a minimally invasive technique with less damage to soft tissue, respecting the patient's anatomy, faster rehabilitation and less complications, with probably better results. Now, we know when looking at the basic science that if you strip innocent bystanders and the paraspinal muscles, that you irreversibly damage them. There are multiple papers demonstrated here, and this quote from Gahanovitz in 1989 showed that every strength parameter tested, except for male isokinetic flexion strength, showed at least a 30% decrease when compared to normal values. And going back to basics once again, if I show you this picture and ask you where the deformity is, well, the deformity is actually in the disc space and not the vertebral bodies. And we know that removing the disc results in 90% loss of stiffness. And this is why we use interbody cages in minimally invasive techniques, to take advantage of the disc space and correct the deformity in this manner, via either minimally invasive PLIFs, T-lifts, laterals, O-lifts, or A-lifts. And the power of the interbody cages is to achieve an indirect decompression. This paper presented in 2014 at IMAS, together with a few of my own examples, show what you can achieve with multiple cages and the degree of indirect decompression you get from them. And you can see here the MRI appearances showing excellent restoration of foraminal as well as central stenosis. Another myth is that you can't achieve lordosis using MIS. And these are, once again, a few examples, and I'll try and disprove this as well later in my talk. Mr. Gibson may well say to you, well, there's nothing wrong with doing a PSO. Well, this paper by Brodkey's group in 2016 showed that there's a 21.5% risk of a major complication occurring, 31% chance of a minor complication occurring, and 23% chance of intraoperative complications, with 6% of patients having a neurological deficit, almost 5% of patients having a wound infection, and 5% having a perioperative death. They found that 33 of patients required revision surgeries after a PSO, and that blood loss was about 2.4 litres. So PSO carries massive complications. But what if I tell you you can do the same thing using a minimally invasive technique? By releasing the LL and doing ACR, you can achieve the equivalent deformity correction with probably 50% blood loss. And there are multiple papers out there which are showing that ACR is as good as PSO, with low complication rates, outcomes as good if not better, with less blood loss and shorter hospital stay. A variety of papers have also done systematic reviews looking at PSOs versus anterior lordotic cages. This review here looked at 11 papers with minimum 24-month follow-up and showed that PSOs had a higher blood loss, major complication, pseudoarthrosis, and dural tears. They said that multiple anterior cages were much more suitable in the older patient due to less blood loss, less major complications, and fewer revision surgeries. And another paper published in the same journal, this time from John Charles Oreck's group, looked at 524 patients with more than 4 levels of fusion and a 2-year follow-up, again showing that pseudoarthrosis is related to surgical technique. Anterior approaches with anterior support decreased the rate by 30%, whereas osteotomy and pelvic fusion increases rates by a similar amount. And you can see by using interbody cages, using 3D lamellar titanium, that fusion rates can be extremely high. In this series of patients published by our own institute, we showed that 99% of patients achieved a good fusion, even with multi-level cages. MIS techniques have been here around for a long time, and algorithms have been written to help guide us as to which techniques we can use depending on the degree of deformity. This MISDEF algorithm, which was published in 2018, is an example of that. If we take a class 1 case where there's minimal deformity, and this is a good example here, we have a 72-year-old gentleman here with an L3/4 foraminal narrowing and very much a focal scoliosis. You can see we don't need to strip open the muscles and do a big open posterior technique. A simple lateral cage here, which opens up the foramen by a small 2-centimeter incision, is all that you need. You get excellent results, good fusion at 12 months, and good recovery. If you have a patient who has a greater LL or PI mismatch, You may then wish to use multi-level cages. This is a 68-year-old lady here who has a 15-degree mismatch and a 53-degree cob angle. There's area side joints, and the MRI scan shows evidence of multiple levels of foramen narrowing. Here, you can use multiple cages to open up the foramen and achieve indirect decompression. This is exactly what we've done. Combine this with L5-S1 ALIF, and although we haven't completely corrected the scoliosis during the first stage, the leg pain disappears and the sagittal balance is restored. Which means that all you have to do in the second stage is a minimally invasive fusion from T10 to pelvis, with fusion augmented with S2I screws and bilateral sacroiliac joint fusions. Once again, you can see excellent restoration of pelvic parameters. And you can stretch boundaries even more with a worsening PIL mismatch. Again, you can use these techniques. This example here is of a 62-year-old lady with a 37-degree cob angle, a 53-degree pelvic incidence lumbar lordosis mismatch, and a 16-centimeter SVA with a very high pelvic tilt. Once again, severe femoral narrowing at multiple levels. And what we do here, again, is a multi-level OLIF technique and L5-S1 ALIF to restore the sagittal balance. Once again, the leg pain disappears just after the first stage. The MRI scan confirms good decompression indirectly, and you simply need to do a fusion posteriorly. This time we use an minimally invasive technique for the lumbar spine and a slightly more hybrid technique for the thoracic spine. But nevertheless, the majority of this is done minimally invasively. And once again, excellent post-operative correction with good overall outcome. So in summary, hopefully I've convinced you that minimally invasive surgery in adult degenerative scoliosis makes sense. The powerful correction tools with MIS antibody cages, which allow indirect decompression of the nerves, good restoration of lordosis, as well as sagittal balance. And you can also achieve a harmonious correction of lumbar lordosis by using the correct angle cages at the correct level. I've hopefully shown you that there are fewer complications with MIS surgery. There's less pseudoarthrosis, less revision surgery, and less blood loss. It simply all just makes sense. And Mr. Gibson will try and convince you otherwise. But I really do believe that the future of adult degenerative scoliosis surgery is via minimally invasive techniques. Thank you very much for your attention.
Yeah, thank you, Dr. Lee, for a wonderful talk. Samir, sir?
Yeah, Dr. Lee, thanks for this great talk. I noticed that you're using a lot of OLIF and ALIF techniques to get a better correction. What is your experience in that? Do you think that it works better than just doing it from all from behind?
Absolutely. Doing a multi-level anterolateral cages via an OLIF technique, there's very little blood loss compared to open. And you're able then to control the curve and, as I said, restore a harmonious lordosis. So I look at the type of curve the patient has and then put the appropriate angle cages in the appropriate places anteriorly. Posteriorly, the only way of actually achieving this is to do either SPOs or osteotomies, which for me it has to be an open technique, which carries much greater complications. So
you would get lesser blood loss in these patients. Is there also any difference in terms of post-operative pain if you're doing these via MIS?
The traditional thoughts were that if you did the lateral cages, you get problems with lots of thigh pain. That's why I don't do X-lifts. I go anterior to psoas. And therefore, the thigh pain afterwards is much less. In fact, you'll actually find that after you've done the anterior column reconstruction, a lot of patients actually refuse to have the second stage because their leg pain is gone. But obviously, if with multi-levels, you have to fix them posteriorly. So I find that it does take them about 6 weeks to really get them back on their feet again. But when they see them at 6 weeks follow-up, they walk into clinic and absolutely delighted.
Do you think that there would be a case in the future to do only an OLIF or something for these patients? As you said, that if they are better with that, then you don't need to fix them from the back.
Absolutely. If it's a single level OLIF, I will only do it from the front. I know colleagues in the US who do multi-level OLIFs for this as well, but they use BMP at every single level in order to establish a fusion as fast as possible, and that's the worry. One of my thoughts is to actually do a multi-level OLIF technique and use anterior rods as well to establish a fusion too. And I know there are systems in the market which allow you to do that as well. But that is indeed something which may well happen in the future.
Thank you. Over to you, Nikhil.
Yeah, Dr. Lee. So the anterior correction that you do through OLIF, the levels you choose from where you would get a harmonious correction, or you give a block before to decide which all levels to do an anterior correction?
So if there's a question as to whether or not you're not quite sure where the levels the pain is coming from, then yes, you do selective blocks to work out whether you need to do a selective fusion or need to correct the whole curve. The examples I've shown are where you have multiple compression, multiple levels, where the pain is coming from all those levels, and therefore they all need to be corrected. So that's one way of working out which levels need to be done. The other reason for choosing the levels is actually looking at the curve itself and how far you have to go up. So if you are going to do a full correction of the curve, you often end up having to do multiple levels, all the levels in the lumbar spine.
Mm-hmm. And the minimal invasive posterior, when you put the screws, how do you contour the rod if you're going from a thoracic? You contour that completely and then do a freehand? I mean, it's very difficult. If you have
yeah, so I was just saying for the MIS lumbar, that's definitely all MIS, but I don't find there's any point in doing MIS thoracic, because by the time you're doing the midline skin incision and trying to do it minimally invasive in the thoracic spine, you end up with an open wound anyway. So for me, thoracic is often always going to be open, but the MIS part is a lumbar. So you can't contour the rod and just place it in, and it's not an issue.
Yeah, that I agree. Okay. Yes, Amish sir. So you have any questions?
No, I think that's a very exciting and interesting talk. And probably, yes, MIS is a way forward to cut the morbidity, at least in these patients. I think they really, for them to tolerate these surgeries. But I think expertise is very important. And, if you're going to take too long with them. So I think probably the message to the junior should be you start doing MIS in the basic cases so that you can then extend it and go to the deformity cases where it would be much more challenging. So that's a great talk.
Great talk. Nice talk, Robert. Can we have Dr. Gibson? He's going to give the open method of treating the degenerative scoliosis, the traditional method. And if we can have his talk, Dr. Gibson is with us. We have his pre-recorded talk.
Hello, and thank you very much for asking me to speak. Many thanks to Sachin, my friend, for inviting me, along with my good colleague Robert Lee, to debate whether open or MIS, minimally invasive techniques, are best for adult deformity surgery. And I've got to take the view that open techniques are best. So let's get into it. And okay, so open surgery is best. MIS is a risk not worth taking. We're all familiar through our training. Most of us are probably orthopedic spinal surgeons. We're all familiar with principles of orthopedic fracture treatment, which is to provide stability, restore alignment, and respect the biology of the tissues to maximize function and gain solid healing. And the principles of deformity correction are very similar. We need to get stability, which is usually achieved through a fusion and instrumentation, either pedicle screws for posterior surgery or anterior instrumentation. We need to restore the alignment, both the sagittal and coronal balance should be maintained. Of course, sagittal balance is very poorly tolerated in adult deformity patients, whereas coronal balance is much better tolerated. And we need to respect the biology. We want to avoid things like infection. We want to optimize our patients, tell them to stop smoking, and we need to work out what's the best bone graft or bone graft substitute that we're going to use in order to achieve our fusion. And we want to maximize the patient's function, which in the spine perhaps means minimizing the number of levels we operate on and fuse. So what is minimally invasive surgery? Well, this is the first problem. Is minimally invasive surgery posterior surgery through stab incisions with percutaneous screws? Is it minimally invasive to do percutaneous screws but to fuse a longer segment than if one was to treat a problem through traditional open surgery using an anterior and posterior approach? Is minimally invasive surgery the same length of incision but using a muscle sparing approach such as the Wiltse approach to avoid the muscle stripping associated with traditional open techniques? Is it minimally invasive to use the anterior approaches which are common, such as the trans-psoas, often called XLIF, or the OLIF, anterior to psoas approaches? There's no agreed definition of what constitutes minimally invasive surgery, and this is half the problem. There's been a published algorithm for the management of adult deformity. This is from Praveen Mamanani's his publication, but it's from his group. And essentially, they classify them into three groups: a class 1, where they consider MIS surgery rarely requires a fusion or only a single level fusion; class 2, with an interbody fusion of the apex or the entire curve; and then class 3, which they consider not suitable for deformities are called class 3, not suitable for minimally invasive techniques, and recommend open surgery. This is an example that they give in their paper of a class 1 deformity suitable for minimally invasive treatment. And I'm struggling to see the deformity. This is the straightest spine I think I've seen this decade. This is one of their class 2 patients, and their pre and post-op views. And this is the class 3, which they consider open surgery for. So, I mean, I can't even see the deformity in the class 1 patients. Class 2 patients wouldn't get surgery in my practice. And for class 3, of course, we're recommending open techniques already. So I'm not saying let's do the biggest operation we can. That's not my point. We all want to minimize the collateral damage from surgeries, but we need to achieve the aims that we set out at the beginning of the talk. My impression is that MIS is often driven by the health insurance companies or the payers of the system, and it's seen as a driver to reduce length of stay, which is conflated as an indicator of quality. And I have a big problem with that. I don't think that this is actually something we should be striving officiously for. We want good outcomes. We don't want short outcomes. There's some recent evidence and a lot of minimally invasive papers that compare open versus minimally invasive techniques come up with a similar sort of conclusion. This is a paper from this year, from the International Spine Study Group, and when they compared open versus circumferential, that's what the C means, circumferential minimally invasive techniques, and they tried to match the curves and the pelvic parameters and the groups of the patients in total, and they concluded that. And this is key, really, well-selected patients had less blood loss, comparable results in the short to medium terms, but longer operative times in comparison with open surgery. One paper which raises a concern for me is this paper, again, a recent paper documenting the high radiation doses used during minimally invasive approaches. So they had a group of 52 patients who had their circumferential minimally invasive deformity corrections, on average a 5-level fusion with about 3 lateral cages, and quite a significant fluoroscopy radiation dose. With quite a large range, actually. So between 33 and 1,000 milligray of radiation. But the average emission dose exceeded the annual risk threshold by 36 times, which is a significant amount of radiation, not something that should be minimized, and a concern for the future, not just for the patient, not just for your patient, but for yourself as the operating surgeon and your staff. Okay, so let's take a couple of my cases. So first of all is a 70-year-old lady who was very fit, but had a long-standing deformity that was getting slowly worse, both in terms of her shape and the fact that she was getting more problems with pain and tired easily. She'd had a previous decompression for root symptoms of the L3 nerve root elsewhere, but this had given her no or very minimal benefit. This is the preoperative X-rays with a significant a significant right lumbar curve. Here you can see quite advanced degenerative changes and a hint of slip at the L3-4, lateral listhesis at L3-4, which is commonly seen, and an overall loss of the lumbar lordosis, global sort of thoracolumbar kyphosis, very typical picture. CT scan suggested that the apex was fused or nearly fused in the concavity with significant osteophyte here at this level. So the decision making really that I sort of went through, decision making process I went through was, should I do front and back surgery? Perhaps I could treat it all posterior with an osteotomy, either a pedicle subtraction osteotomy or multiple Smith-Peterson osteotomies. I perhaps wanted to go back and have another go at decompressing the L3 nerve root and get fusion. And was that fusion going to be circumferential or posterior only? And what about the instrumentation? Should she have a fusion of the whole spine, T2 to the pelvis, or would I be able to stop at the thoracolumbar junction? Perhaps I could stop at L5 rather than going to the sacrum or pelvis. This is the outcome. This is what I decided to do. I stopped at the T11. I didn't feel the need to instrument the whole of the thoracic spine, but I did do an asymmetric pedicle subtraction osteotomy here at the L3 level in order to restore the coronal balance, and I instrumented to the pelvis, but no anterior surgery. And she did well from that. I think she broke her rods at about 2 years. We redid the rods, and that was the only surgery. So she only needed revision of her posterior rods and no anterior surgery. Second case, 75-year-old lady with a degenerative spondylolisthesis as well as a lumbar curve. Not as severe a deformity on the coronal plane on the AP X-ray, but a L5S1 lytic spondylolisthesis. Initially, she was fixed by my predecessor, and he had a similar approach to me, but without the pedicle subtraction osteotomy and fixation with sacroiliac screws rather than iliac bolts. But she eventually loosened at the bottom end, so you can see quite a lucency around the sacral screws and the alum screws here. And she eventually started to decompensate both sagittally and off to the left in the coronal plane. So again, I did a similar thing. I did an osteotomy, which I don't think you can do minimally invasively, We certainly can't do it safely. Extended the instrumentation to the pelvis and higher up into the thoracic spine. And the key to the outcome here is the restoration of the sagittal balance and the lumbar lordosis through the osteotomy. And again, this is not something that I can't do an osteotomy through a previously instrumented rigid spine using minimally invasive techniques. Next case is just to illustrate the fact that a short segment front and back surgery, in my view, can be considered as minimally invasive, even though it's a traditional open technique. A 60-year-old lady with post-traumatic kyphosis. She was hit on the head by a canopy, an awning that came out from her garage, and she was sort of collapsed backwards, and she had a fracture of the upper lumbar spine, which was initially treated conservatively, but in the end wasn't going to settle, and she had severe symptoms of pain and mechanical instability. So she had a same-day front and back fusion with initial surgery was anterior, placement of an expandable corpectomy cage here filled with the bone from the fracture site with an anterior plate, and then same-day posterior surgery with screws. So traditional open technique, but because it doesn't require too many levels fused, is probably better for her than a technique. I've seen some people describe percutaneous screws over a long segment for a similar type of fracture fixation, which in my view is more invasive than a shorter segment front-back fusion. So, of course, there will be some cases more suited to others, to MIS than others. But the cases that I see that I would classify as proper deformity are those with revision that need revisional instrumentation, or have previously fused or naturally occurring rigid spines that need an osteotomy, or have severe deformities that require open anterior release or complex techniques like vertebral column resection, although I try to avoid this if possible. I think it's a dangerous operation to have. So in summary, my plea is we must obtain stability with adequate instrumentation, restore the alignment, and aim for the return of function whilst respecting the spine and the biology. The traditional aims of every spine surgeon treating deformity that there has been. We must not sacrifice the outcome or those objectives for the sake of a new technique. Additionally, please, if you are considering doing minimally invasive surgery, please make sure that you feel it's worthwhile going through a learning curve in order to achieve it. Get a mentor, but if you have good results with open surgery, then stick with it, because I certainly will do that. And I'm going to hand over to Robert Lee now, or perhaps he's gone before me. I don't know. I had no idea what he's going to say. So perhaps there may be some questions we can answer those live. Thank you very much.
Yeah. Thank you, Dr. Gibson. Hello. Is Dr. Gibson there? Hi. Nice talk.
Thank you.
Yeah. So we had Dr. Lee before you, and he gave a good talk on the MIS way, and we saw you open. So I would like to ask Dr. Samir, sir, any question for Dr. Gibson?
No, I think he has made it amply clear that MIS, of course, is has its points, but it should not be used over enthusiastically. And there has to be some rationale of thinking that by doing an MIS procedure, if you are actually having smaller skin incisions, but you're doing more damage inside, then that's not truly an MIS. And I think the bottom line is to do the correct procedure and not to be married to the concept of doing an MIS as a principle,
but rather than doing what the patient really needs to be done. And if a surgeon then has experience, skills set up to provide the same procedure in an MIS fashion, then surely that is a good option. But one doesn't need to have to do it MIS. We have to do the right thing, basically. So patient selection, procedure selection, all these are much, much more important than whether you do it MIS or whether you do it open. That becomes a much finer point,
That's very important. I think don't get going by the procedure. First, take the proper patient selection. Is that, Dr. Gibson, what you would agree?
Yeah, I agree. I mean, in debates like this, you're forced to take a position that might be more extreme than what you would really do. And of course, I know Robert Lee has great results from his technique. So my sort of point is if you've got a technique that works for you, if that's a traditional open technique, then don't change it, because you're only going to sacrifice your outcomes for the sake of learning something new.
Okay, yeah. So fine, that's very nice, Dr. Gibson. So Satyan, do we have time for a case?
Go ahead. Just show your one case quickly.
So because of the lack of time, we'll just go with a single case. So I mean, it's basically about if I'll just share my screen. So yeah. Yeah, so basically just a single case. So is the screen visible?
Yes,
go ahead. Very much.
Yeah, so this is a 54-year-old maid, housewife. Main complaints of low back pain, very minimal leg pain. But because she's a maid, she's unable to do her daily work of bending and working. She has tried a considerable conservative treatment with other surgeons and under me also. Her DEXA is normal, D3 is around 28, no medical comorbidities. And these are her standing AP X-rays. She has a lumbar is S1, the apex is at L3-4, and this is the sagittal X-ray. These are sagittal MRI films. The L3-4 is the one which was showing a little bit more stenosis, loss of thoracic kyphosis, complete flat back, degenerative scoliosis, and her axial films. The 5S1, S1, S2, 4-5, a little bit more stenosis on the left-hand side, and 3-4 with this. So now the main problem was, being an Indian, she is a maid who works at multiple houses, but she can't do her daily work of bending and working. She has tried conservative line of treatment, but what should be the option given to her? I mean, because her main work, she's just 53. I mean, her main work is going to go on for another 5-10 years. And should we go for a conservative? If yes, then what? And if operative, then what? Because this was the main dilemma that I was facing. Yeah. So from the panel, Samir sir.
So I think as we have said, especially in our scenario, we do conservative as long as possible, because any surgery we do in her has two problems. Number one, it is going to restrict her mobility and her spinal mobility. And number two, at this age, no matter what we do, there are going to be revisions. So if you do only a decompression, she's going to require a fusion. If you do a fusion, she's going to get an adjacent level. Then she's going to get an imbalance. So there are going to be this lady doesn't have one surgery which finishes it for her. And given her social status as well, it's going to be a problem. So I would say, exercises, blocks, etc., and then try and find out what her problem actually is. And, if it's leg pain, is it back pain or not? But I'm afraid if she does come to a stage where she comes for surgery, she's not one where we are going to get away with a smaller surgery, because she does have a lot of imbalance, coronal imbalance. And, she's got loss of the sagittal balance as well. She's got flat back, and she's young. So she's not going to, we need to do the so-called whole hog for her, the proper surgery for her. We need to correct her, decompress and give her a fusion and a correction. A small surgery is not going to work in this lady.
So do a complete from thoracic to the lower down.
So delay it as far as possible, but once you do it, it's going to be the bigger surgery rather than one of the smaller ones. Because if she was 70, 75 with one leg pain, we may do a selective decompression or something of that sort. But at this age, with this sort of thing, this curve is going to progress and she's going to land up with a lot of problems. So we are going to have to use the principles of how to get this curve back in the coronal and the sagittal balance and decompress it when we are doing a fusion.
Operate.
Yeah.
Yeah. Dr. Lee, can we do this for minimal if it comes to an operative situation?
Absolutely. I mean, firstly, I would say I agree with absolutely everything that Samir has said. I wouldn't touch it with a barge pole for the time being, for all the reasons he stated. And for me, this is an all or nothing case with a huge amount of preoperative counselling that's required. But if I were to do this invasively, I mean, she's a good candidate for a multi-level load lift to restore the foraminal heights. And I would do a day lift as well. And then I'd see what she's like after that stage and see how far up you need to go. But no matter what you do, even if it's minimally invasive, it's going to end her career. She will not be able to go back to the work that she's doing. So again, leave it as absolutely long as possible. But again, I would do minimally invasive techniques in her case.
Okay. So, yeah. So actually, in my case, what we did was we just did a conservative, and with willful neglect, she just lost to follow-up. So I think it's been now since 2 years since we have not seen, but 4 years which we follow up, we gave all kinds of conservative trial. We gave her blocks. We did physiotherapy and all. She didn't improve significantly, but she was not totally unhappy also, but she didn't want to go for a surgery. So I think we just managed with the conservative, but what I said, willful neglect. So I mean, this is a point where it needs to be thought, looking at what is required for her.
The only thing, like I said, is that she's very young. So this is the problem. The dilemma comes in the very elderly patients who we get, who also have a limited lifestyle and who don't have much expectations from life. You know, our Indian ladies, many of them, by the time they're 70, they have very limited expectations from life. We can conserve them till the very end. But for a young lady, relatively young, she's relatively young, who is also a breadwinner, it becomes difficult to, deny them treatment which will work for them and help them, of course.
Yeah.
Satyan is sending huge messages to us.
Yeah, so I think he's saying that we need to distinguish. Thank you so much, Dr. Lee. Thank you, Dr. Gibson, Dr. Samir sir, and Dr. Ranjit for the wonderful session and very insightful. So Satyan, I think we are done with the session on adult degenerative scoliosis.
Yeah, Nikhil,
Thank you.
Nobody has thanked you, so I should thank you, Nikhil. You did a good job of stringing it all together. And I especially thank the foreign faculty who must have worked hard to join their times to our times and have given us very precise information which is useful in our scenario. So I really thank all of you all.
Been a pleasure. Thank you for inviting us.
Thank you.
Thank you.
Great honor.
Thank you. Thank you again. And we'll go on to the next session for which I want to invite Dr. Abhijit Pawar to take over the session. We are going to be talking about navigation and robotics in spine surgery. Abhijit and Dr. Manish Kothari, go ahead, please. Your session.
Yeah, welcome everyone. Welcome to Bombay Spine Society conference. We'll start with the robotics and the navigation segment. This is the future, and this is the fad is what we're going to be discussed. With us, we have two excellent talks. One by Dr. Ronald Lehman. He's from the Columbia University. He's a professor, a very dynamic surgeon. He's been in the military of the US Army as well as in private practice currently. And we also have Dr. Sajan Hegde, who's a star of our country, pioneering the work in robotic spine surgery. Unfortunately, we don't have Dr. Ron for the time being. Can I ask the technical team to play his talk?
I'm currently a professor of orthopedic surgery at Columbia University in New York City in the United States. Today we're going to talk about robotic spine surgery. Where are we and where are we going? Here are my disclosures. In addition, there are many different things that we have to think about as we're doing spine surgery. We have to figure out exposure. Are we going to use an open approach or a minimally invasive approach? What types of decompression are we going to use? How are we going to approach the inner body? We're going to go from the front, from the back, or from the side. In addition, we have implants to think about, different types of osteotomies, whether we have to do a 3-column osteotomy or can we get away with just doing posterior column osteotomies, and the correction. So all this goes on as we plan our case. So if we can take one of these things or several of these things and minimize these to make them relatively automatic, it has to be better for our stress level during surgery, ultimately better for outcomes and better for patients. But what really is this all worth? So we know at this point that many of us have had cases or have seen patients where there's a significantly malplaced screw. And certainly if we look at cases like this, where we have a screw that's into the aorta, or into the spinal canal or spinal cord, these can be catastrophic. So let's take this, a relatively straightforward adult curve in terms of scoliosis. It's about a 65-degree curve with some thoracolumbar and overall thoracic kyphosis. We can sit a little bit closer up. We have a PI of about 56 degrees with our lumbar lordosis about 21 degrees. So we have a mismatch of about 35 degrees before we start this case. In addition, the thoracolumbar kyphosis also takes this into account, and our SVA is about 7.5 centimeters. We also look at the MRI for degeneration and where the ultimate compression is going to be on the nerves. And then once again, we think about this in terms of what options do we have? Our options to do a pre-op CT scan. This is hugely beneficial in that when we do the
I'm the moderator.
benefits, such as vacuum dysfunction, joint pathology, or osteophytes. In addition, the entire surgical team this allows for some preoperative planning, as well as our technologists in the room, as well as robot assistant experts, and also then plan all these screws out ahead of time so we know exactly what types of screws we're going to use, where they're going to go, and what they're going to look like. In addition, we can use what we call the scan and plan, which is very similar to what we do for navigation, where we bring the O-arm into the room, take a 3D CT scan in the OR, and then use that rendition to go ahead and plan our next screw. One of the really great concepts about this is that we can go ahead and perform osteotomies or bone cuts or corrections. We can use this for residents and fellows as well as surgeons that are training, or in more complex cases where we're not quite sure where to perform the osteotomy, and by doing and practicing different levels of the osteotomy, we can see what the reciprocal change and correction is going to be. That we can do with using the powerful software package for this technology. As you can see here, we can optimize the construct. We can ensure the screws are in the right position. We can also make sure that the rods all line up. We can make sure that the tulip heads are very similar, and we can do things like avoid the superior facet. All these things are incredibly beneficial. One of the things I think that's really pretty impressive is that we can get a surgical preoperative plan. So this is a sheet that gets printed out. The surgeon gets to see it. The circulating nurse, the OR technologist, as well as all the implant company, as well as the sales rep, knows exactly what types of screws we're going to use, how long they're going to be, and how large they're going to be. Because one of the things that we run into, certainly in a large city like New York City, is we have too much equipment open on the back table. You can see here for a standard deformity case, we can have 30 or 40 pans opened up. And this comes at a really high price. Not just that it's more difficult for the scrub tech to find out where things are, but also the fact that these cost a lot of money. And in the US, especially in a city like New York City, it's about $300 to sterilize and process each of these pans. And you can imagine if we're using 30 or 40 pans for a case, that's tens of thousands of dollars. And so for a case like this that I previously showed, this is the type of correction that we can achieve. And so this patient was significantly coronally imbalanced before surgery, and as a result now, he's completely back into coronal balance. In addition, his sagittal profile has significantly changed and improved, and he's able to stand up much more straight. What I get asked often is, how does this affect how I currently perform surgery? And how is this different than what I did before? Well, one of the huge benefits of these strong planning tools is that for a minimally invasive surgery, I can now look at various things. I can look to see where exactly is the skin incision? How do the towers intersect and overlap? How long is my incision going to be? And then how far off the midline is my incision going to be to be able to place my implants with the minimal amount of soft tissue disruption, as well as decreasing the amount of distracting the muscle or translating the muscle with different retractors. And then we can go ahead and place our screws. And I think this is one of the huge benefits when we look at these different types of implants, is we can place these more reproducibly with much more precision. We can also then use tools to help dissect out the facet joints, to help improve the correction, or to loosen up the spine itself. lordosis for this particular case. Then we can take, once again, and perform our surgery, regardless of what types of implants we use. And so you can see here, for a 1 or for a 2-level case, we can achieve good lordosis comparatively. Once again, losing large cages with good lordosis, and also performing posterior column osteotomies to help, once again, achieve this correction, even for 1-level single surgeries. For a 2-level case, as a case like this, we once again want to make sure that we can get and achieve a lordosis. We start out with about 4 degrees of lordosis at L4-5 with really bone-on-bone apposition at L5-S1, and ultimately achieve 20 degrees at that level with 36 degrees overall from L4 to S1. We can also contour the rod. We know exactly what the rod should look like before we even start the case. In addition, we know how long the rod should be as well. All these things I think are incredibly beneficial and important, and once again, makes it much more reproducible for all of us. And we can see here now from preoperative to postoperative exactly what the construct should look like, what we achieved during surgery, and did we actually achieve exactly what we set out to do. All of these things incredibly beneficial to know what our goals are, where we start and where we end, and did we achieve our correction that we actually set out to do. We can then reconstruct her and be able to make sure that she's perfectly aligned. We can also do things like place subaxial cervical spine pedicle screws. And this is just my case from a couple of days ago. We were able to place the C6 pedicle screw. We can see it back here on the screen as we do it. And we're able to use the Midas high-speed burr to burr through the sclerotic aspect of the C6 pedicle. This was, once again, very straightforward. I used a preoperative CT scan, and you can see here, this is from a proximal junctional failure case. We were able to place C6, C7, and new T1 screws even through the proximal junctional failure level. Got great fixation. Once again, made it very rigid and much more reproducible. We're now doing things like what we call simultaneous surgery or single position surgery, using an a-psoas approach or a trans-psoas approach, or even an ALIF in the lateral position. We can now take a case like this with a complete bone-on-bone collapse at L3-4 with a grade 2 spondylolisthesis as well as a pars defect, significant osteophyte formation off the side, and in a single position without having to flip, we can do all this surgery without the need for additional procedures or staging of the case. You can see here on the MRI as well. The CT scan shows the sclerosis as well as significant modic end plate changes, as well as the pars fracture and the elongation of that particular area.
Manish, if you're around, we can start the next talk. I think towards the end, there was a little bit of a problem with the talk, but overall, an excellent presentation about the robotic technology and how it is so useful in dealing with complex cases where sometimes it becomes very difficult to put in these pedicle screws. And we are not able to put them in safely, or if sometimes you have to go into the cervical region, and if it's a revision scenario and we need to put in cervical pedicle screws as well, and it becomes very, very difficult. So if we have this kind of technology, or able to put these in quite safely. So Manish, your views on that?
Yeah, of course, it's an excellent tool to plan your surgery. And it's not that it cannot be done in an open manner, but having these tools and the machines makes your life much, much easier and your job much more precise. And the word that I liked was used by Dr. Ronald Riemann was reproducible, which is that most people will be able to do the same thing, not just a few genius surgeons who can do this, who can do a particular surgery. So the word I liked was reproducible. So this is what these machines can do for you, not that you cannot do it open as well.
And what do you think about the fact that that we need to put in with the robotics? You need to have a lot of CT scans to be done earlier, extra radiation as well. Is that something of a concern in these cases? Because I feel that you may be exposing the patient to more radiation.
Of course. So especially I'm most of the times concerned in idiopathic scoliosis, young girls, exposing them to CT radiation is definitely a concern. In older age group, if you're doing an adult deformity, the concern will kind of be acceptable, cannot be completely justified, but it is acceptable and it is doable. But the radiation definitely is on the higher side, and definitely more than if you're doing a C-arm procedure, which will also have radiation. So if you compare radiation to the surgeon, it is definitely less because all your C-arm shots are now kind of almost gone. But the radiation to the patient is definitely a concern, including the CT as well as all other O-arm and whatever we use.
Yes, Satyan, I would like to differ in this case because if a patient is exposed to a radiation equal to 1 dose of CT scan, I think it is not a big compromise at all. What is more advantageous will be surgeons. We are exposed to a lot of radiation in this minimal invasive procedures or even in scoliosis surgeries. So with this robotics or use of O-arm and navigation, the radiation to surgeon is almost zero. So I think that makes a big difference where we are exposed to radiation almost on an everyday basis. If the patient gets a radiation of 1 dose of CT scan, I don't think it makes a big difference in the long run.
Great. So we have our own robotic surgeries being performed in India, and one of the pioneers was Dr. Sajan Hegde. Would you like to introduce the talk?
Dr. Sajan Hegde is one of the pioneers of robotic surgery. He started with the MESAR system, and he's done more than 400 cases. And he's shown in various conferences, he has shown us some excellent cases that he has done, including high-grade spondylolisthesis and so on. So let's get on with his talk. I'm sure the talk is far more interesting.
Good evening, ladies and gentlemen. Today I talk about the Indian experience with robotic-assisted spine surgery. We are already 400 cases and counting. Now, pedicle screws I have been placing for the last 25 years and more. My technique has been primarily freehand, but it has always been an issue for placing pedicle screws in obese patients, in revision cases, and severely deformed spine. And the pedicle we know offers the strongest point of attachment. It has been used for over 50 to 60 years. The pedicle screws have been widely accepted as an invaluable part of spinal instrumentation. And Lenke went on to say that pedicle spinal fixation is a state of art in deformity correction. All of us use different techniques. We have, it is based on our training, our experiences, the resources available. I prefer to use the freehand technique. Some surgeons prefer the fluoroscopic technique, but there is the issue of radiation and cumulative radiation to the surgeon. Of course, malplaced Screws can cause a lot of complications. There can be dural injuries, root injuries, paraplegia. And of course, we know that serious complications are rare. But misplaced pedicle screws with greater than 2 millimeter perforations have very poor biomechanical strength due to their malposition. The most challenging obstacle of placing pedicle screws safely in revision surgery is the fusion mass and the lack of anatomic landmarks. Now, whether one uses freehand technique, intraoperative markers, radiographic control, the incidence of patients with pedicle screw malposition would always remain very high on account of the large number of screws that are placed. So how does one make dangerous spine surgery safer and improve or increase the accuracy of pedicle screw fixation? Way back in 2012, Apollo Hospital was the pioneer in robotic-assisted spine surgery, and we got the Mazor second generation spine robot called the Renaissance. This uses robotic guidance. It's based on virtual pedicle screw placement, which is done on a high resolution CT, which is taken prior to surgery, and the planning is done. And this is done virtually on the computer screen and taken, and a 3D sync is done at the time of surgery, and the robot is placed on mounts and the correction is done. So here we have a child with a double curve, which is severe and rigid. The pedicle screws have been guided using the robot, and with accurate fixation and good correction, she has an excellent correction. This child has a far more complicated deformity with multiple hemivertebrae, and the spine is displaced in all directions and rotated in all directions. This becomes a huge challenge if one has to do it manually. This is a CT scan. A virtual screw placement on the CT scan is done prior to surgery. And on table, you can see the extremely difficult trajectories for screw placement. This is the screw placement done from the left side for the right side pedicle. The pedicle screws are accurately placed, the hemivertebrae excised, and a good correction is achieved. Now, in this child who had a severe spinal deformity, congenital deformity, and had undergone multiple surgeries, this becomes a huge challenge. The child is small, the pedicles are small. She has had multiple surgeries, the implants have given way. So this is a challenge where there are no landmarks for screw placement. The robot then is very useful in this kind of situation. And I don't think this kind of surgery can be done without the robot. So what's new? The next generation robot that we are using now is the Excelsius GPS robotic navigation system. This has a very rigid arm which can be navigated real time, and pedicle screws can be placed directly. No wires need to be used. The robot is multifunctional and has unique real-time information available and imaging versatility. As I mentioned, the arm is extremely rigid and all the instruments are integrated. So in this 13-year-old child with a severe deformity, we are able to do the intraoperative X-rays, and based on the previous CT, which has been performed the day before, plan the screw trajectory as well as the size of the screws, and place them perfectly to get a good correction. In the past, of course, because of the radiation issues, I never ventured into doing minimal invasive spine surgery. Now, with using the robot, I'm able to do spine surgery in a much better manner and much more efficient. Here we have a burst fracture, L1. and we guide the screws using the robot, do a segmental fixation. And here in this 14-year-old child, we are able to use the robot in a very unique manner. This is a child having tuberculosis affecting the L2 vertebra. She has complete destruction, as you can see here. She has a huge abscess in front and around the L2 vertebra. The CT scan shows complete destruction of all parts of the L2 vertebra. The plan is to do a minimal invasive fixation in the lateral position, as well as the corpectomy of L2 and reconstruction and biopsy. Here you see the patient positioned and the X-ray pictures being taken. The robotic planning is also done. The robot helps the placement of the screws with the patient in the lateral position. The screws are in place through MIS incisions. Anterior corpectomy is done and a cage placed, and the patient has a good recovery. This 32-year-old gentleman with cervicothoracic kyphosis due to ankylosing spondylitis has severe restriction of his activities of daily living. The sagittal X-ray shows the severe deformity. The CT scan shows the loss of landmarks, which would have made it very difficult and extremely challenging for placement of screws using the manual technique. After the patient is positioned, a 3D fluoro CT is done. This is fed into the robot, and with real-time information, screws are placed perfectly in the cervicothoracic area. After a cervicothoracic osteotomy, the deformity is corrected and the patient has excellent sagittal restoration. Finally, I come to the 67-year-old lady who presented with low back pain with radiation to both lower limbs, gradually progressing over the last 2 months and interfering with her day-to-day activities, limiting her walking distance. She has loss of lumbar lordosis, severe compression at the L4-5, L5-S1 levels. After a preoperative CT is fed into the robot, the planning is done. This is the live image showing the screws in place, placed minimal invasive, as well as 4-level T-lift done to restore the lumbar lordosis. This is the post-operative images. Her preoperative spine had a sagittal deformity which was corrected, and the lumbar lordosis, which was extremely reduced preoperatively, was brought back to normal. The advantage of minimal invasive surgery is that it allows us to mobilize the patient a few hours after surgery, and it shows the immense advantages of using the robot for doing these surgeries. To conclude, we are one of the earliest users of the spine robot way back in 2012. And over the last so many years, we have done over 430 cases. And I can definitely say that the robot plays a very important role in our surgical options that we offer to our patients. Thank you.
Excellent talk by Dr. Sajan Hegde. He's been one of the earliest users of the robot and one with the highest experience. Dr. Abhijit, what has been your experience with respect to navigation or robot? Would you like to add some comments on this? The cases shown by Dr. Sajan Hegde, sir?
Yeah, I mean, in deformities or in cervical thoracic junctions or high cervical spine lesions, or even in high thoracic spine lesions, I think the robotics and navigation and the OAM is significantly beneficial as it improves the visibility. It makes your implant placement precise and accurate and safe. I think it's not just a fad, what we say in this topic of this in this session, but actually the necessity nowadays in patients with high-end deformities or in cervical spines or high thoracic lesions.
Yeah, in most, if we have Dr. Shailesh here, sir. Dr. Shailesh, sir? Hello?
Hello.
Yeah, Dr. Shailesh, would you like to add some comment? So, as you have been using the navigation frequently now.
Yeah. So I think excellent talk by Dr. Hegde, and in this complex deformities of cervicothoracic region, or where you need cervical pedicle screws, this OAM navigation is excellent. Okay, navigation, you don't go wrong. You really have a very good advantage of all the corners of the pedicle, and you really go very safe. In rotated vertebrae, it's again a very, very big benefit. You don't breach the pedicle. You really can get into the canal well, and that's a big advantage of robot. And I think what cases Dr. Hegde has shown were brilliant cases, and I think this is the future. Some of my video is not, I think the host has stopped it. It's not open. I don't know why it is there.
Right. I think Dr. Ajay Krishnan is also in the panel. I don't know if he's around. Can you hear me, Dr. Ajay? I think he's not with us physically. So yeah, I think we'll get on with the next talk. Should we start with Dr. Shailesh or Dr. Abhijit now? Mrs. Surida?
Dr. Abhijit's talk first.
Right. All right. Please play Dr. Abhijit's talk.
Good evening, everyone. Today we're going to discuss the use of OAM and 3D navigation in scoliosis surgery and deformity correction. As we know, in patients with scoliosis and spinal deformities and kyphosis, a lot of patients have dysplastic pedicles, atrophic pedicles, or even in some cases, absent pedicles. So placing the instruments in these patients is critical. Medial or lateral perforation carries the risk of violation and injury to vital structures, including the nerves and vital organs of the body. That's why the role of 3D navigation and OAM-based navigation is very important. But the important question is, why not just C-arm-based navigation or a freehand technique or X-ray-based navigation? There are several limitations of the C-arm-based technique or the X-ray-based navigation, especially in the high thoracic spines, cervical spines, obesity, and patients with severe deformities. There is superimposed bony architecture. There's the rib cage, the shoulder, the scapula that comes and obstructs the vision in patients with osteoporosis, and in patients with deformity. The visibility can invariably be poor, and that can lead to misplaced pedicles and misplaced instrumentations. Now, this is a typical example of an X-ray of a patient with scoliosis, a congenital scoliosis, where the visibility of the pedicles in the AP and lateral planes can be very poor and can lead to misplaced instrumentations. This is the high thoracic fixation. The scapula, the shoulder blade, the humerus can come in your way, and this can lead to misplaced screws, and the high thoracic vertebra, especially at the T2, T3, T4 in scoliosis correction. And osteoporotic spines as well. The visibility is extremely poor in the high thoracic or thoracolumbar junction or in patients with obesity. But there is enough literature to show that the perforation rate in pedicle screws in the lumbar spine can range from 17 to 34%, whereas in the high thoracic spine from 23 to 55%. That's very high incidence of perforation rate with a freehand technique. That's where the role of O-arm or O-arm-based navigation comes into, with accuracy is almost 99%. And so this is the typical elements for navigated spine surgery: a navigation system with a localizer, a patient reference frame, surgical instruments with attached trackers or optical markers, a monitor. And this is the O-arm, which is basically an intraoperative CT scan. The patient is positioned on the operation table. The O-arm is a 3D CT scan that comes into the picture. It scans the patient with a three-dimensional shoot. These images are transferred to the software, and then the O-arm goes out of the operation theater. Now the surgeon comes in and he performs the surgery under 3D navigation without exposure to any radiation. And the placement of screws is nearly 100% accurate, which you can confirm again with another shoot after the surgery. So this is the patient with adolescent idiopathic scoliosis corrected by an O-arm-based navigation technique. You can see on the right side, the pedicles are calibrated by the pedicle probe and with the use of navigation. So the placement of screws is almost 100% accurate. This is a child with syndromic scoliosis with about 140-degree curve in the thoracolumbar spine from T5 to L3. Now these are significant rotations and dysplastic pedicles. The risk of perforation can be very high, and the risk of misplaced screws can be very high in these patients. So in this patient, we did the stage 1 transthoracic release of the spine, followed by stage 2 on the same day, posterior thoracolumbar fixation from T5 to pelvis under the O-arm and 3D navigation. And there is a fair correction of deformity in this child. In patients with high end deformity like kyphosis or angular kyphosis, congenital kyphosis, semivertebrae, vertebral column resection can be safely done with the use of 3D navigation and use of a navigated drill. You can check the depth of your drilling easily under 3D navigation and safely perform vertebral column resection up to 2 or 3 levels in these patients. A 3-level VCR in a patient with congenital kyphosis. This is another child with congenital kyphosis with a hemivertebrae, and as you see in the CT scan, she has absent pedicles at the level of T5 and T3, T4 on the right side and tight stenosis. So this correction was done under navigation and O-arm with the use of navigated drill, and a safe correction was obtained in this patient. Another patient with a rigid deformity, the visibility is, you can see the pedicles are barely visible under the X-ray. So this was done under 3D navigation and O-arm, and a fair correction of deformity was obtained in this child. This is another patient with scoliosis and syrinx and ulnar carry malformation. A large syrinx extending from C3 to D12. Stage 1 foramen magnum decompression was done, followed by stage 2 scoliosis correction after 6 months. And the fixation was done from about T5 to L3, and the safe correction was done under 3D navigation and O-arm control. Another patient with adolescent idiopathic scoliosis, fair correction of deformity under O-arm and navigation. Now, congenital scoliosis is another challenging patients who have multiple hemivertebrae. The pedicles are atrophic and can lead to misplaced screws in these patients and injury to vital structures. They are very rigid curves and correction is difficult in these patients. So with the use of navigation, you can place screws at the maximum levels and obtain a fair correction in these patients. Another patient with congenital scoliosis and multiple hemivertebrae, a fair correction of deformity with the use of O-arm and 3D navigation in this patient. So in these patients with high-end deformities, with dysplastic pedicles, the solution is 3D navigation. It has less radiation, almost no radiation to the surgeons. It's less time, and it's almost 100% accurate. It's more precise. The most important advantage which I see in spine surgery of this O-arm and navigation is almost zero radiation to the surgeon. And yes, radiation is a big deal nowadays. Radiation hazards, as we know, are dryness of eyes, fatigue, tiredness, burning of skin, numbness, neuropathy. And in advanced cases, even we have seen cases of infertility, cataract, cancer reported in the literature. That's why we must take care of our own safety. And the biggest advantage of this O-arm based navigation is zero radiation to the surgeon as he's standing outside the operation room during the surgery. There is enough literature to show that the CT scan based navigation is about 99% accurate as compared to the freehand technique. So it's more accurate, more precise, and less radiation. And that's the new way to go. Thank you.
Excellent talk, Dr. Abhijit. You've shown some very fantastic cases, which is made possible because of your navigation. So what has been your experience? Do you feel more comfortable, more relaxed with having navigation, or does it make you more flustered with the amount of technology, amount of errors that you have to consider? Once the O-arm is out, you still have to consider whether there has been an error. Has the what do you call it?
Tracker.
The tracker, has the balls of the tracker moved or not moved? Because you have to keep a constant check on the tracker, because even a 5 millimeter movement in the tracker will take away your entire navigation. So how do you kind of take care of this, or what are your thoughts on it?
Yeah, that's a good question. I mean, yes, the tracker has to be positioned well. That's why I make sure that the tracker doesn't move at all. It has to be fixed rigidly to the spinous process, and we always take care that the tracker doesn't move, because even if slightest movement in the tracker can actually lead to misplaced instrumentation. But and it has happened to me a couple of times. But you come to know, as soon as you're doing these cases, you understand that you're at the right location, but the navigation is showing the wrong position. So you come to know that the tracker has shifted. So nowadays I understand that, okay, the tracker has slightly shifted. So in case that happens, I fix the tracker again and take a O-arm shoot again. But that rarely happens. Most of the times it's safe, and you can easily rely upon your assistants and your fellows to put screws. So it's less tiring, and the major advantage is no radiation while you're operating in the operating room, no lead gums, nothing.
Yeah, that's a fair comment. Dr. Shailesh, I think we'll start with your talk. Can we play his talk, or is he presenting live?
Hello, everyone. Thank you, the BSSCON team, President, Secretary, and all the team members. I would like to start with our presentation on O-arm navigation in spine surgery and our initial experience of around 910 screws. What has changed in our practice in recent time is this beautiful gadget which has come in India in recent time, and this is the O-arm navigation, which is like a real-time 360 degrees imaging in operation theater for us. When we get a patient like this, 71 degrees kyphotic angle, 41 degrees the coronal cob, and hemivertebra with kyphoscoliosis, we always need to plan it well. This patient is with progressive deformity. The family is concerned and they want the deformity correction. We need to do all the proper investigations in such cases as routine, all the x-rays, the parameters, the MRI, where we really can plan whether you need to do a shorter fusion or longer, because the patient should not decompensate after your primary surgery. And in this particular case, we plan for deformity correction and kyphoscoliosis correction, along with hemivertebra excision. The big advantage of O-arm is accurate placement of screws even in apical region, and the osteotomy, which we can really do it under navigation with the help of O-arm. It really is a great tool for osteotomies, and we are understanding and maturing more and more as we do this kind of complex deformities with osteotomy. And this is the final outcome. You can actually see the amount of resection, the wedge. You can see the deformity correction, and this is the beauty of real time. And nearly a year's follow-up, this child is happy, taller. And our experience of more than 1.5 decades with standard freehand and CM guided open and MIS fixation surgery was good. But in recent 1.5 years, with the third generation O-arm navigation fixation in spine surgery, the experience is great, and we are learning great with better outcomes in our own practice. That's what we have realized. The O-arm navigation can be used in various pathologies, and all these important ones which are in our practice, like deformity, revision tumors, osteoporotic spine, cervical pedicle screws, thoracic and lumbar traumatic spine, MIS surgery, even cervical traumatic spine. And when we realize that deformity, most important is always whether I will be able to put my screw, whether there will be a pedicle morphology will be dystrophic or some problematic hypoplastic pedicle or altered pedicle body angle. All these things are there in our mind when we plan for a deformity correction. How will be the apical vertebra? How will be the rotations? But with this, we really can see it and plan well. This is a 15-year-old girl, cervicothoracic deformity, worsening cervicothoracic flexion deformity. Mother was really concerned. Family was concerned as she's a growing child. Around 52 degrees was the COB. We planned for a C7 to L1 deformity correction in this particular case. We did all the important imaging, and we really got very good screws in all the concavities in this cervicothoracic deformity. At times, there can be challenging screws, as I was mentioning, the smaller or sclerotic pedicles. And we have to be careful when you use the instruments, and you have to be very, very cautious. But in O-arm, you really can see through while putting this, and that's a big advantage. We got a curve to around 25 degrees. Second case of double major thoracolumbar curve. This girl is a 14-year-old girl with progressive deformity. 78 degree was thoracic COB, and lumbar was around 56. Significant deformity, and we planned for a deformity correction. Sometimes these deformities can be challenging, but if you see on table, on positioning, we were really concerned with this, but we got very good placement of the screws, strategic screws. We normally plan for around 70 to 80% of the screws in this kind of double major curves, and we really got a good deformity correction at the end of it. Osteotomies were done multi-level, and we got a excellent coronal and sagittal balance in this young girl. These are the things which are going to come, and I was just talking about the apical levels where we really can go very, very well at the end vertebrae, T2, everywhere we can really go through very, very smoothly. This is the biggest advantage of this. This is a type 3 quota bottom base screw pedicle. There is sclerosis. Starting. And this is a big advantage. You just see it and carefully advance your instruments. Big advantage of navigation, we can see. And again, you really can understand your deformity very, very well. And kyphosis, yes, there is a big advantage of O-arm navigation. You can do the osteotomy, you can plan the osteotomy, and that's the big advantage. This is a young gentleman, 25-year-old, worsening deformity, IT engineer. We did a kyphosis correction. Big advantage of O-arm navigation in osteoporotic revisions and tumor, apart from deformity. These are the 3-4 very, very important forts. And in such patients where there is severe osteoporosis, various medical comorbidities, high-grade listhesis, severe back pain, worsening by the day, and this lady is with the double-level lysis, L3 and L4, and grade 2 to 3 listhesis. Initially, she was treated with medications, but then she worsened, and then she came to us on a wheelchair as she was wheelchair-bound for 2 to 3 weeks. We planned for a decompression and stabilization of L3, 4, and 5. We planned for a delta fixation. The pelvic indices are here. Sacral slope was 47, tilt was 30. We did a transpedicular, transdiscal, transcorporeal fixation. We planned for a slightly inferior angulation of the screw at L4 because there was foramen of L4 which was coming in the way. Therefore, we didn't want to do this. We didn't want to go through the foramen. Therefore, we planned for slightly inferior. We got a very robust hold in the L4
This is a high-grade
body.
listhesis in a 77-year-old lady with severe leg pain, wheelchair-bound.
And if you see here, the margins are very, very well covered, and we could get a long length screw. This is 7.5 mm screw, and all the foramens are completely open. This patient is significantly better standing and walking now. And these are the challenges in high-grade listhesis with porosis. And this lady had double-level fracture, the D11 and L5 was lytic listhesis, and it was worsening. We planned for a lumbosacral fixation. At the same time, even there was sitting pain, we planned for a fixation of the dorsal spine fracture. And she really did well. Around 8-9 months follow-up, she's doing excellent. Most of the things of daily living she's doing. She was unable to even get up and stand and walk for nearly 3 to 4 months. Revision spine, big advantage of O-arm navigation because you can plan your revision screw, you can plan your decompression. Also, the bony mass, the screws or implants inserted previously, we can actually have a better anatomical understanding on table. And this is a big advantage. This is a proximal junctional failure in a 67-year-old gentleman, badly painful, and he was crouched. We planned for advancement of fusion in this particular case. There was a deformity, degenerative scoliosis in this particular gentleman. With significant, the VAS was around 8, 9 on 10. We did around D10 to S1 revision. We got dual core screws, absolutely long length screws, and he's doing so fine so far. And tumors, we can exactly understand the lesion, how much you want to resect, whether you want to do spondylectomy, whether you want to do interlesional decompression, curettage, all these things really can be planned. These are revision adenocarcinoma and dorsal spine referred by an oncologist as the patient worsened in 15 days. He was doing fine after the primary surgery for around 3 years, walking independently, doing all the work, but he became paraplegic. There was a large extra dural and epidural soft tissue of the tumor, and there was a recurrence of the tumor which was compressing the cord. Otherwise, there was no other lesion as per the PET, and the oncologist felt we should immediately decompress this and stabilize, as he was with radio and chemotherapy, with bones were slightly weaker osteoporotic. We advanced the fixation and we did complete decompression of the cord, and this is all done under O-arm navigation. Porotic spine, big advantage. You don't want to breach a pedicle, you don't want to go at a higher levels, you don't want to pull out. The biggest advantage of O-arm navigation, you can go with the good trajectories, you can go with longer length, you can really do the best of possible things in osteoporotic pedicle screw fixation with O-arm navigation. This is our recent paper published in Interdisciplinary Neurosurgery, which is talking about the precious pedicle in osteoporotic spine, accuracy of O-arm guidance in pedicle screw placement. And our study talks about 99.5% of accuracy in pedicle screw placement. as the angle of convergence, angle of inclination, and the length of the screw, everything can be dealt at one go. And these are such dynamic fractures. Some patients really are doing fine in bed, but the minute they get up, they can't stand and walk. Such kind of instability needs to be dealt with fixations, and OARM really is of a great help. This is a 1-year-old follow-up of this lady. And fractures, thoracolumbar fractures, where we can have various different types. And in this particular case, there is a 3-column injury with low limb power 0. There is again associated with ribs where injured. We can really plan your fixation well, strategic, and really get out very fast. Big advantage in minimally invasive spine. You have to just do like a standard spine, but you really have a big advantage of OARM navigation as you are seeing in a GPS-like technology on the navigation, and you are doing it. It's a big advantage. That's what I will definitely say. I must thank you all for patient hearing, and we need to accept the technology in future. Thank you all for patient hearing.
Thank you, Dr. Shailesh. Excellent talk. I think we are already overshooting time. We just have one very quick question to Dr. Shailesh. What do you do? What are your steps when there is a the readings are not as per your liking? When you think that the tracker needs to be adjusted, do you repeat the scan all over again, the OARM scan all over again, or do you go by your feeling?
No, normally this is a possibility, and I can say around 5 to 10% of the time there can be a misplacement of the tracker. You have to understand exactly whether you really need it now, at what stage it has happened. If it is your surgery is almost done and it is at the last phase, probably you can get away without using the OARM. You can just no need to do anything. But if you really want it, if it happens in the beginning, you have to repeat it. And as Dr. Abhijit was talking about surgeon safety, I think it is a healthcare safety to all the people in the theater. The patient is having that minimal dose. Nowadays, the newer machines have very less doses now. 13 seconds is the time of shoot. It's not much. What normally we do our HRCT chest is around 1.5 minute of the shoot. This is a 13-second shoot. So I think there is a lot of uproar. People just talk about, and we are coming up with our own paper, that there is not significant amount of radiation which really happens to the patient. And now we are coming up with the lead gowns to the patient's safety as well. So that if there is a need, definitely we can reduce the amount of radiation to your patient for that one time also. So I think we should revise and go back. We need the shoot if you are in the beginning and if there is a loose tracker.
Yeah, I think that was an excellent session. Fantastic talks by Dr. Shailesh, Dr. Abhijit, Dr. Ron, and as well as Sergeant Hegde. Thank you everyone for attending. Very good evening. From behalf of Bombay Spine Society, I thank all the speakers for being here, taking their time to present their excellent work and showing these videos. Thank you, everyone.
Thank you.
Thank you, Manish, for conducting this session, and thank you, Dr. Adhankar and Dr. Abhijit, for doing very well here. We've learned a lot in this, and this is definitely one more important step in our armamentarium, which is going to improve patient care. So we now move on to the next session, where I'll invite Dr. Pramod Lokhande and Dr. Sambhav Shah to take over on talk about our endoscopic spine surgery. We had an excellent session on endoscopic spine surgical techniques on the last weekend, and we'll be further taking this further ahead with you. Over to you, sir.
Yeah, thank you, Dr. Satyen. A very warm welcome to all the delegates and all the faculties. We have an excellent session today, a second one in this conference. And this session is mainly focused on expert speakers all around the world, mainly Germany and Turkey. And I have with me Dr. Sambhav Shah, who is going to coordinate with me. And we have an expert panelist surgeons. Dr. Arun Bhanot is there. Dr. Sukumar Sura, is he there? Dr. Ajay Krishnan is there. Yeah. So I would like to welcome Professor Christian Wojciechowski, Professor Dr. Ali Guven, and dear friend Mr. Dirk Gothel, who are going to have talks in today's session. So without wasting much time, can we start with first talk of Mr. Dirk Gothel? It is about instrumentation used in endoscopic spine surgery. Dirk, are you there? Yeah. Suvidha, can we have Dirk's talk, please? So before we start, I would like to introduce Dirk. Dirk is the general manager of Revo Spine, which is a sub-company of Richard Wolf. It basically deals with endoscopic spine surgery, all the endoscopes and the equipments associated with it. It's a subsidiary of the main company. And Dirk is a biomedical engineer who is passed out from the Berlin University in 1997. And he has been involved in research and development of these endoscopic instruments for last 20 years. So he's a really dedicated guy, and he's an excellent surgeon on the cadavers also. So we call him as a cadaver surgeon. He's one of the best teachers I've seen all around the world. So welcome, Mr. Dirk Gothel.
Thank you very much for the invitation. My name is Dirk Goethel. I'm from Germany, from the Revo Spine company. My background is biomedical engineering. I'm involved in the research and development of endoscopic spinal techniques since more than 20 years. And my topic today is technical aspects of full endoscopic spinal surgery. The development towards full endoscopic techniques was going along with the requirements for least invasive techniques, and the change from tubular systems to working sleeve systems, which means that we use an endoscope with an integrated working channel. Finally, we are talking about the extended surgery systems, which has many components. We have, of course, the endoscopes as a main part, and also here is important that we have a very good optical lens systems inside, because we need light, especially when we want to transmit pictures with 4K, with a high resolution. The light transmission system is very important for that. We need instruments, and of course we have special requirements for the stability of the instruments, and in our systems we can work with instruments up to 4 millimeter diameter, and of course with different shapes for different tasks. We have drilling systems. Also here we have requirements. It's very useful when we want to use it under direct endoscopic view is to use the deflectable burrs. We have RF systems which are important, and we are working under continuous irrigation during the surgery. Therefore the fluid management is very important for our surgery. What are the system requirements when we think on new developments? It's clear safety is number one. Usability is very important. That means easy to use. Then the visualization is important, but also topics like economy should be efficient and also universal use. I want to highlight some topics for technical aspects regarding safety, and we very often it is discussed the topic irrigation. What are the requirements for that? On the one hand, we need a high flow to get a clear endoscopic picture, especially important for drilling. On the other hand, we have to avoid an increased intraspinal pressure due to the water irrigation. The tools for irrigation are usually the gravity. That means we hang up the bag over the patient, and on the other hand, we can use a sufficient pump. One main question for using irrigation in endoscopic spine procedure is how to avoid overpressure? One answer is we have to use an open endoscopic working sleeve system. What does it mean? I would like to explain this on the example gravity. We have the patient here, we have the intraoperative working area. We use a transforaminal endoscope. We connect the bag and the irrigation tube. And if we would close now the system completely, that means we would not have any outflow. We could reach that pressure, which depends on the difference between the working area and the height of the bag, and which can be like this. If we hang it up 50 centimeter above the patient, we can reach 36 mercury. If we hang it up 100 centimeter above the patient, we can reach a critical pressure of 73 mercury already. The question is how to avoid that. We just have to open the outflow. Because when we open the outflow, only this pressure is getting effective. That means the difference of the water column between the intraoperative working area and the outflow of the endoscope, which is usually 15 centimeter, and which means 12 mercury. As we now know that we have to use a system with a sufficient outflow and the open outflow, the question is how to keep the outflow open during the surgery. Because we have to use instruments. We have different constructions of systems in the market. We have systems with 2 irrigation and outflow channels inside the endoscopes, and the diameter of the outflow channel is the same as the inflow channel. The problem is here when we use a big instrument, we block the outflow of the working channel, and then the outflow depends only on this area. And if we have this area equivalent to the inflow area, and we know during the surgery can happen that some pieces of tissue can block the outflow, then there is a risk that we can increase the pressure inside the spinal canal or inside the area. Another system, what we are using is using an oval-shaped endoscope and a round-shaped sleeve. And there's always a space between this oval-shaped endoscope and the round sleeve. And this area here we use for outflow. This area is 5 times bigger than the inflow area, which is here. That means, and in this way we can really avoid that we block the outflow. That means the outflow keeps open as long as you don't close this attachment here. A second possibility to avoid overpressure inside the patient is we have to use a flow-controlled endoscopic pump system. What does it mean? For everyone who knows or who is familiar in using arthroscopic pump knows that you can only increase the flow by increasing the pressure. And this is what we have to avoid. So we developed a special software for our existing arthro pump, and we call this spine mode. And the way how we do this, it's not a pressure controlled pump, it's a flow controlled pump. What we control is the flow, because we know when we don't have an outflow, we will not have flow and inflow. And as long we have a flow, that means the outflow is open. And the system realizes then a pressure which will never be higher than 50 mercury due to this intelligent pump controlling system. Once the outflow is blocked, we don't have inflow anymore, and then the pump will stop immediately the irrigation. So we can avoid that.
Another important topic regarding safety is connected with the use of radiofrequency surgery. We have special requirements here, especially we want to reach a safe and efficient hemostasis when we work close to neurostructures. On the other hand, also we want to resect soft tissue, and this should be very efficient when we're using RF surgery. But are there differences between different generators using or calling RF generators? Yes, there are. Radio frequency means a bandwidth between 350 kilohertz on the lower end and 4 megahertz at the higher end. And we see that the electrical resistance of human tissue is going down towards higher frequency, which means less heating up of tissue when we use a higher frequency, and that means less heating transmission to surrounding tissue. And that's the reason, especially when we want to work close to neurostructures, we want to avoid that much heat is going to surrounding tissue. That's the reason why we use a 4 megahertz device for endoscopic spinal surgery. Here we see the difference between both kind of devices, 4 megahertz with a blue line and 350 kilohertz with the red line. We did measurements at the tip. We could reach the same temperature. That means we have the same effect inside the tissue. But when we come away from this tip inside the tissue, we measured different temperatures. With 350 kilohertz, we measured 58 Celsius degree. With the blue line here with the 4 megahertz device, we measured 38 Celsius degree, which is a huge difference. And especially when you work close to neurostructure, in this distance, you could destroy the neurostructure with a 350 kilohertz device, but not with a 4 megahertz device.
Also, the ergonomic handling for our electrodes should be sufficient, easy to use, the rotation should be possible, and the weight should be not too high, because there's always a risk that, especially for interlaminar approach, that the electrode drops down and then it should not damage any neurostructures.
Another milestone in the development of full endoscopic techniques was the development of new camera systems with a higher resolution. Nowadays we are talking about 4K resolution. This allows us to zoom up the picture and we see the structures much more clearly with a higher resolutions, and we can better differentiate structures. On the other hand, we have a possibility now to process pictures digitally. That means we can enhance it with higher contrast or with different colors, and so we can have a better differentiation with this kind of image processing than before. Thank you very much for your attention.
Thank you, Dirk. That was an excellent talk on the irrigation system, which most trainees and most new coming spine surgeons, they are confused about. So this was an eye opener for most of them. And any questions? Arun, you have any questions regarding the new system which they have developed, the smart system?
No, that's an excellent new development, because conventionally we have always been worried about using the pump, especially as Dirk clearly mentioned that most of the pumps were pressure controlled. And whenever there was an extra bleeding, you wanted to have a flow which was more than average, you would use a higher pressure. But the intelligent flow control system would be a big advantage, and maybe you will not need to struggle with your irrigations by just trying to raise the height or maybe add a manual pressure pump to your system.
Okay. Ajay, are you there? Ajay Krishna? Okay. Sambhav, any doubts, any questions?
I basically wanted to ask Dirk one more thing. There is something new which has come up by Revo, which is basically the ultrasonic navigator for transforaminal surgeries, which guides you to put your needle in the foramen. So if he's around and if you can just throw a few lines on what that system is.
Dirk, are you there? I think Dr. Ali could take up the question. Yeah. Is it possible for you?
Yeah, okay. It's electromagnetic navigation. We do registration with the C arm, 180, and the next lateral. Then we choose our target point. Then we navigate our needle, dilator, and the working sleeve at the same time. This brings a big advantages because the safety and the accuracy is really good. And on the other hand, you reduce the radiation exposure. And what we can do with this system, you can introduce the system altogether, means that dilator and the sleeve together, and you see both during the procedure. And at the end, once you're inside the foramen, then you can remove the dilator and your working sleeve is there. And during the whole operation, you can track and you can see your position of the working sleeve. It's an electromagnetic navigation.
So does it also give you any feedback with regards to the neural structures, or is just your instruments?
It's a navigation of the instrument. You don't get any from the neural structure.
Yeah, great. Now, I think we should move on to the next talk by Dr. Ali himself. I would like to introduce Dr. Ali. I think he's one of the best endoscopic surgeons which I've seen all over the world, and he has been associated with Revo Spine for a long time. He was working as a clinical manager. He has taught a lot of people all around the world about the basics of endoscopy, not only on the cadavers, but also, he personally visited a lot of hospitals and demonstrated live surgeries there. So he's basically from Istanbul, and now I think he has started working back at the Nightingale Hospital at Istanbul, Turkey. So I'd like to invite and welcome Dr. Ali to present his talk on this thing, foraminoplasty.
Okay. Thank you for inviting me to this symposium, Professor Lokanda. I'm going to talk about the foraminal bone resection. I don't want to call it the foraminoplasty or foraminotomy because these kind of things sometimes confusing the surgeons. It's the bone resection with the foraminal access. Before starting that, as you said, I'm working in Istanbul in the Florence Nightingale Hospital there. And this is my disclosure. As you mentioned, I'm responsible for the international and the trainings of the Revo Spine company. As we know, we have two different approaches, the foraminal and the interlaminar approach, because here I would like to underline it. I don't want to call it a transforaminal approach because every time we don't pass through the foramen, that's why I call it the foraminal approach. And as you know, we have different foraminal approaches like transforaminal, intraforaminal, or extraforaminal approaches. And apart from that, according to your entry point, we have different approaches. The terminology for the posterolateral approach. Usually, we measure the midline, and then we find a midline and measure 8 or 10 or 12 centimeters to the lateral on the disc level. Then we find the entry point. With this entry point, our working angle is about 45 degrees, and this is a really good approach to reach the intradiscal space. But the problem, as you can imagine, the ventral epidural space. We cannot reach the ventral epidural space without doing a bone resection with this one. And the solution for that is to do bone resection. This is one solution. And the other solution also, you can choose more lateral entry. And why this way, you don't need to resect bone or less than the post-lateral approach. These are the techniques to enter. What is the terminology of extraforaminal approach? Basically, it means that we are working outside of the foramen. If you want to do the bone resection in the foramen, then you need to stay outside. Or if you want to resect or decompress the exiting nerve due to the herniation, we need to work outside of the foramen. For the discectomy, let's divide it for stenosis and the discectomy for the bone drilling. For the discectomy, in our philosophy, we believe that, of course, the foraminal approach is the least invasive approach. It's an open gate to the spine. We would like to do the operation with the foraminal approach, but according to our philosophy, we have some restrictions to do that. This is only maybe when you attend these kind of symposiums or when you check the literature, you can see different tactics here. All of them are done really with successfully, but we can only share our experience with you right now. What we do usually, if we see that the iliac crest is higher than the foramen, we prefer to do interlaminar approach. But of course, the other solution here, like L5S1 level, you can come a little bit oblique, and you can drill the bone on the facet joint, and then you can access to the spinal canal. This can be a technique with the bone drilling, but for me, it's much easier to do interlaminar approach instead of doing a foraminal bone drilling. Also, as part of the 4-5 level, again, you need to care about the iliac crest. The second criteria for me is the migration of the herniation. If it is located in the red zones, like upper than the upper pedicle, lower edge of the upper pedicle, or upper edge of the lower pedicle downward, we prefer to do interlaminar approach, as we are restricted in the crown side with the exiting nerve, and also we are restricted with the pedicle in the caudal side. But of course, it's not. You can do like this. You can do bone drilling with the pedicle or with the facet joint, and you can reach more cranial caudally here. But we don't prefer to do more. And the third criteria for us is the foraminal size. If the foraminal size is narrow due to the hypertrophy of the facet joint or the short pedicles, then it's not easy to pass through the foramen with the instruments and do the discectomy inside the spinal canal. And then the other option here again, we prefer interlaminar approach. I will come to this topic later. But the other option that you can back on the junction of the pedicle or to the facet joint, and you can resect some part of the facet joint, and then you can create a better access to the spinal canal. Okay, to do foraminal bone resection, what are the options in our hand? Basically, the technique with the manual drilling is known as a foraminoplasty foraminotomy system. Basically, it is with the manual drilling system under the fluoroscopy, step dilators, and the steps drilling. Step by step, you can enlarge the caudal side of the foramen, and at the end, you can introduce your working cannula and then the scope and start the operation. It means that the operation is divided two parts. One first part is with the manual drilling under the fluoroscopy. It is kind of blind approach. And the second part, then you do the operation with your endoscope. And the other option for us is to do extraforaminal approach with the shaver system. Especially we work with the detectable shavers that we don't change the direction of the instruments a lot during the operation. As you know, the exiting nerve root and the ganglion that you can patch and you can squeeze it with the pedicle. If you change the direction of the system a lot during the foraminal approach, basically we prefer to do with the angled instrument. These are two things. What we do, there are different techniques. Of course, you can back on the bone. We can start with the front cutting burrs. But basically, if you want to do enlarge the foramen to create a better access to the spinal canal, then we do like this. We place the needle at the dorsal annulus on the medial pedicle line, and then we introduce the guide wire. Guide wire of the system is a little bit stiff than the regular system. And then over the guide wire, we go step by step with the dilator and the working sleeve. We start with the smaller one, and then we switch to the bigger one. Then we drill with the step by step from smaller to bigger. Then we do like this under the fluoroscopy with the drill. We can resect that part. Be careful here with the manual drilling system. You can work only at the caudal side of the foramen just to create a better access to the spinal canal. It doesn't mean that you can decompress the exiting nerve root in the cranial side of the foramen, because it's really, really dangerous under the fluoroscopy, blindly working in the cranial side of the foramen. Then the option, if you want to do decompression to the exiting nerve root, like an ACP impeachment to exiting nerve root, then we definitely have to choose a burr system, shaver system. Especially we prefer to choose an angled one that we can drill the caudal cranial side of it. Usually we prefer extraforaminal approach in these kind of cases. Then we place our needle and the system at the caudal side, junction of pedicle to the HCP. Then we dissect all the tissues, and then we start operation like that. And under our visual control, we do the bone drilling, and you can protect the exiting nerve root. You see the video demonstration with the deflectable shaver systems. It's when you press this button, the tip is deflected. You see the pedicle here, the standing facet, and at the same time with the cannula, we protect the exiting nerve root, and we do everything under our visual control. And you see, you can expand your resection over the exiting nerve root. Now we are at the left side of the patient. Now we dissect or we prepare the foramen. There's 3 o'clock you see the pedicle, 12 o'clock you see the ACP, and at 6 o'clock you see the disc space. And we put with our cannula, we protect our exiting nerve root, and under our visual control, you can resect the bone like this. Now you see the video from the straight burr, and also we can use, as I said, the diamond dissectable burr, and then once you resect the facet part of the SAP, then you can reach to the spinal canal more better, and then you can do discectomy, and also you can reach more medial. But this doesn't mean that you can decompress the recess sufficiently in this technique. This is just for discectomy from my point. Why we don't prefer lateral foraminal approach to decompress the recess? Because there's a high risk that to do a sufficient decompression on the recess, you have to resect the major portion of the facet joint. And there's a high risk that you can damage the facet joint, and still, even you reach that part, still you might have compression on the nerve structures from posteriorly, especially from and the recess from the ligamental flavum or the upper part of the cranial lamina. Then, in case of the compression of the recess, we choose interlaminar approach. Again, as a summary, for the central stenosis in our philosophy, we prefer interlaminar approach. Definitely, you need to go to the contralateral side, because, and if there is a lateral stenosis on the recess, we prefer interlaminar, not the foraminal. But if there is a foraminal stenosis compressing the exiting nerve root, then we prefer extraforaminal approach with the shaver system. But as I said, for discectomy, you can use your manual burr system to do the bone resection on the caudal side of the foramen. Thank you for your attention from my side.
Well, thank you, Dr. Ali. An excellent lecture from you. Any questions from the audience? Okay, I have one question. Yeah. Yes, Abba.
Yeah.
Go ahead.
Just one question. In your practice in general, how much % of your work is more of transforaminal as opposed to interlaminar for in stenosis?
Generally, all stenosis and in discectomy, I do 20% for the transforaminal, 80% interlaminar approach. Definitely, I never do a stenosis case with the foraminal approach.
Yeah. So another question for Dr. Ali. I think you have those two excellent systems of doing foraminoplasties. You have those manual reamers, which you have hand-driven reamers, and secondly, you have the tip-controlled endoscopic drill system. How do you decide which system to use in that particular case? And do you decide it pre-operatively or you decide it intraoperatively? And what are the advantages and disadvantages of both this system?
Yeah, as Professor O'Connor, as I explained, usually we prefer shaver system, drill system to do bone resection. I call it bone resection. But in case of if the narrow foramen, again, if the pathology is a hypertrophy of the facet joint, then I don't do it with the foraminal approach. I do it with the interlaminar approach because at the same time, I would like to do the posterior decompression to the nerve structure. Only my practice is if I diagnose that the ACP, the tip of the ACP is pressing or compressing the exiting nerve root, then I do extraforaminal approach and resecting tip of the ACP to decompress the exiting nerve root. But personally, I never I never do a bone resection with a foraminal approach to reach the spinal canal or to decompress the spinal canal.
Okay, yeah. And you always use the tip control drill system all the time.
I feel much comfortable with this system because I would like to see what I am doing there.
Yes. Arun, any question? Yeah.
Dr. Ali, when there is a down migrated disc herniation in the upper lumbar vertebrae like L1-2, would you still choose the recommendation that you gave, the interlaminar is better because then you'll have to resect a lot of bone sometimes reaching up to the facet, because many a times for the interlaminar approach, you have to reach the lateral edge of the nerve root.
Yeah, you're right, because in the upper levels, the foramen size is larger than the lower levels. Then we prefer mostly in most of the cases, we prefer transforaminal approach for these kind of things. But if it is really high down migrated, no question, we need to do it. I do it with the interlaminar approach. But of course, it is not in the limit with which I showed on the slide, the indication limit in the upper level. That's because I answered for your question. I think. In the upper, I think that in the upper levels we do more transforaminal due to the foraminal size.
Yeah.
Right.
One more question from my side. If you have a pathology which is compressing both the exiting and the traversing root at the same time, like you have a paracentral disc with a foraminal extension or extraforaminal disc, what is your approach for such cases?
I do interlaminar approach in this case, and usually I have these kind of cases also, like a stenosis and the extraforaminal herniations. But in this case, I do a little bit laminectomy and try to reach the apex of the ACP. Then I resect the tip of the ACP. Once you rotate your 5-degree optics, easily you can search the exiting nerve root and reach the anterior part of the exiting nerve root. But if it is really located lateral than the pedicle, the herniation means, it's not good to do it with the interlaminar. It's better to do it with the transforaminal access. And usually in this case, I do only transforaminal to reach also the spinal canal.
Just one comment to all panelists. Has anyone ever done an interlaminar and transforaminal at the same time, at the same level in the patient?
I think Dr. Sukumar has some experience for this, not myself.
I have done in 1 or 2 cases. I don't remember, but that was quite long back. But it is not something that we regularly do for all the cases. Yeah. Maybe Dr. Wojciechowski, he has any opinion on that? Is he there?
Yes, I'm here.
Yeah. Hello, Doctor. Welcome. Yeah.
Yes, I never did both in one surgery. I every time decide what is better to go transforaminal or interlaminar, and it depends where the disc herniation is more located. Is it more located in the foramen, or is it more located in the spinal canal? So when it's more in the spinal canal, so I will start with the spinal canal and go lateral into the foramen. And when it's more in the foramen, so I will start transforaminal and then go into the spinal canal. But I don't think that's really necessary to do from both sides.
Yeah. And what kind of foraminoplasty you do? You use the reamers or you use the endoscopic drill?
I only use the drill. I don't believe in this trifans because I think that the risk for the nerve root is too high.
Yeah. Okay. Thank you. So I think this was a very good talk, and we'll move on to the next session. And I would really like to welcome Professor Christian Wojciechowski. I think he's on the Indian event for the first time, probably. I think. Is it?
Yes.
Yeah. Welcome, sir. And I would like to introduce him. He is a very, very senior and expert surgeon in endoscopy. He was a head of neurosurgery department at the Charity Hospital in Berlin for many years. And he has started his own spine center in Berlin now, and has been practicing endoscopy for more than 10 to 12 years. Welcome, Dr. Wojciechowski, and he'll be talking on endoscopic procedures for cervical spine.
Yes, thank you very much for the kind introduction. Let me see.
Yeah, can we have the talk, please?
Yeah. Okay, so I would just like to talk about the full endoscopic spine surgery on the cervical spine. So I did more than 1,000 surgeries on the lumbar spine, and we started with this lumbar spine endoscopic surgery in the late 90s. And after I have a lot of experience in the lumbar spine endoscopy, we just also started with the cervical spine. Because usually when you have cervical disc herniation, you have different kind of disc herniations. You may have some calcified, also with the OPLL, you may have lateral disc herniation, medial disc herniation, and you have also many levels. So when you have a disc herniation, so you need to decide what is the best approach. Should you go from ventral or should you go from dorsal? The problem is when you go from ventral, so usually you need to pass the disc to the posterior part where disc herniation is. So in the lumbar disc surgery, you will never do this. So every time you will go from dorsal because you have not so much problems to medialize the nerve root and to reach the disc herniation. In the cervical spine, it's more difficult because you have the spinal cord which cannot be displaced. But the problem is when you go from ventral, so you need to remove the disc at first, and then you will reach the disc herniation, remove the disc herniation, and then you will have a hole. And the question is what to do with the hole. And usually you will place cage or artificial disc, so you will have an implant. So better is when it is possible to go from dorsal. And when you go from dorsal, usually we use in the first time the microscopic technique. So we need to remove a little bit of the facet joint. So we have some risk of destabilization. Yeah, so this how we do the usually microscopic foraminotomy. So you see the interesting part is here because there we do the surgery, but we need to expose much more, even with the microscope, because we use instruments and we need to have some space for the instruments so we can work with the instruments. So we need bigger exposure than usually necessary. So to work with the forceps, to work with the suction, to have the rongeurs. So this is our surgical field, and this is the exposure what we need even to be able to work with the instruments in the depths. So the problem is that we need a bigger incision. We need to go through the muscles. So we just need to use some retractors, and then we will have some pressure on the muscles. We will have some hypoxia to the muscles, maybe also some bleedings in the muscles. So we will have postoperative neck pain and also the risk of kyphosis due to joint resection. So the better option may be to minimize the approach, and the way to minimize the approach is the endoscope. The position of the patient is the same as in the microscopic surgery. So we have this prone position, we use the Mayfield clamp, and we use C-arm lateral view. So we have here the station for the C-arm and then the endoscope. And we just minimize the visual field to these where we also do the surgery. So The procedure is the same, but much more located and smaller. So we have only a small visual field, so we can see this in these pictures. So we see some parts of the dura, we see the nerve roots, and we go through the axilla, so it's different from the lumbar disc surgery, where we go over the shoulder. So here we go through the axilla, and then we can reach the disc herniation and remove the disc herniation. So we have nice instruments to do it. So I usually start with this oval bore drill, and then we can also use diamond ball drills. So really the same instruments which we use in microscopic disc surgery of anatomy, but smaller. So we have also different rongeurs, forceps, punches. So really, really nice instruments which are very, very small, so we can minimize the approach. So at the beginning, usually we use more X-ray to see where we are, to control our instruments. With more experience, you will use less X-rays, just only to verify the level, and then we'll also only use the screen for the endoscope. So this is the picture how we do it. So we have the flavum ligament, we have the lamina here, and the facet joint would be here. So we start to drill a little bit off from the lamina. So we start with this oval. Well, then we can use the scissors to open the flavum. So it's like in the lumbar endoscopic disc surgery. Yeah, we can see we minimize the approach to this interesting area. So we don't need to expose the other structures, what we usually do in microscopic surgery. So we use the radiofrequency. Dirk explained how or why it's better to use the 4 megahertz radiofrequency, because we don't have so much risk to injure nerve structures. Then we also the nice rongeurs, so we can just resect bone also with rongeurs, so we can thin the bone with the drills, and the last layers we can just remove with the rongeurs, and these are very, very sharp 2 millimeters rongeurs, and for this cervical spine it's really enough. The difference between the cervical endoscopic spine surgery and the lumbar is that you always stay with the endoscope outside the spinal canal. Usually with this interlaminar approach in lumbar spine, you will go with the sleeve inside, and then you will just rotate the sleeve and medialize the nerve root. This we will not do in the cervical endoscopic disc surgery. You can see the dura from the spinal cord, and here you can see the nerve root. Yes, so we have always this 90-degree of from the nerve root axis, and then we can just incise the posterior ligament and resect the disc herniation. We can also decompress more the nerve root by removing a little bit more of the bone. So when we have the opinion that there's still some bone, some foramen stenosis, so and then we can check it with the hook. I like it very much because sometimes there may be some disc herniation under the nerve root, and you can mobilize disc herniation from under the nerve root with the hook, and then you can remove it. So we do it in this step. So we start with the oval drill, or then the diamond drill, and then we use these rongeurs to remove bone parts. We can also use dissectors just to orientate where we are, where's the nerve root, where's the spinal cord. We can also use the probe just to displace a little bit the fat, epidural fat, and so on. So we can just see the structures, and then we can remove disc herniation, and we can use hooks just to try to mobilize sequesters under the nerve roots or more, or also under the spinal cord. So, other example, as you can see, it's really nice for these lateral disc herniations. So we have especially at 4, 6, or 6, 7, because the interlaminar window is a little bit larger. When you go up to 2, 3, or 3, 4, 4, 5, so smaller interlaminar windows, so you need to drill a bit more, but it's also possible. So it's not a problem, but you need to know that you will need to drill a bit more. So we start with these oval drills, and we have this ball. So it was a little bit more spoon, so not so much big windows, so we need to drill a bit more. Then we use these rongeurs to remove the last layers. You can see the epidural fat. You can always see the nerve root. There are also these protected oval drills. So when you already remove the yellow ligament, and you need to drill a bit more just to protect the dura, you can use these drills. So you can see the nerve root here. You can see the dura of the spinal cord. So just here's the disc herniation. So it's very easy when you have a free sequester, so you don't need to insist along the ligament. Nerve root, dura from the spinal cord, epidural fat. And when you see it, so you may think it's finished, but then it's always need to use the hook to check if there's some sequester left. And with the hook, you can really go under the nerve root and mobilize. You can see, we can mobilize much more. So it's really very important to get all these parts out, because it's not good surgery when a patient has after surgery the same pain than before. Therefore, what you cannot see, you need to try to touch with the hook. So you need to feel it, but with the hook, not with the finger. Yes, now the nerve is nicely compressed. So also last example, same procedure. At first, we just shrink the soft tissue to have a better exposure of the bone, of the lamina and the facet joint. Then we start with the drill. So also lateral disc herniation. So we start with the drill. So now we are inside the spinal canal. So we need to drill a bit more. Sometimes the bone is too thick to get it out with the rongeurs, so we need to thin it. So then we'll use the rongeurs to remove the last layers to see the nerve root. So we will just look with this probe. We will just shrink a little bit of fat.
And I want them to open and close. And I will do an hour's worth of stuff, and I want to be paid for the whole session.
So you can see.
Yeah. I back you 100% on that, because
No, you said that before. I mean, I think I'm going to just not do the extra NHS, or not as much.
Yeah.
And
so then you can remove the.
Yeah.
You've
got to do it. You've got to do it.
Well, I think I know the NHS. I know it's stupid.
The disc herniation, which can be removed.
I've got some private ones.
Use the hook just to mobilize the last parts. Check.
I'm booked every weekend.
Get all the parts out.
No, I know.
Yeah.
So that's finished. So finally, we have good indications for the endoscopic cervical disc surgery. So these are lateral disc herniations, we have some borderline indications. So when the disc herniation is in the foramen but goes also in the spinal canal, so we can grab it in the foramen and remove it also from these medial parts. It is possible. What we cannot do is when we have such really bony foramen stenosis and also with this medial disc herniation. Okay, so thank you very much for your attention. Finished.
Yeah, thank you, Dr. Wojciechowski. I think it was one of the best lectures. Hello.
Hello.
Overlap the audio of the other hall. Suvida?
I was a registrar, he was a fellow.
Hello.
Hello.
And so the magic yeah. stopped working. He said, we'll convert it to a fusion.
Hello.
Hello.
Yeah, there's some confusion.
And they don't want to wait on it.
Hello.
Hello. Yes, I'm here.
Well, yeah, David.
Suvida, can you please mute Mr.
Alex Gibson, please? Suvida?
Yes, sir.
Yeah, please mute. There is an overlap of discussion between the two halls. So we are not able to hear anything.
1 minute, I just check.
You should just surprise me with my. They're so fucking itchy. Yesterday, I nearly killed it.
Hello. Yeah.
Hello.
Yeah. Professor Wojciechowski, thank you very much for your excellent talk. It was a very good lecture. And any questions from the audience? Sambhav, any questions from your side?
Yeah, Prof. Thank you for the amazing lecture. Just one question. In patients which we see sometimes ligamentum flavum infolding hypertrophy posteriorly, have you ever attempted any of these endoscopic procedures in the cervical spine where there is a central myelopathy from mainly ligamentum flavum hypertrophy?
I was paying 30 grand a year.
You mean if you did with a spinal canal stenosis due to hypertrophy of the flavum?
Yeah, but in the cervical spine, sometimes we see a 1 level or a 2 level ligamentum flavum infolding.
Yes, you can do it like in a lumbar spine. You can just decompress also in the cervical spine. Also, when you have a little bit bony stenosis on the cervical spine from dorsal, so you can do all these procedures. You do it in the lumbar spine, also in the cervical spine.
But would there be any change in the way you dock your scope or technique? For an example, in the lumbar spine, if we want to go over the top or we want to drill a little bit of the base of the spinous process, sometimes we take a more lateral approach to the midline. So would there be any difference with regards to the technique per se if you are trying to attempt that in the cervical spine?
I think my experience is in the cervical spine, it's even a little bit easier than a lumbar spine because the spinal process is not so thick. Yes, and usually you have more distance between the spinal processes. So just go to between the spinal process in the cervical spine. In my opinion, it's easier than the lumbar spine.
Right. And second thing, Prof, do you attempt also anterior cervical endoscopies in cases of central discs where you're just going in through the disc and removing the piece, or is there been any experience in that direction?
Yes, we did rare cases where we just did anterior cervical endoscopy because there's always the problems that you need to go through the disc and reach the posterior part of where disc herniation is. So, I mean, in some selected cases, it's okay. So we do it in some selected cases, but usually I think the standard is just the ventral discectomy and then fusion.
Fusion. All right. Thank you, Prof. Thank you so much.
Yeah. Arun, any questions?
Thank you, Professor Wojciechowski, for the excellent talk on cervical spine. Any special tips for controlling the bleeding? Because in the cervical foraminotomies, many a times you can have slightly higher rate of bleeding than the lumbar spine. So what are the ways you handle it positioning wise, intraoperatively?
With the endoscopic cervical spine surgery, I never had problems with bleeding. It's in the microscopic. When I started with neurosurgery in the 80s, so we just did a lot of microscopic foraminotomies, and my chief put the patient in a sitting position, because in the sitting position there was less bleeding due to this venous drainage. Because in microscopic technique, due to more resection of the bone and also due to these bleedings from the muscles, we have much more problems. In the endoscopy, never. Because you see the vessels and you just coagulate the vessels first. And I think with this probe, you have better opportunities to stop bleeding than with the forceps. But sometimes the vessel is attached to the forceps and you cannot get it out. So in my opinion, with the endoscopy, you have less problems with bleedings than with the microscope.
Yeah. Right. So one question from my side, Professor. Have you experienced any congenital nerve root anomalies in the cervical spine, like double roots or maybe a extra root or maybe a triangular kind of root any times? And how do you manage such cases in your practice?
Yes, we see sometimes double roots, so you need to really check what is nerve root and what is disc herniation, because sometimes even this problem with double nerve roots is maybe not so easy. And then, yes, it's usually with the one nerve root, you just need to mobilize the nerve root and just to see how you can reach the disc herniations. Sometimes you decompress more, so to remove more bone, to see all the structures, and yeah. So the main thing is to have a good anatomy. Yes, so just to see there are really double nerve root and something like that, so you can be sure that you will not destroy your nerve root because you think it's a disc herniation. Yeah.
And any incidents of dural tears in your practice, and what is your protocol to manage such dural tears?
What do you mean?
Any incidents of dural tears? Incidental durotomies?
Dural tears. Yeah. Yes, in a cervical spine usually not, but in a lumbar spine, especially in decompression surgery, not so much in a lumbar disc herniation, but decompression surgery, when you have really severe spinal canal stenosis, so you can get a tear to dura. Then usually we just try to put some sponge inside the dura and then fibrin glue. Yes, we have this long needles, so you can just go through the endoscope with the fibrin glue, and then we just put fibrin glue. So it's only for tears which are very small. When you get a really big tears, so you need to change to the microscope. Yeah.
Yes. Yeah. Thank you so much, Professor. And now we'll move on to the next session. I think it's going to be an interactive case session, and the cases will be presented by Dr. Arun Bhanot. Arun, can you please take over?
Yeah. So I'm sharing my screen, Suvida. Is my screen visible?
Yeah.
Yes.
Okay, so to set the ball rolling, I'll start with the migrated herniation. So this is a case of a 65-year-old lady who presented with severe acute onset right leg radicular pain for about 3 weeks that had worsened for the past 1 week. So she was a known case of chronic kidney disease with deranged renal parameters to some extent, multiple comorbidities like diabetes, hypertension, and some heart condition. Her ejection fraction was 30%. The radicular pain was so intense that she wasn't even able to sit, and she was practically on the stretcher, confined to bed. And neurologically, she had a grade 3 quadriceps and grade 2 tibialis anterior on that side. She did have some chronic low-grade back pain for preceding several years. This is her X-rays. And this is her MRI. So I'll just run through the MRI and then we'll take opinion from the house. So we can see there is a significantly up-migrated L3-4 herniation on the right side. It doesn't look like a foraminal type. It's a up-migrated intracanalular herniation at L3-4. So this is the anatomy of the herniation displacing the thecal sac. So what would be the opinion of the panelists here to how to manage about this case? So these are the challenges we have here. She has a CKD, which we do not have much choice of giving a prolonged conservative treatment in the form of analgesics. The comorbidities also warrant that she should at least become mobile at the earliest possible. But at the same time, they pose significant challenge in terms of surgical treatments if we have to choose one. So, Pramod.
Yeah. Does she have any exiting root symptoms?
No.
Yeah. Okay. So purely traversing nerve root symptoms, L4 nerve root symptoms, isn't it? Yeah.
No. It's a up-migrated one. So she has, it's a L3, she had some L3 root symptoms as well because quadriceps was weak.
So she had both the nerve root symptoms, the L3 and L4 also. Okay. Yeah, it is possible for us to do a transforaminal approach in such cases because up-migrated discs are relatively easy to treat by a transforaminal approach as compared to down-migrated disc herniations because the pedicle doesn't come in between. So we can definitely reach inside the canal also, and it is possible for us to decompress both the traversing and the exiting route at the same time by transforaminal approach.
Sambhav, what is it? Yeah. Do you anticipate any problems in transforaminal approach in this case?
I don't think so. It would be a problem. The only thing is my decision for interlaminar versus transforaminal would mainly depend on what the anesthetist also is comfortable with. If GA is contraindicated in this case, considering the comorbidities or the ejection fraction, then definitely my first line of management would be a transforaminal approach. But if the anesthetist, is the patient obese or, there are some contraindications with regards to prone procedure under LA also. And if GA is preferred over a LA, then definitely I would do this interlaminar. So my decision would definitely be based on what is safer for the patient with regards to anesthesia point of view. But this could be tackled from both the sides, transforaminal as well as interlaminar.
Professor Wojciechowski, is he with us?
Yeah, I think it's also both is possible. You can go from transforaminal and also from interlaminar. In my opinion, maybe from interlaminar it's a little bit easier because you are really don't need to go through the foramen, so it depends on the size of the foramen. But we have a big foramen, so in this upper lumbar spine usually we have big foramen, so it's also not so difficult to go through the foramen. But it's also possible to go interlaminar. So both is possible. So I think it depends on your experience. When you are good experience with the transforaminal, so the advantage of the transforaminal approach is that you need less bone resection. So then you can do a transforaminal. Some people are not so experienced with the transforaminal, so they prefer the interlaminar. So you can also do it interlaminar.
Any other panelists would like to throw any different point of view from the one which we have already discussed? Dr. Ali, anything more than what we have discussed?
Dr. Ali is not there.
Okay. So if there's none, I'll just share what I thought, what was the thought behind choosing what we treat. See, she's multiple comorbid conditions. And as Sambhav rightly pointed out, the anesthetists were definitely edgy about giving general anesthesia to such a patient. And but my concern with transforaminal approach was that many times I find that these herniations are multifragmented. And in transforaminal approach, sometimes you can miss multifragmented herniation because you think sometimes you have removed one or two fragments and that becomes the end of your procedure. Anyhow, because of the comorbid conditions, because of it's a up-migrated herniation, and we had a reasonable experience of treating such cases with the transforaminal. We chose the transforaminal approach. and I'll just show you. But we agree that no one has chosen nerve root block, and it's only a surgery, which is again dependent on whether you're going to do a microscopic or endoscopic, and the panel agrees that it is an endoscopically treated surgery. Anesthesia we already discussed. So we chose the transforaminal approach under local anesthesia. In this case, the only thing is that our trajectory has to be slightly caudal to cranial, because we are going to advance our cannula superiorly through the foramen. And as shown here, we kept the cannula just in the foramen. We did not dock in the disc space. And once we keep the cannula, and you can see on the picture on the right, there is a significant angulation permitted from the initial horizontal trajectory to distal to proximal trajectory. This is a small video that shows how it is done. So as you see, we are just inside the foramen so that we are able to see the posterior longitudinal ligament. This is the exiting nerve root. And on the top, you can see the ligamentum flavum under the facet, and you can see the herniation. Now you see one fragment that is coming out. And as was my apprehension, it is multi-fragmented. So we have to ensure that we do not miss out on any fragment, because it's a neurological deficit and she is not mobile because of the deficit. So we have to ensure that we don't miss out on any fragment. And once we do multi-fragmented, and then you see the exiting root is already decompressed, and you can see the traversing nerve root at the end of the procedure. So that is how we were able to get a reasonably good outcome. And this is the post-operative MRI. Any comment?
Very well done, Arun. I think there is no doubt about what you have done. It's well done.
Absolutely. This was a perfect indication for this. But as you rightly said, one worry is always that have we left any fragments behind? So obviously, if this lady was a younger patient with no comorbidities, I would probably venture into interlaminar, where I see the whole nerve right from the shoulder to the axilla. But what you've done is the perfect indication, and it's very well executed.
So my point is that even if we are anticipating multi-fragmented herniation, one should aim to look for the reasonable length of the nerve roots, both the exiting and the traversing, so that there's no doubt. And that is what is the ultimate aim of the procedure. So shall I move to the second case?
Sure.
Yeah, please. Yeah.
Now, this one is the opposite of what we just saw. This is a 70-year-old male with a left leg radicular pain and presented with weakness and inability to walk. His left iliopsoas and quadriceps were grade 3. He had a sensory hyposthesia below L2 dermatome on the left side and hyporeflexia, but he was voiding by self. This is his MRI that shows a large L12 disc herniation here. You can see there is a large down migrated L12 herniation, which is going right up to the lower pedicle of the L2 vertebra. And these are the axial sections showing a disc which is going right up to the lower border of the L2 pedicle here. Now, what do we think about it?
So in my opinion, probably L12, I would, with a down migrated disc, I would prefer the interlaminar approach rather than the transforaminal.
Right. That's correct. And Ajay is here? Ajay Krishnan?
Ajay probably is not there.
And
Yes, sir.
I would agree. I would also do the interlaminar approach. I think L1, 2, it's difficult transforaminal because you need to respect the kidneys, so you have the posterolateral approach. So you would need to resect some parts of the pedicle just to go down when it is a multi-part sequestered disc herniation. So I think the interlaminar approach is fast and easy, and it's the best decision for this patient.
Pramod, anything from your side?
Yeah, I have a slightly different opinion. I think both the approaches are possible, but the amount of bone resection which you do at L1-2 level to reach the lateral border of the dura or the lateral border of the nerve root is quite significant. And secondly, I'm worried about the possibility of the neural retraction by the interlaminar approach. So if you really want to see the fragment completely, you do have to retract it, and that may add on to the insult which is already there. She has the grade 3 power. One of the advantages of transforaminal approach in such cases is the foramen is very big. Secondly, the mediolateral thickness of the pedicle is very narrow. They are narrow and vertically elongated pedicles.
Right.
So it's easy to get for us to get under the pedicle. Okay. The facet is not large. So because the facet is not large, if you did not take a lateral approach, you can just go in through the posterolateral approach. And I think it's possible to do it with a transforaminal approach by a surgeon who has some experience, definitely.
Okay.
I completely agree. There's only one thing that if you see, if this disc was more of a very central disc,
right,
I would definitely even prefer probably a transforaminal. But it was like a paracentral disc. It's more towards the left side, and that's what I think probably makes it easier then to try and grab that fragment out from the interlaminar approach.
No, the problem here is that it is a significantly down migrated herniation, and the transforaminal approach will definitely have a problem of removing the down migrated fragment, especially because again it is a 70 years old male with the possibility of multi-fragmented herniation. So you may be able to get one or two fragments, but you may still miss something which is very close to the nerve root in the pedicular zone.
Arun, we are running out of time.
I'll just run through. I thought what Pramod said. So actually, I agreed that we will need to cut a lot of bone in the interlaminar approach. So I used the transforaminal approach, and the angulation was downwards. So of course, we had to drill a little bit of the pedicle. This is a small 1-minute video I'll run through. So this is the orientation. 12 o'clock is dorsal and 3 o'clock is caudal. So this is the facet and the undersurface of the facet which we are drilling. Along with that, we will be drilling the upper surface of the pedicle. So we feel the medial border of the pedicle here, and we drill the tip control burr as well with the matchstick burr. Both we combine. And now we're drilling the medial border of the facet pedicle junction. And now we can see the nerve root, and then there is a fragment right across, so which we mobilize with this hook, and then we remove the fragment. And because now we have done a little bit of foraminal widening, we feel confident that we can remove multiple fragments. So like we removed only one, then we remove another one here, and then we look distally towards the lower part of the pedicle here, and then we can remove that as well. So at the end, we get this nicely decompressed nerve root right from disc to the pedicle ending. And this is his post-operative MRI showing this much is the amount of pedicle which we had to drill, superior border of the pedicle.
Yeah. Excellent. I think there are lots of more cases to be discussed, but very little time. And Satyan is already signaling me a lot of times. So it was an excellent session. Thank you for all the faculties, especially Dr. Ali, Dr. Professor Wojciechowski. You spared your time and you joined this session and enlightened us with a lot of new things. Thank you, Dr. Arun, Dr. Sambhav, and Dr. Satyan to give us this opportunity to conduct this session. Thank you so much.
Thank you all. Thank you so much.
Thank you, everybody. Thank you to all our foreign faculty and our esteemed local faculty, Dr. Lokhande and Dr. Arun Bhanot, who have really been very helpful and supportive for helping us in this conference right from the beginning. Sir, we'll be ending this session after a very good day. We will stop this hall and we will move on to Hall A. I would like to invite you all to the Hall A, as we will be having some messages from some Olympic medalists for this conference, and followed by entertaining night by a stand-up comic as well. And tomorrow morning we have a very a good session in association with Spine Surgeons of Nepal, and then the presidential session with the Cervical Spine Research Society. So thank you, everybody, and good night.
Thank you. Thank you so much.
Recording stopped.